It starts at 2:01 time.
Yeah. Hello, Prashant?
Yes, sir. We are
Can you
live
start?
now.
Can you
Yes,
start?
sir. Yes, sir.
Just give me 2 minutes time. I'll just speak for 2 minutes and then we'll hand over to the chairpersons.
We are live now.
Good afternoon, Shanmugam. Good afternoon, Shanmugam.
Good afternoon, sir.
Good afternoon.
Good afternoon, Shanmugam. Yes, sir. Good afternoon, sir.
Listen. Or speak. Okay, first speaker only.
Yeah.
Sir, we are live now.
Okay, shall I start?
Yes, sir.
Okay, thank you. Namaste. Good afternoon to all our faculty members who have readily accepted to join this meeting, and also to all the delegates who have joined and who have registered, and also friends from the RX events who have made this possible in a very short span of time. If you look into the scientific program, the scientific committee, including Professor Venkatraman, Dr. Anand Moses, Professor Anand Moses, and Dr. Krishna Seshadri have put in an excellent program so that it's a very, very practical program. You can see that all categories of people can look into that. And you know, the who is who in the faculty or the national level are also included with enthusiastically. This is the 4th version of 3D conference. Usually it is held in the April last weekend, last 3 meetings. This is because of the extraordinary situation that we are facing in the world. We are making it into a virtual platform. So last year it has been a very successful meet that we had. We had about 1,200 delegates who attended the meeting, and then we enjoyed the sessions as well. Thanks to everybody who has been involved into that, in the organizing committee, scientific committee, and the delegates and faculty, everybody. This year also the enthusiasm has been extremely good. We had 4,000 delegates plus who have registered for this particular meeting. So that I'm very sure with all your involvement and the faculty members are going to ready to share their experiences, knowledge, everybody to all of you. So be proactive. Please ask questions. You can put it in chat box. And then our faculty members who are very knowledgeable are ready to answer your queries as well. Thank you and all the best. And God bless you all. Thank you. Now, let me start the sessions. What I would like to do is that we would like to introduce the chairpersons of the day. Prashant, can you put the chairpersons? Yeah. Now we have 3 eminent people as chairpersons who are very good friends of mine. Dr. A. Shanmugam, a young and dynamic diabetologist from Chennai. He is also the professor of diabetology in Stanley Medical College and Hospital. And then we have Dr. M. Shanmugavelu. He needs no introduction to these people. He's from Trichy. Senior most, he's senior to me as well. He's also an excellent teacher. And he'll also share his knowledge to all of us. He's from Trichy and senior most diabetologist from Trichy in Tamil Nadu. And we got my very good friend again, Dr. L. Srinivasamurthy from Bangalore. And he's also a senior diabetologist and he's going to join us as chairpersons. Over to you, chairperson, sir.
So good afternoon, everyone. I think Dr. Shanmugavelu will speak, sir.
You want me to, because Dr. Shanmugam, he wants to leave much early so that.
Okay. Please.
Dr. Shanmugam.
Yes, sir. Good afternoon, one and all. At the outset, I thank Professor Dr. Vijay Kumar sir for the opportunity. And every year, as he said, we are having a real virtual, real academic meet in almost for 2 days, and eminent speakers from all over the Tamil Nadu and all over the India speak over his conference. A lot of information has been shared in every year Diabetes Dialogue Discussion Conference. And this year, unfortunately, due to COVID pandemic, though we cannot able to have a real conference, but we cannot able to lose our science and the knowledge sharing. That is why he arranged such a way that we should have a very good virtual meet this year. And I thank for Vijay Kumar sir for making this a virtual meet this year, and pulling all the eminent speakers once again for sharing their diabetes knowledges. And to start with, we have an eminent speaker, Dr. Usha Ayagri, and a senior endocrinologist from Chennai. And Dr. Usha Ayagri is trained in diabetes and endocrinology at the Oxford University Hospital, Oxford, UK, where we are waiting for the best COVID vaccine to have in all over the world. And she is currently working as a consultant diabetes and endocrinologist at Metabolic Medicine in Chennai. And she worked as a full-time consultant in UK in diabetes, endocrinology, general medicine until August 2004. She was a clinical lead in young adult diabetes services at Buckinghamshire NHS Trust UK, medical lead and bariatric clinic at Royal Berkshire NHS Foundation UK. Madam, you can start your session. Madam. Thank you. Madam, unmute yourself.
You have to unmute yourself.
Yep, sorry about that. Thank you very much for the very kind introduction, and thank you, Dr. Vijay Kumar, as always, for inviting me. It is 2:08. Could I please request a time check at 12 minutes from the chairs? Thank you. So over the next 15 minutes, I'm going to be talking about relevance of AGIs in the Indian scenario. I have no conflicts of interest. The first few slides, I'm going to go rather briskly. We know that there is an excursion of blood glucose levels postprandially. We know that you will see in this slide that in the diabetics in blue, there is a blunting of the plasma insulin response and a higher peak of the plasma glucose response with food in type 2 diabetes compared to people without diabetes. We also know that whereas glucose disposal and endogenous glucose production are under the control of insulin and glucagon, the absorption of glucose and the appearance of the ingested glucose in the blood is completely free of any hormonal mechanisms. We know that early changes in postprandial glycemia predate type 2 diabetes because there is a loss of first phase insulin secretion. There is a decrease in peripheral insulin sensitivity, and we also know that the hepatic glucose output is dysfunctional. There is inadequate suppression of hepatic glucose output, and therefore this increase in postprandial glucose levels start coming in even at the phase of prediabetes. On top of all of this, we are an extremely carb-rich nation where approximately most of our diet, 64 to 67% of our diet, comes from carbohydrates across all areas of the country, and we know this from the starch study. Moreover, compared to a Western diet, you will see that both in rural and urban India, 70 to 75% of our calorie requirement comes from carbohydrates. And why is this important? Because postprandially, our glucose excursions in the yellow arrows are much higher in Indian population compared to the Asian, West Asian, and African as well as Caucasian population. If you look at all the other populations, postprandially we have a higher excursion. Not only are we cursed with higher postprandial excursions, for the very same food, if you eat a biscuit, if you eat cereal with milk, compared to a Caucasian population, Asian Indians, for the same meal, for the same carb intake, your postprandial excursions are higher. So postprandial excursions start early. Indians are carb eaters, and for the same food, our excursions go higher. This is also important because we know that in Asians, the majority of our HbA1c across all levels. Across all levels. This is the Wang data. We are all familiar with the Monnier data that tells us that as your HbA1c comes closer to 7, there is a higher component of postprandial glucose that contributes to your A1C. But the Wang data shows us that in Asians, across all levels of HbA1c, across all quintiles of A1C, postprandial glucose excursions in the dark green are a significant contributor to HbA1c. Now, why is this important? We are starch eaters, we have higher A1Cs with higher PPGs. This is important because we know that survival depends on postprandial glucose even before the onset of diabetes. In this particular study, this is followed up A, B, C, D, A with a postprandial 2-hour glucose on a GTT less than 140, but with a higher fasting glucose 140 to 200 and more than 140 to 200 with relevant 1-hour glucoses, which I've taken out because they're not relevant to us. You will see that when your postprandial 2-hour glucose is less than 140, there is a mortality risk of 1.28, and when it goes to 140 to 200, there is a mortality risk of 1.76. So the survival curves go up even before, and remember, less than 200 is still impaired glucose tolerance. It's not even diabetes. Even at the stage of impaired glucose tolerance, if you have a high plasma glucose at 2 hours, you have a higher mortality. Next, we know from the DECODE study that for any level of fasting plasma glucose, less than 110 to 125, more than 126, as your postprandial glucose goes up 140 to 199 and more than 200, your mortality, and this is relative risk of death, increases with postprandial glucose irrespective of the starting level of fasting glucose. So your 2-hour plasma glucose is a marker of death, as you can see in both these studies. So 2-hour postprandial glucose contributes to macrovascular disease, carotid medial thickness being increased, decreased myocardial blood flow, increased early diastolic dysfunction, and we know that these contribute to heart failure and type 2 diabetes. There is an increase in oxidative stress, increased inflammatory markers, retinopathy, and pancreatic cancer. So 2-hour postprandial load is important, and we have to reduce it. And as this study shows you, more patients achieve an A1C under 7 by achieving your postprandial glucose. So even if you achieve your fasting glucose, if you don't get your postprandial under control, fewer people achieve a A1C under 7. But get to postprandial control and more people achieve A1C control. So we cannot get good control without controlling postprandial glucose. We are intrinsically high carb eaters, and for the amount of carbohydrate we eat, we have higher postprandial excursions. So how can we address all of these? Now, remember I said that glucose intake and absorption is independent of insulin and glucagon when I showed you the 3 things that contribute to postprandial glucose. And in terms of glucose absorption, this group, the alpha glucosidase inhibitors, have a unique mode of action in that they stop the absorption of your various forms of starch. So they act on glucoamylase, sucrase, maltase, and isomaltase. And essentially what they do is it inhibits the absorption of these oligosaccharides and polysaccharides. What does that do in terms of your blood glucose? Without acarbose, you can see that there is an immediate increase in carbohydrate absorption at your duodenum and jejunum. But when you add acarbose to the mix, because of the inhibition of this alpha glucosidase, there is a much flatter profile in terms of carbohydrate absorption. So your carbohydrate absorption is decreased with acarbose. This then results in a mean change of HbA1c by about 0.8 in people on acarbose. So this is a systematic review and meta-analysis of multiple placebo-controlled randomized trials. And you will see that on 50 milligrams TID at the maximum, there is a reduction of 0.8 in HbA1c and approximately a 40 milligrams per deciliter reduction in postprandial blood glucose levels. Now, this is important because HbA1c reduction is much more pronounced in the Eastern diet rather than in the Western diet, because as Indians, we have a higher carb load. So it makes sense. Remember where I showed you that in the Western diet, only about 30-40% of their calories come from carbs. But in our diet, it is over 70%. So it makes sense that in our diet, by taking an AGI, we inhibit the absorption of those polysaccharides more, and therefore we get a better reduction in A1C with our AGI use. And especially in India, around 2,000 of these patients in this study were from India. You can see that this is real world evidence. Mean fasting glucose and mean postprandial glucose decreases significantly, 70 and 75 nearly, and nearly 40 after 12 weeks of use of AGIs. So more than 80% of patients got the full dose of 150 milligrams per day, and they had a significant improvement in their fasting and postprandial glucose levels. If you look at metformin as initial therapy compared to acarbose, so both acarbose and metformin were used as initial therapy in China in the March study, and you will see that the A1C reduction is about equivalent when you use these as initial therapy in type 2 diabetes, with a postprandial reduction which is numerically higher in the acarbose. As you would expect, the fasting was better with the metformin, but you will see the postprandial, and therefore the A1C was similar. And this is one thing that we don't appreciate, because we stop absorption of these carbohydrates. You see a weight loss in these patients that you put on an AGI. With acarbose, you see a reduction in weight of approximately 2.5 kilos. This is head-to-head acarbose with voglibose comparison of efficacy and safety. And you will see that numerically, there is a higher improvement of HbA1c and especially the 2-hour post-meal glucose with acarbose compared to voglibose, with a body weight change of approximately again the same, just under 1.5 kilos. So you get a higher reduction with fasting, postprandial, and A1C with acarbose compared to voglibose. Now, if I showed you originally the head-to-head acarbose versus metformin in drug-naive patients. Now, what happens if you add acarbose to metformin? You will see a further improvement in A1C down to 1.76, and you will see a further, this is where it's coming from, you see a good improvement in your postprandial blood glucose. So the postprandial blood glucose improves even further when you put together acarbose with metformin. Now, acarbose, DPP4 inhibitors, and HbA1c, and SGLT2 inhibitors all have approximately the same glucose lowering effects, especially in an Asian population when you start with an A1C that is more or less comparable. So we know that DPP4 inhibitors give you approximately a 0.65, 0.7. We know that real world SGLT2 again gives you about a 0.8, and acarbose would also seem to give you an equivalent A1C reduction. So this concept that we have of these older drugs perhaps being less effective, less safe, is not quite validated. And if you look at the entire group of drugs, of course, the trials are few in number when they looked at the comparison, but the mean change in A1C you will see is approximately comparable between all the drugs, between about 0.65 and 0.8, which is what we expect from all the trials that we know. So these older drugs, which especially in an Asian population that has a high carbohydrate intake, can reduce your postprandial glucose, and this gives you a better A1C. This is borne out by this 5-year observational study with the acarbose, where you had a reduction and a durability. Please look at the durability. You had a reduction early on, but there was a durability out to 5 years in terms of reduction of your closed squares, postprandial glucose, open squares, fasting, and HbA1c. So there is no loss of durability because this is a completely independent effect. It is neither dependent on insulin nor glucagon. So you will see that this treatment durability is not dependent on any endogenous mechanisms. And the other thing that it does is, because it reduces your blood glucose levels, it blunts your insulin response. And this comes into use even more in pre-diabetes, where you will see that it is effective. So this insulin sparing effect is quite useful in early diabetes, especially in the Asian population, where you have a strong first phase insulin deficiency. Now, this translates into add-on clinical benefits because you have less hypoglycemia and you have a trend in favor of weight loss with these agents. So because they're insulin sparing, obviously the risk of hypoglycemia is extremely low and you lose some weight. Other thing we don't realize is that acarbose improves GLP-1 secretion in the L cells of the intestine. And what this translates to, we know that GLP-1 is an insulin secretagogue. And what this means is that you get an improvement in your fasting and your 2-hour plasma glucose levels. And this is a small study, 24 weeks, 24 patients. So in theory, there is an improvement in your GLP-1 levels as well. And
I'm sorry to interrupt.
Yeah.
Last 2 minutes, ma'am.
Last 2 minutes, thank you.
Yes.
Therefore, when you add it on to DPP-4 inhibitors, it gives you an added benefit in terms of the green line, your plasma glucose levels and active GLP-1 levels. Now, as I said, in pre-diabetes, there is an increased percentage of reversal to normal glucose tolerance by 35%. There is a reduction in progression to type 2 diabetes. I'm going to go past the next couple of slides, except to say that there is a reduction in ischemic stroke, hypoglycemia, and progression to atherosclerotic events. And 24-hour CGMS profiles show you that there is less postprandial variability, and therefore more time in range with acarbose and with AGIs. So there is a higher time in range and less glycemic variability with these agents. You can add these on to insulin and it will help further control your mean glycemic excursions and improve your postprandial glucose levels. It also has a favorable effect on your gut microbiome. So guidelines, all the guidelines, IDF, ACE, RSSDA, ESI, all of them recommend acarbose as second line in addition to metformin and lifestyle changes. And it can be taken with meal, just before meal, or at the maximum up to 15 minutes after the start of the meal. Please note, start, not end, because it needs to be in the gut at the same time as the carbohydrates. So Indian patients have intrinsically a high carb intake. We know that with our high carb intake, we have a disproportionately high postprandial sugar levels. AGIs effectively control your postprandial excursions independent of beta cell function. They have additional benefits with the cardiovascular protection. They're time tested, the side effects are extremely tolerable, and they can be combined with any of the agents that you're currently using for your patients. Thank you very much.
Thank you very much, madam, for your excellent, elegant, and electrifying talk on the role of alpha-glucosidase inhibitors in Indian scenario. You have highlighted nicely the realities of patients in India with the type 2 diabetes with reference to carbohydrate content, postprandial hyperglycemia, its correlation with reference to cardiovascular events, and also the need for simplicity as well as the convenient type of therapy. And you have highlighted nicely about alpha-glucosidase inhibitors in general and acarbose in particular with reference to reduction in fasting, postprandial plasma glucose, the durability of glycemic control, and also with reference to other pleiotropic effects. Thank you, madam. We'll take up the question at the end. Now I request Dr. Srinivasamurthy to take over this proceeding.
Thank you, sir. And it's my privilege and honor to introduce Dr. Vijay Vishwanathan, sir. And I think this August gathering does not require any introduction.
So I'll start. Yes, Srinivasamurthy.
Fine, sir. I think only one word, sir. DFood International, which is an international non-profit organization. Sir is the president-elect. I think it's a proud moment for all of us because it represents experts from all over the world. And we are very proud to have that you reached that stage, sir. Thank you very much. And please go ahead, sir.
Thank you, Srinivasamurthy. In the next 10 minutes or maybe 12 minutes, I'll try to finish off a very important but a very difficult topic which Dr. G. Vijay Kumar, I have great respects for him because he is a very senior diabetologist. And I'd like to tell all the chairs, Dr. A. Shanmugam, Shanmugavelu, and Srinivasamurthy, I'll finish in 10 to 12 minutes. Laser pointer, yeah. So numb feet is very difficult to talk, but let me finish in 10 minutes. First of all, when you have numbness in the feet, you must remember that there should be a sufficient history of a chronic hypoglycemic exposure. And there should be diabetes. And usually, when you think of a numb feet and diabetes, only if it is symmetrical and it is bilateral. The person says he's got numbness on one side. It could be a lumbosacral radiculopathy or something like that. So a characteristic pattern of numbness which involves both the feet and it's symmetrical should make you think of diabetic polyneuropathy or peripheral neuropathy. And usually, but not always the case, it might be associated with retinopathy and nephropathy. Now, the important point, many people ask me, is it neuropathy a damage of the microvasculature or the macrovasculature? It is definitely a microvascular complication. And it's the endoneurial hypoxia which is responsible. And this lipid peroxidation I'll talk to you in a minute is very, very important, is an important factor. This was a Nature article we wrote last year. I had the good fortune of being asked to join a group of American and UK neurologists in writing this primer in Nature Review. And you can see it's a beautiful article. If you want, you can write to me. It's a beautiful monograph on neuropathy, which we wrote, the neurologists from London and United States. You can see that the primary defect in diabetes is the axonal degeneration, which happens. Demyelination also happens, but the main pathology or the main pathophysiology is this one, lipid peroxidation. All the other things are common for retinopathy and nephropathy, hypoglycemia and all that. But lipid oxidation and these factors, what is shown in blue, and FFA levels getting increased is quite peculiar for diabetic neuropathy. So that's why you find that in the early stages, so you see that this is a study which we published in 2004, 16 years ago, where we found that even during the stage of pre-diabetes, about 19% have neuropathy. They have numbness of the feet, more than burning and so on. They have numbness in the feet. And it is a pre-diabetic phenomenon. Because in pre-diabetes, now along with Dr. Eva Feldman from the United States, we're trying to find out the association between neuropathy and each component of metabolic syndrome, of HDL, LDL, triglyceride, and so on. Therefore, it's very early to start with. And this was a study which we published 20 years ago. You can see that as the prevalence of neuropathy and age advances, the prevalence of numbness and the neuropathy in general increases several times, several fold higher. Now, the numb feet, I'm going to talk about the treatment in a couple of minutes, but the most important danger of a numb feet is the formation of a callus and injury and repetitive trauma. So this is the biggest danger. The patients can put away with neuropathy, with numbness and all that. But what we have to tell them is the danger that lurks behind that numb feet. And that is the formation of a callus, the collapse of the midfoot, and you get ultimately a foot ulcer. So this is the important point which we need to emphasize. This was a study which we published along with colleagues from Africa and from Germany in diabetic medicine. And you can see that among patients with diabetic foot ulcer, the neuropathy was present, numb feet was present in about 70%, or I'm sorry, about 80%, more than 80% of people from our Indian subcontinent. So neuropathy is an important risk factor. And this was a study which we published across India from 31 diabetologists. And again, we found that neuropathy was the commonest cause of amputation. Numb feet was the important factor for the development of an amputation in India. Peripheral arterial disease is responsible in about 35%, but neuropathy was responsible for about 82% of the numb feet, that is for the onset of an amputation of foot ulcer. And once you have a numb feet, because of this risk of amputation, the cost is tremendous. You see the cost to the diabetic patient who has numb feet and who has amputations and so on. is about 4 times higher if you have these amputations compared to people who do not have any complication. Now, can we do something about amputations? So in the last 3-4 minutes, I'm going to spend on how to prevent the numb feet from getting into danger. So first of all, we showed that simple foot care education. This was a paper published in Diabetes Care in 2005. We showed that you can prevent an ulceration by just 1 minute. You can prevent an amputation from happening in India, the Indian setting, by foot care education and teaching people about the numb feet. Now, this was during the lockdown in the month of April. Somebody came to us with maggots. You can see it's completely neuropathic numb feet. And I hope all of you have had lunch already. So it's full of maggots. And in the month of April, we could not do much, but we managed to somehow debride it and put a skin graft in the month of May. So this was during the COVID lockdown. And this is the consequence of neuropathy. And the numb feet, you can see the person has got a well-established callus and wasting of the intrinsic muscles of the foot. So these are all the consequences of numbness of the feet. Now, the numbness can be treated with drugs. Yes, the same drugs. There are no specific drugs for numbness, but the drugs which you give for the pain, which works on the C fiber, you must understand that numbness is because of small fiber neuropathy. Pain is also due to small fiber neuropathy. Therefore, if you target those agents which act on the A delta fiber and C fiber, you can get relief. So pregabalin is one option. Those drugs which act on the sodium channels is another option. So these are all the options which you have. You don't have a specific drug for numbness. There are recommendations from the American College of Endocrinology and American Association of Neurology. All of them seem to prefer pregabalin for neuropathic numbness, tingling, paresthesias, or pain, whatever it might be, whatever be the symptoms of neuropathy, the positive or the negative symptoms, pregabalin seems to be the choice. We did this study for a pharma company where we tested about 70 patients with topical gabapentin. And we found that numbness, when they complained of numbness and we applied topical gabapentin, they got relief because this topical formulation had gabapentin, ketoprofen, and so on. And it works on the A delta and the C fibers. You can see this picture. It works on the C fibers and A delta fibers, and also on the local substance P. And when you apply it to the skin, don't worry, it doesn't get absorbed into the system, into the systemic circulation. And we found a lot of improvement in the relief of symptoms in patients. They had a 47% reduction in all the neuropathic symptoms like numbness and pain and tingling and everything. All these symptoms reduce, including numbness. So therefore, the pregabalin seems to be a good choice for numbness of feet. Local gabapentin seems to work in numbness of the feet, and so on. And in the last 2 minutes, let me talk to you about the new International Working Group on Diabetic Foot Guidelines from Netherlands, which talks about numb feet. I was fortunate enough to be a part of this elite group, which works on the International Working Group on Diabetic Foot. And the 5 key elements of prevention in the numb feet is, first of all, you have to identify the numbness. You have to regularly inspect and examine the at-risk feet. You have to tell the patient your feet is numb. You have lost God's gift to mankind, pain. You have lost it. You have to educate the patient, family, and healthcare providers. Very important to provide the appropriate footwear and also treat the risk factors for ulceration. Now, the International Working Group on Diabetic Foot gives you several risk categories, 0, 1, 2, 3. And if you have loss of protective sensation, that is numbness, you are at very, very high risk. And you have to see the patient with numb feet very frequently if he's got either peripheral artery disease or loss of protective sensation. And the instructions are, don't walk barefoot if you have numb feet. Wear socks always, even when you're in bed. You wear socks, even without shoes, you wear shoes, socks, I mean. And you have to examine the feet every day, because a numb feet can get hurt without you knowing about it. And routine wearing of appropriate footwear is very important in a numb feet to reduce the plantar pressure, because as I showed you in one picture, the maggot-filled foot, the callus is a typical feature of a numb feet due to high plantar pressure. And way back in 1991, we started manufacturing footwear materials apart from the MCP, and we were quite successful in developing a lot of models before the numb feet. So numb feet needs a footwear which has got a counter and a soft insole and an upper and so on. Therefore, I think what I've tried to show you in the last 10 minutes is how to take care of numb feet. So there is no specific guidelines for numb feet, but the International Working Group has come up with guidelines for taking care of loss of protective sensation, LOPS. And that's what we need to do when we talk about numbness. You must tell your patients there is no magic cure for neuropathy. There is no magic cure to get rid of your numbness, but you can apply topical gabapentin, gabapentin, and pregabalin and so on. I'd like to once again thank the chair and Dr. G. Vijaykumar for asking me to give this talk on a very important topic, very tough topic, very tough topic. Painful neuropathy is much more easy to talk.
Yes.
Thank you, sir. Very kind of you and excellent deliberation. We request you to stay back for the Q&A session that will be after the 2 lectures, sir. Dr. Shanmugavelu, sir.
Yes, now I invite Dr. Jayaprakash Sai. Yes, Jayaprakash Sai, Chief Medical Officer, Apollo Sugar Clinics, Hyderabad. He is a fellow Robert Timer Turner Diabetes Research Training. He is a National EC member, RSSDA, and he is also a fellow RSSDA. I request him to take all of us through his presentation on Frozen shoulder. Over to you, Dr. Jayaprakash.
Tell them to get some tea, man. He brought it up.
Dr. Jayaprakash?
Sir, I don't see him in this group.
Okay, then we'll
Vijaykumar, sir?
We'll invite
Vijaykumar,
Dr.
sir,
Morgan. Dr. Morgan. Morgan is ready.
Jayaprakash
Now,
sir, not busy for call, sir. I call you.
Dr. Morgan, can you make a presentation now? We'll have Dr. Jayaprakash presentation subsequently. Dr. Morgan, are you ready? Yes, I invite Dr.
Ready,
Morgan.
sir. I'm ready,
Yes.
sir.
Yes, Morgan, one of the physicians from Chennai, is an active member in most of the CME programs. Without Morgan, no, we have not participated in any of the CME programs in Chennai. I request Dr. Morgan to take all of us through his presentation on stress and depression in diabetes. Over to you, Dr. Morgan.
Yes, sir. One second. Yes, share screen.
Yes, proceed.
Thank you, sir. Thank you for giving me this opportunity. Am I clear, sir?
Yes.
Yeah. Thank you for giving me this opportunity and the kind words of introduction from the chair. This is a great opportunity to be part of 3D. I would like to, over the next 10 to 15 minutes, we'd like to present on stress and depression in diabetes. We all know this diabetes and depression is a rapidly growing area where you have the chronic therapy is a big problem for all the people because of the socio-economic burden it gives. And finally, the quality of life of each patient becomes poor because of this. Worldwide, more than 425 million people have diabetes and around 375 million have depression. So huge numbers are there in both. Because of this, both the disorders are projected to be one among the 5 leading causes of disease burden. That is like almost like the Chinese, like every alternate person is going to have diabetes and depression. The recent STAN study found that around 20% of persons with type 2 will have depression. What promoted them to have this was people who had associated previous history of depression, history of mental status below a mean level, history of previous neuropathy, fair or poor self-reported health status, patient who needed insulin for control of their destiny, as well as female gender and high blood cholesterol levels. If you see this, Indians have only around 2% of people, the Indians have depression. Possibly it's because of the way we live together, and it's a common host status. We have better around help for people. So compared to many other places in the world, it's much lesser. That said, it is increasing by leaps and bounds. So diabetics have a twofold increased risk for depression. So as the number of diabetics are going to rise, number of years diabetics are going to rise, the number of depression patients are also going to be on the rise. According to the ADA, around 3 to 5% of population at any given time, the rate of diabetes is between 10 to 15% will have depression. Depression is under-recognized because most of us do not ask for it. Patients don't come out with it because of the social stigma, as well as the timelines that we do not spend with the patient. But unfortunately, if both exist together, the control of diabetes and control of depression both dwindle very fast. So what? It is only 8%. So why worry? It is because together they have a great impact on each other. Diabetics report an earlier onset of depression. Depressed diabetics have earlier, more severe prevalence of physical problems, definite link, bidirectional influence, which causes more morbidity for people. The basis is rise in the catecholamines, which cause all these things. What happens is in chronic stress, more amount of catecholamines, less amount of control, and it's a vicious cycle that happens. The pathogenesis is that it's not a causal association. It is a complex association. That is both ways. Depression increases the uncontrolled diabetes. Uncontrolled diabetes, more number of people have depression. Depressive symptoms are more common in diabetic patients with macro and microvascular problems. So any patient with complications have more amount of depression. And if you look at the pathogenesis, what happens is that the external environment, that is the poverty, childhood adverse life, all those things causes poor eating behavior. The poor eating behavior and in the intrauterine stage, there's a fetal nutrition problem, there's a maternal stress, and the catch-up growth is very good. These people land in obesity. And because of that, what happens is there's the epigenetic change, inflammation goes up, thereby insulin resistance, hyperglycemia occurs. And the insulin-resistant hyperglycemia, along with it, causes more amount of complication and cognitive impairment. Both these together causes depression. So depression and diabetes are caused in a common soil to a great extent, thereby people suffer more. The effect of depression on diabetes is that after adjusting for all the other confounding factors, depression by itself can raise HbA1c by around 0.9 or 1. Pungudu et al. Found that there is a significant association between depression and glucose intolerance cells. That is, even in pre-diabetic status, the amount of depression increases. National Health Interview study shows that it is 7.15 times more likely to expression and debility if a patient has got comorbid depression in a diabetic. Conversely, depression can also increase the risk of type 2. And not only that, the cortisol hormone, if it is chronic, can keep the person uncontrolled for a long time, thereby all the complication worsens. Impact of depression on diabetic control. We all know that depression worsens the blood control level, and it causes both functional, physical, and psychological costs associated with depression. Several studies have documented decreased adherence to diet, exercise, medication regimen. Obviously, a depressed person will get they'll have less number of visits, they'll adhere less to the treatment, because depression is going to make them not want to do many of these things. Even the antidepressants can cause change in the way you have the glycemic thing, because it increases the insulin resistance, decreases the insulin sensitivity, and causes changes in the inflammatory cytokines. It is well documented that it induces weight gain, through which again it causes more metabolic syndrome and diabetes. What is the outcome when both are there together? There's a higher risk for heart disease, higher body mass index. As I showed you, depression as well as the catch-up growth if it occurs early in life can cause more amount of this thing. Depression as well as antidepressants can cause increase in the body mass index, thereby the metabolic syndrome worsens. It cause hyperglycemia. And because they are depressed, their self-care ability decreases, and their advice, other exercise advice, other things, adherence also decreases. Thereby it increases mortality. It also has been clearly shown that persons who are depressed have more number of hospital visits, and thereby the expenditure incurrence is much more. Diabetes and depression, when you look at the self-reported health score, is only secondary to persons having more than 2 chronic conditions and depression. So diabetes by itself is worse than when they have an arthritis and depression, when they have asthma and depression, when there's no other chronic condition. Compared to all that, it is worse. How can we help the assessment? Patients, we need to talk with them. That is the most important part of the treatment. Medication, stress management, and tools for stress management, including support group and counseling, has been shown to be the most important part of it. If you look at it, the way people present is depression and diabetes symptoms overlap. So the patient feels that the clinician is unaware of it, and the clinician feels that patient is not listening to him. Depression is associated with onset or amplification of physical symptoms. So patient comes with vague symptom which we brush aside because their uncontrolled blood sugar is the cause. It is commonly associated with difficulties with diabetic treatment because the patient does not listen to what we say. Because of the stress, the patient may not appreciate or take our advice properly, because of which the patient feels that we do not have a good control because the clinician is not taking care of me, and vice versa. Depression may reduce the ability of the individual to trust the doctor. Thereby, they do not accept what the doctor says, and they do not turn up for appointment. They do not take up the healthcare providers this thing seriously. Psychosocial issues, what does the ADA recommend is that they say it should be an integrated, collaborative, patient-centered approach. Psychosocial screening and follow-up may include, but it's not limited to, the attitude about diabetes. So, and quality of life is impaired very much, for which we should not only screen the patient, the caregiver, the family members' attitude should also be screened, so that they do not come and tell that, they are not averse to the patient's difficulty. Not only that, the older adults should always be screened for any cognitive impairment and depression. Then only they will be able to be cared for better. And ADA recommends that patients with depression who have got a positive score and who need this thing should be kept for cognitive behavioral therapy from an expert. So an expert referral is recommended there. Whom do you refer? You should refer those patients who do not come under control, who's got a very low self-esteem, who has got a fear of hypoglycemia, the anxiety outweighs the real hypoglycemic problem, patient who omit their insulin or medication because they are frightened, who has got either an eating disorder, that is both overeating, bulimia and overeating, they need to be referred. Patients who have got a positive cognitive impairment, they need to be referred. Before undergoing a bariatric surgery, the outcome should be properly talked to so that they stick to what happens. And not only that, those who have a positive, or we should say negative scoring, should also be the thing. multiple studies have been done with number of drugs, including nortriptyline, fluoxetine, paroxetine, etc. But they all improve depression, not the glycemic control. Whereas the cognitive behavioral therapy has been again and again in multiple studies shown that it is able to decrease depressive levels as well as the glycemic score better. So possibly cognitive therapy is the thing. Then when do we treat depressive patients? With the other thing. When there's a comorbid depression and less anxiety, there you can use an SNRI or SSRI. If there's a sexual dysfunction, there you can add. If there's a significant neuropathy, you can use an venlafaxine or duloxetine, which can be effective in both. In these places, and antidepressant is advocated in and diabetic. Now, so coming to the end of the session, we'll see the take-home message is that it is very prevalent. It is time we start asking our patients if there's anything, if possible, start scoring them so that those who have depression can be needed out and we can spend some time to talk to them so that they feel better. Challenges remain because of this for the patients and providers. In fact, many of the older physicians used to say, like, those who are not under control, you try an antidepressant, they may come under control. The inclusion of established screening protocols is necessary, and cognitive behavior therapy has been shown to be better, more effective in control of diabetes and depression than supplying more and more drugs. Because as a diabetologist, we need to give people a great quality of life so that the glycemic pentad, preventing hypoglycemia, controlling their HbA1c is alone not enough. So we need to prevent hypoglycemia for various side effect reasons. Likewise, the quality of life needs to be looked at so that we render an wholesome care to the diabetics. Thank you.
And thank you, Dr. Mohan, for your highly informative talk on diabetes and depression. According to you, depression is most often neglected, untreated, undiagnosed. And you have pointed out nicely the impact of depression on glycemic control, the impact of depression on diabetes-related complications, the role of antidepressants and depressants with reference to the change in body mass index and other risk of diabetes-related complications. We'll take up the question at the end. Please stay with us for some more time. Now I hand over the microphones to Professor Dr. Srinivasamurthy.
Thank you, sir. I think the next topic is about the therapy for the depression and the psychosis with our diabetics face. I think Dr. Mohan has rightly pointed out the problems with the depression. Now we have Dr. Selva Pandian to talk about the antipsychotic drugs and diabetes. So meanwhile, we request all the audience to post their questions in the chat box, please, so that the eminent speakers are staying back for your question and answer session also. Dr. Selva Pandian, sir?
Yes, sir.
Yes, sir. Okay, Dr. Selva Pandian is a director at the Kamakshi Diabetes Care and Research Center, and he's a diabetologist with special training in endocrinology under Dr. S. Murthy, and is a teaching faculty in Annamalai University in Chidambaram from 2004. He's attended various conferences and has got various deliberations. And over to you, sir.
So my screen is viewable, sir?
Yes, sir.
Hello?
No, sir, not yet.
Hello?
Kindly share your screen. Dr. Selva Pandian, kindly share your screen.
Hello?
Prashant, RX Events, kindly look into the problem.
No, sir, not a problem. Sir,
Yes, Dr. Selva Pandian, share your screen.
Can you share, sir?
Yeah.
It was seen once.
Yes, sir. Yes.
Yes,
Okay,
yes,
sir.
proceed.
Yes, sir.
Proceed, Selva Pandian.
Yes, sir. Thank you, sir. First of all, I would like to thank the chairpersons for their kind introduction. And I would like to thank the 3D and the organizing committee. Along with, I would like to thank Dr. G. Vijayakumar for giving me this excellent opportunity. And I'm going to talk on antipsychotic drugs and diabetes. I'm not a psychiatrist. I'm a diabetologist. In the diabetologist's perspective, what is the antipsychotic drugs and how it is going to cause diabetes? That's what I'm going to talk. And it is now emerging that several of the novel antipsychotics are associated with weight gain. And we all know that weight gain increases the risk of obesity-related morbidity. And furthermore,
there are some predisposed patients receiving antipsychotic medications may have de novo glucose dysregulation, exacerbation of pre-existing diabetes mellitus, or the induction of diabetic ketoacidosis. So although the risk associated with each of the commercially available novel antipsychotics is not definitely known, there have been significantly more cases of these problems with clozapine and olanzapine. And however, we can't say that these drugs are causing diabetes is remains to be inaccurate. But still, the second generation or the atypical antipsychotic drugs are effective treatments for various forms of psychiatric illnesses. And the first generation drugs, such as chlorpromazine and haloperidol, have been associated with significant and sometimes rapid weight gain, increased plasma lipids, and abnormalities in insulin sensitivity, including diabetes. And there was a consensus panel of experts with endocrinologists and psychiatrists, and they published some recommendations. That is, before starting a patient on antipsychotic medication or as soon as possible after initiation of therapy, assessment should be made to determine if the patient is overweight or obese or has diabetes, hypertension, or dyslipidemia, and accordingly an appropriate treatment should be initiated. And even when the patient gains more than 5% or more of weight gain, certainly there should be an option of consideration to switch on to the other antipsychotic medication. But patients who have gained weight are at risk of developing diabetes. So changing APD to one less likely to cause metabolic effects can be considered, and weight against the risk and benefits from continuing the treatment with the same drug should be considered. And in the general rank ordering of antipsychotic drugs that have the greatest to least risk of metabolic effects, the greatest is with the olanzapine, next is the quetiapine, risperidone, ziprasidone, and lastly the safest will be the aripiprazole. So weight gain can occur with all these drugs, but there is a considerable variability exists among the patients receiving the same drug. So it has to be noted. And while the antipsychotic drugs have the propensity to cause weight gain, a risk factor for diabetes, there appears to be a direct relation or an additional effect on insulin sensitivity. So the long-term treatment with antipsychotic drugs was reported to cause insulin resistance in lean patients with schizophrenia. And the etiology is not clear, but schizophrenic patients have more diabetes than the general population, even when the drug use is controlled for in calculating the prevalence. So regardless of the cause of diabetes in a patient receiving an antipsychotic drug, they should be treated using any and perhaps all the measures noted previously. Although using drugs to treat diabetes poses a risk of an additional side effect burden and increased costs on someone receiving an antipsychotic drugs, if changing antipsychotic drugs is not an option or changes have been attempted and failed, then certainly we have to go to the other controlling measures like minimizing the weight gain to the treatment with antipsychotic drugs may be useful. So in that thing, we know several drugs with the sibutramine in topiramate and metformin, but still only one drug seems to be exception and safe also, that was metformin. And this was been used safely and effectively in adolescent age, 10 to 17 years with olanzapine, risperidone, and quetiapine. So lifestyle modification that needs a very high motivated subjects, then only with this lifestyle modification, they can have a successful weight control. So the cause of diabetes is still fact unknown, but it is said to be a multifactorial phenotype, and it is unlikely that any single factor will be sufficient to explain the illness in the most of the populations. And these are the three drugs which are dangerous for diabetes: chlorpromazine, clozapine, olanzapine. And somewhat moderate risk for diabetes is risperidone and quetiapine. And the lowest risk, as I told you, it is aripiprazole and ziprasidone. So the best antipsychotic for diabetes will be the aripiprazole and the ziprasidone. And the key point is the second generation antipsychotics should be prescribed if extrapyramidal symptoms have been a particular concern in patients using the antipsychotic drugs. So in that case, aripiprazole, clozapine, olanzapine, and quetiapine are least likely to cause these extrapyramidal side effects. So of the second generation, as I told you, amisulpride and aripiprazole have the lowest risk of diabetes, and prescribing of most antipsychotic drugs requires full blood count, urea and electrolytes, liver function test to be checked before starting the treatment and annually thereafter. And this is one paper regarding antipsychotics and diabetes, which had an age-related association. So here they saw that antipsychotic drug use was associated with diabetes mellitus, and the association is stronger in younger patients. In older adults, the difference was much smaller, and lower risk was associated with atypical agents as compared to the typical antipsychotics. So clinicians should be aware that young adults treated with antipsychotics are at increased risk for diabetes. Thank you.
Great, sir. I think you were on time. Before the psychiatrist pitched in, you stopped it.
Yeah.
So thank you very much at this odd hour talking about the antipsychotic drugs and diabetes. And it was good to hear from a physician rather than a psychiatrist, because that is what we look at in our angle. Thank you very much for that.
Thank you.
Shanmugavelu sir?
Yes, sir. We invite the speakers. We request Dr.
Usha Aigiri, Dr. Vijay
Usha Aigiri,
Vishwanathan,
Dr. Vijay Vishwanathan, Dr. Mohan, and Dr. Selva Pondian. Please come for discussion. We'll take up the questions. Yes, we would like to. Where is Dr. Venkatraman? Dr. Venkatraman, please join with us. We'll have a fine discussion because we have ample time. In meantime, if we get Dr. Jayaprakash, we'll listen his lecture also. Yes, Madam, Dr. Usha Aigiri.
Yes, I'm right here.
Yes, Madam. We have a first question to you. That is, of the available two alpha glucosidase inhibitors, namely voglibose and acarbose, which one is good?
Can I just say to the event manager first, there is a horrible echo on this
Yes.
sound somewhere. It's really, really, really bad. So could somebody please deal with that?
I just messaged them.
Yeah. Okay, between acarbose and voglibose.
Voglibose, which is better?
Okay. There are very few head-to-head comparisons between acarbose and voglibose. That is one. Number two, where there is a little data, they seem to be more or less equally effective. Numerically, there might be a small difference, but not a huge statistical difference. Voglibose claims to have fewer side effects, but voglibose at the gut level also acts on mono and disaccharides more than on poly and oligosaccharides. But the reason I personally prefer acarbose is because this is the only trial, it is the only AGA that has cardiovascular outcome data. From Rory Holman's group, acarbose is the only one that has cardiovascular outcome data. So in terms of efficacy, both of them would seem to be more or less equally effective. In terms of side effects, I have found absolutely no problem with tolerance, although some of the literature does cite that voglibose may be better. In terms of cardiovascular outcome trials, acarbose hands down is the only one that has any data. I hope that answers the question.
Ma'am, then why, ma'am, I've got a question related to that. Why so many companies with voglibose have come out and acarbose is still with only one company?
I think it's the same as the old being, see, we always run after the new and the fashionable. And the other thing I'll say is voglibose, I think, is a Japanese molecule which has come to India. Acarbose, two things. When I was in the UK, I barely ever used any AGIs because the need for a carb absorption inhibitor was minimal. But when we did use it, acarbose is the only one available across Europe because voglibose is not licensed elsewhere. So I think in India, it is a question of the licensing and the cost more than anything else. But acarbose has been in the market for much longer, is used in the rest of the world and has good data in terms of cardiovascular, one cardiovascular outcome trial. So I think in India, it's just how it's been promoted or not promoted.
Dr. Srinivasamurthy, I think you must be remembering, few Indian companies, they have come out with acarbose, but they withdrew because comparing voglibose in terms of flatulence, that was less with the voglibose. So many of the pharma companies, they started focusing their attention on voglibose because of the less GI side effects, rather than they look into the real pharmacokinetic and pharmacodynamic profile and the long-term cardiovascular event profile with reference to acarbose. That is the main reason.
And also the manufacturing cost. Manufacturing cost is way high with acarbose.
Less with voglibose.
Dr. Shanmugavelu, I've been using acarbose, 25 milligram, and there's absolutely no side effects if you use 25 milligram. If you go to 50, then you get all the side effects. Similarly, voglibose 0.2 has no side effect. Go to 0.3, you start getting. So I think, I tend to use 25 milligrams of acarbose for the last 27 years. And I have not had to withdraw anybody from acarbose 25 BD, 25 TID.
I agree completely. I use Acabose. It's my AGI of choice. And very, very, very rarely have I had to. And the other thing is, people who don't have excessive GI side effects on metformin will generally tolerate AGI well. So that is an indicator. If somebody tells me that they've tolerated metformin well, I'll confidently use an AGI.
Yes, madam. GAS.
Empirical, purely empirical, not evidence-based.
So
Dr. Venkatraman, what is your experience, sir, on Acabose versus
I
Voglibose?
totally agree with you. I think a lot of players are there in the Voglibose market. But I thought Usha's talk, I think as usual, she has done a brilliant coverage within the limited time. There are two aspects I thought Usha and Velu, if you permit me, for the sake of the clinicians and the practitioners who would be listening, get connected. Number one, when you talk about the glucosidase being inhibited, the question that will be at the back of the mind is, can people have lactose intolerance? When you are going to block some enzymes in the intestinal tract, how about the lactose intolerance? So we have to assure them that this is an alpha glucosidase inhibitor and lactase is a beta glucosidase, even though it's fundamental. Sometimes, in fact, one of the doctors was asking me when I give this prescription, sometimes it's not as if we remember the basics throughout our lifetime. So it's better to assure them. That is number one. Number two, which I thought was much more important, is now alpha glucosidase inhibitors are on board because of the carb content and the TP control, which is absolutely essential, on board with sulfonylureas, insulin, etc. So there is an increased propensity of hypoglycemia when sulfonylurea or insulin is on board. When a co-prescription of an alpha glucosidase inhibitor is there, then it's better to avoid or not to give the table sugar which is available in the kitchen. Normally we do that whenever, because that is sucrose. You have already inhibited this, you should give only glucose. So these are the 2 points I thought which will be very, very relevant. I totally agree with Mohan. Glucobase, that is Acabose in a very small dose, plus very impressive data. I think the data are so much, very, very impressive, both for the prevention as well as for the cardiovascular endpoints, especially even though it could be exploratory, it is very, very relevant. And Mohan, congratulations to you. I mean, Vijay, very congratulations to you, Vijay, on your president-elect. And you beautifully highlighted a point, but what I thought was, it's virtually impossible to treat a numb feet from the point of view of therapeutics. Whereas extremely painful, you do all the gimmicks. You play with your molecules, you have the external application you can control, but the numb feet, I think the risk for the amputation is so high. I think you nicely highlighted, you have to ask the patient to accept it and then be careful from a future morbidity and other point of view, from the point of view of this thing, amputation. I think you nicely highlighted. I really enjoyed. And one point that you nicely highlighted, the small fiber need to be targeted for both. I think that's a relearning exercise. Thank you so much for in your short time. You just highlighted and then assured the clinicians. There's nothing much that is extra that you do, but whatever you're doing, we'll address the numb feet from the form of therapeutic intervention. Thank you so much.
Dr. Vijay Kumar, what would you do for a numb feet? Would you do anything extra than?
Nothing, only prevention of ulcer. That's the only thing we could do that. I don't think we can do anything more than that. I don't think we can do more than that. But I just want to ask you, Dr. Vijay, do you think that there's some new products like, levocarnitine, which is supposed to improve the microcirculation of the nerves? Do you think that those things are really work? Because it's supposed to improve the nutrition, blood supply to the nerves, and then that would improve the nerve conduction, velocity, and other things. Is it true?
No, as I showed you the initial slides, Dr. Vijay Kumar, it's the endoneural hypoxia, and that is completely dependent on lipid peroxidation hyperglycemia. So none of these agents, including methylcobalamin, I don't use it because it's absolutely useless. But methylcobalamin is used right, left, and center. The only treatment which has been shown to have some benefit in neuropathy is alpha-lipoic acid by Dan Ziegler from Dusseldorf, who showed 600 milligrams for 6 months. So in India, we have two brands. I'm not supposed to say that, but Alase and Alafin, which comes as 600 milligrams. So I use it extensively in neuropathy. Alafin and Alase. I'm not supposed to tell brand names, but these are two brands which are available as 600 milligrams, which I added on to Neuroburn Fort or Neuroburn Plus or whatever. But apart from that, there is absolutely no role for methylcobalamin and benfotiamine and blah, 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 blah.
I think Vijay, if you remember this, the concept of endoneural hypoxia probably tempted people to try even pentoxifylline. I remember pentoxifylline was at one time enjoying some sort of a patronage, and that it was a costly placebo rather than being meaningful effect. It was quite expensive.
In fact, severe gastritis. Severe gastritis you get with Trentol.
Yeah.
Severe gastritis.
Yes.
So, Dr. Vijay, sir, which set of patients do you use footwear in the numbness setting, sir?
See, supposing
what kind of footwear?
You should measure the limited joint mobility. So that is not done in India. So if you have limited joint mobility with neuropathy, your risk of amputation goes up 5 times. And Professor Andrew Bolton showed that limited joint mobility does not occur in the Asian Indians, whereas I showed in one paper subsequently that it does occur in Indians. So limited joint mobility, if you just dorsiflex the big toe, and if you can't, because limited joint mobility in the hands is prayer sign, but in the lower limbs, you have to dorsiflex the big toe, and if you can't do more than 60 degrees, you have limited joint mobility. You can also use a goniometer and measure the subtalar joint movement. That's difficult. So if you just move your big toe down backwards, dorsiflex it. If you're able to do it 60 degrees, you don't have limited joint mobility. But limited joint mobility and neuropathy will definitely add more insult to damage, and you should tell your patients not to walk barefoot and wear a protective footwear.
Thank you, sir. And this methylcobalamin, you said,
can I have a...
Yeah, please, sir.
Sir, I'd like to have a question. Sir, does Epidemiology help?
Sorry, Mohan?
Epidemiology. Epidemiology.
Yeah, but again, the data is not very strong. These agents have been tried in the past and given up in Japan. And there is no hardcore data. We need studies, and nobody apart from the Japanese and Indians use that drug.
Dr. Vijay, if you look into the studies that has involved Epidemiology, patients with advanced neuropathy, elderly patients, diabetes of longer duration were selected, were recruited, and this particular drug was administered without any benefit. On the other hand, patients who are young of the diabetes of shorter duration, when initiated with especially painful neuropathy, 50 milligrams twice daily, definitely there is improvement with reference to painful neuropathy part of it, along with other pregabalin. So the inclusion criteria of that particular study that decides about the efficacy, tolerability profile of the particular drug. That's my view.
Vijay sir, you said categorically that methylcobalamin you don't use at all in practice, but what about the occurrence of B12 deficiency with metformin long-term usage?
That we are anyway giving supplements, no? We don't give metformin without giving supplements today. And if you have doubt, in the workup for neuropathy, you have to check your vitamin B12, thyroid, and gamma globulin levels and everything. You have to do a workup. As I said in the first time, don't assume every neuropathy is diabetic neuropathy. You have to rule out all the other factors. Diabetic neuropathy is a diagnosis of exclusion.
I think that's an important point. Important point what Dr. Srinivas has said. That is regarding the using that your B12 deficiency. When somebody is on metformin, there's no point in giving again oral.
Only parenteral.
You have to give an injectable. That's an issue because it cannot be absorbed. So we need to give injections.
Not frequently.
One more question, Dr. Vijay. Do you think that this epilorastat, though it is not useful in numb fit, we know that. Do you think that it may be slightly useful for painful neuropathy at least? Because it works on this orbital pathway. Do you think it works?
We discussed just now, Vijay.
Regarding the numb fit. He was talking about the numb fit.
No. We are talking about painful neuropathy. I made a mention about painful neuropathy.
Sorry. I missed it.
No problem.
About the numb fit, I want to make a Velu. Can I just?
Yes, always.
That the association of type 2 DM and hypothyroidism, the presence of the manifestation of numb feet is much more rather than without hypothyroidism. This is just an observation. So
Usha can highlight that.
Hypothyroidism. Yeah.
Usha, you see a lot of hypothyroidism and diabetes, no?
Yes,
Usha?
there is, and we had an abstract that was published a few years ago that showed that certainly where diabetes exists, up to 30% of women could be hypothyroid, and it's worth screening for hypothyroidism in women, especially with type 2 diabetes, less so in men. So definitely in hypothyroid women, but I haven't seen any literature. I mean, I know you said it's anecdotal, Dr. B, but I haven't seen any literature. I'll go and have a look if there is any increased incidence of neuropathy with treated hypothyroidism, not untreated, but with treated hypothyroidism in diabetes, whether there is any incidence of increased neuropathy. I'll have to look up.
Especially numb feet, that's an observation. Yeah, I would like to have feedback from you. Thanks, Usha.
Sir, I have a question.
Yes, Gauri.
Gauri Shankar, please.
Sir,
Yes, Gauri.
sir, regarding this antipsychotics, sir, is there any preferred drug as far antipsychotic induced hyperglycemia is concerned? And second thing is to Usha madam. Madam, like between oglibos or acarbose versus DPP-4 inhibitors for postprandial hyperglycemia, which one will you choose? Or will you in a given patient, are you comfortable in using both these drugs in an Indian setup?
I combine, honestly.
Both DPP-4 and
I mean, my DPP-4 usage is quite high to start with anyways, but despite giving DPP-4s, especially in our Tamilian, South Indian setting, that meal that has the largest carb load, I put an AGI at that. I usually put an acarbose before lunch or before their largest carb load. So I might use a DPP-4 metformin combination morning and evening and put in an AGI midday. I routinely combine these, and it's safe to combine. There is data to show that it's safe to combine.
Okay. So regarding the question of preferred anti-diabetic drugs for antipsychotics induced hyperglycemia.
Dr. Selva Pandian, I think he's there.
See, that's what the thing. What I found was aripiprazole.
Selva Pandian,
Yes.
please respond to
Yes, sir. Yes,
Gauri
sir.
Shankar.
Yeah.
Yes.
Yeah. See, as per my literature, the only one drug which was very commonly used nowadays in younger patients, aripiprazole. That had the least literature to say that it causes diabetes. And next is the japrisone. So these are two drugs, and that's what I was very specific with these two drugs. And one more thing was amisulfide. These are the first these two drugs. Then amisulfide also can be added. So aripiprazole, I see a lot of prescriptions in the diabetic population, and I think so that will be the safest. And as I told you, the first generation drugs are very, very vulnerable with the weight gain, and that should be avoided. Or at least it has to be weighed according to the risk and benefits, whether it has to be can be used in the patients, diabetic patients.
Right.
Most of our patients, most of our patients are not on ariprazole, sir.
Yeah.
They are on either olanzapine or risperidone.
Now the
so
latest,
not even 5% of the paper are there, and they are not the good antipsychotics also to start with. So my question is not changing the antipsychotics. Is there any preferred therapeutics, like somebody say like the GLP-1 is better choice for these patients who are non-compliant, and there are some studies also. The senior
yes, of course. Patients on antipsychotic drugs, GLP-1 receptor analogs are definitely useful, beneficial in terms of achieving glycemic control as well as in achieving weight reduction also.
But it is very difficult, sir, to with these psychiatric patients to have the complaints that to giving a GLP, because giving a diabetic drug itself, the complaints is so bad that they require attender. Somebody should attend them. Or in that case, I think so. GLP,
for education,
even
motivation.
though it has, as you told, the benefits are there, but it can be in the event of any trial or something, but not in the real world experience. It will be very difficult, sir, to manage them or to have a complaints with them. It will be very difficult.
Actually, I do a once. Sorry, if I may come in. I use a once weekly GLP-1 receptor agonist, and it's very easy to train the family to administer it. The device is easy to use, and the compliance rates go up manifold. And the GLP-1 receptor agonist is particularly useful because in case of antipsychotics, it's not just the diabetes, but the added burden of obesity and the non-compliance, not only with medication, but with dietary measures and lifestyle measures. Generally, getting them to exercise is difficult. Getting them to eat healthy is difficult. So I find a GLP-1 receptor agonist, a once weekly one, extremely useful, and compliance and concordance has never been an issue for me.
But
sir, I have a question to raise. Sir, does bromocriptine help in such patients?
Of course, bromocriptine increases the dopamine level, no problem, especially the quick release formulation. So start with 0.8 and increase it to 2.5. But the thing is, there is no RCTs available as of now to recommend this particular product for management of patients with depression and the patient with the diabetes.
Velu sir, you have not asked Dr. Mohan
One
any
of the
questions.
add-on drugs for Parkinsonism by some people, especially bromocriptine 2.5. It used to be a prescription of previous generation neurologists.
I mean, that is a slow release formulation. He is asking about quick release formulation.
Oh, quick release.
Yes.
Quick release formulation.
I
Quick
just
release.
have couple of points with respect to antipsychotics and diabetes. In the diabetic in elderly diabetics, senile psychosis I see so often. And the family is not too comfortable seeking a psychiatric opinion. Of course, you can always wash up the hand. But I find that a small dose of a QTPin, just about 25 milligrams, does a fantastic job. And it was heartening to learn that all these antipsychotics do have a detrimental effect on the metabolism in a younger individual rather than the elderly. So just to say that when you are dealing with an elderly population, your chances of encountering a senile psychotic patient is very high. If you are allowed to have a psychiatric opinion, fine, you have the extra advantage and then you are comfortable. On the other hand, as a treating physician and diabetologist, if the family insists, small dose of QTPin does the job so wonderfully. I've managed quite a few patients, and it's heartening to realize, as Cello pointed nicely highlighted, it doesn't have much of a havoc from metabolism point of view in the elderly population, whereas the younger, that is quite an interesting. We always see as the age advances, everything increases, but fortunately, probably the exposure to the antipsychotics at that age is not adding an extra risk with respect to metabolic derangement. Thank you.
Yes. My question to all the panel members, in the absence of Dr. Jayaprakash Sai, let me bring one particular issue for discussion. That is, we come across periarthritis, that is adhesive capsulitis in our day-to-day clinical practice. We use the conventional drugs. My question is, have you ever tried hydroxychloroquine in the management of frozen shoulder? I want your opinion and also your views on this particular drug. Hydroxychloroquine in the management of adhesive capsulitis, because there was a poster presentation in American Association of Clinical Endocrinology way back 3 years before 2017 by Sasak Joshi et al. He gave 400 milligram of hydroxychloroquine on the top of standard of care. There was significant improvement over a period of 12 weeks with reference to glycemic control as well as improvement in the shoulder pain scores. I want your opinion. Yes,
Shanmugavelu,
yes,
the first paper from India, Nihal Thomas and I we did this study on hydroxychloroquine for IPCA.
Yes,
and we
sir.
published it. We compared it with 45 milligrams of pioglitazone.
Yes, sir.
And we found that hydroxychloroquine brought down the HbA1c as good as 45 milligrams of pioglitazone. It's published. And after that, they have published 2-3 papers. So I think the glycemic control improves dramatically with hydroxychloroquine. And Nihal Thomas and I produced the first paper from India comparing with pioglitazone 45 milligrams. At that time, it was available. So we were using. So I think hydroxychloroquine directly may not be influencing the periarthritis. By controlling the diabetes, it might be influencing, or maybe it's got some anti-arthritic potential. I don't know.
Since we are using for rheumatoid arthritis, SLE associated with joint problem, there was improvement and maybe.
Anti-inflammatory effect.
Yes, Paneer.
Yes,
you must have done. Yes, you must have also participated in the trial.
Yeah. It has some anti-inflammatory effect. Both are getting controlled. See, for your information, myalgia, the Kaikal Kodachal syndrome, for those people, along with the anti-diabetic, it affects both. So it controls myalgia as well as instead of going for pregabalin and all. Even pioglitazone 45 milligram will increase the weight gain, edema, etc. Here, the edema, weight gain are all not there.
Yes.
Periarthritis is not an inflammatory condition. Periarthritis is not an inflammatory condition, so it helps us.
It's a form of rheumatic condition only.
It's
So
muscular.
let me try to clarify that from whatever I have understood. When a diabetic patient is present with shoulder pain, he can have all these things. You can have adhesive capsulitis, you can have a periarthritis, you can have even a rupture of a tendon. I always find that quite often a blind treatment of a shoulder pain is fraught with a lot of risk, and the
MRI.
when it gets postponed. I think MRI is a must whenever there's a resistant shoulder pain. I agree with you. Any anti-inflammatory, maybe hydroxychloroquine acts as an anti-inflammatory because once it is effective in rheumatoid, why not in inflammatory arthritis or adhesive capsulitis? The inflammatory component can be taken care of. But when you talk about the shoulder pain, there are so many ingredients into it. At some stage, when there is a resistant pain, I think it's worthwhile doing an MRI because quite often there has been certain amount of pathology happening which is amenable only for surgery. For example, rupture of a tendon, etc., etc. And of course, not. The importance of physiotherapy need not be underestimated because absolutely the physiotherapy and then remobilization and of course local steroid injection all do have a role. But shoulder pain is an entity which requires evaluation in a resistant patient, which I'm afraid is not done to quite a good number of diabetic patients. They always go with PA right shoulder, anti-inflammatory, physiotherapy, etc., etc. Finally, they land up with a frozen shoulder. I think at some stage, aggressive investigation.
Sorry, sir, but not all of them are landing up, sir. But of course, I could say 70% after good control of diabetes or 80% they recover.
We agree.
They beautifully recover.
After proper evaluation.
Yeah.
Exactly. Proper evaluation.
Who are all not responding for minimum 3 months to maximum 6 months.
Initially, also an MRI needed, sir, because I saw a patient who had my own staff nurse father. The knee test was positive, Insulin syndrome was positive, classically presenting like an frozen shoulder. But when I did an MRI, it was presenting with a multiple myeloma. So
we need complete evaluation, no problem at all. Better after ruling out other possible causes, and if it is pertaining only to the classical adhesive capsulitis in a diabetic patient, can be given. That's all. Okay. I really, yes.
Arvind must be wondering whether he is in an orthopedic platform or a diabetology platform. Because we are discussing orthopedic
since the topic is on frozen shoulder, I brought this for discussion. Anyway, yes, sir. Thank you so much.
We did not involve the depression, the most neglected even in our practice. Symbolically, we are not involving that discussion, but also I think Dr. Mohan is depressed now. He gave a lecture on depression and diabetes.
Yes. Srinivasa kindly. Yes.
Dr. Arvind Gupta.
Arvind Gupta. Nice to meet you. Nice to meet you.
I was just listening to your panelists' comments regarding the hydroxychloroquine. And actually, it is just my instant comments I want to give. And the comment is, whatever the said and done, hydroxychloroquine works very well in post-viral arthralgia. And we are using here in Rajasthan in post-chikungunya arthralgia, post-dengue arthralgia, and so many post-viral arthralgia, hydroxychloroquine works very well. So even in my diabetes patients who suffered from dengue, chikungunya, and other arthralgia, it works very well. So that is why I want to give this just little comments.
Thank you, Arvind. Thank you, Arvind Gupta. Thank you so much.
Thank you.
Yes. Dr. Srinivasa, you can say thanks to the organizing committee members. Yes.
3:30 in the afternoon. I think we had a very successful first meet with the august presence of Dr. Shanmugavelu as my co-chair. And with great inputs from S. Venkatraman sir and all the other panelists. We sincerely thank all the speakers and Dr. G. Vijay Kumar for the success of the meet. I think we are on time and we are handing over to the next session. Thank you very much again for everyone.
Thank you, Vijay. Thank you, Vijay Kumar.
All the
thank you. Thank you, Thank you for the speakers as well as the chairperson. It is an excellent discussion. Thank you for everybody. Thank you for
everybody. Yes. Thank you.
As the name of the conference is, Diabetes Dialogues and Discussions. I think we started off very well with that discussions. Thank you.
Thank you, Vijay Kumar.
Dr. Venkatraman sir.
Ready to sigh because we didn't participate and we had the time.
And Dr.
Special
Mohan,
memento
Dr.
to be sent to
Salapandian, Dr. Srinivas Murthy, Dr. Sharmagavelu.
Thank you, sir.
Thank you very much, everybody. Dr. Vijay. Now we'll go to the next session. We have already Dr. Panneerselvam have joined. Dr. Vijay Vishwanathan will not be available to chair the session because he has got some other engagement at the same time. So anyway, Dr. Panneerselvam is there to take it forward. Dr. Panneerselvam is very senior and very academically oriented, knowledgeable diabetologist and physician from the city of Chennai. He's got a lot of presentations to his credit, and also he has got a lot of in his presentation skills. He always shows his cases, real-time cases from his clinic, and he runs a very busy clinic called Arna Diabetes Center, and he is a well-known person all over the country, especially in Tamil Nadu as well. Sir, Dr. Panneerselvam, welcome to you and thank you for joining us.
Thank you.
And please take over. Please take over the session.
Thank you, Dr. Vijay, for organizing such a wonderful conference despite COVID, very sincerely and elaborately, and calling all of us and making this webinar platform to discuss on diabetes. So today we have plenary session. So very important topics by very senior speakers and important speakers like Dr. Arvind Gupta, Krishna Seshadri, and Dr. V. Mohan. So Arvind Gupta is going to talk on environmental toxins and diabetes. Dr. Gupta, Department of Diabetes, Obesity and Metabolic Disorders, Mahavir Jaikuria, Rajasthan Hospital, Jaipur. He has a lot of his credits, fellowship in American College of Endocrinology, and he has organizing secretary, 31st annual conference of RSSDA 2003 Jaipur. We all went there 17 years before. They have organized very well there. And he was co-scientific chairman of RSSDA Jaipur, member project review committee ICMR, and visiting clinician for Mayo Clinic, regional faculty, associate editor, International Journal of Diabetes Developing Countries, IJDDC, presented papers in various international conferences as well as national conferences. More than 78 papers on his credit. He is a member of all these organizations, AAC, APA, and RSSDA. And he is very good friend of all of us, and he is very good speaker. He is going to talk on toxins and environmental toxins and diabetes. Of course, various multiple pathophysiology for diabetes. 30 years before, we had a partial deficiency of insulin for leading to maturity onset, absolute deficiency leading to type 1 diabetes or juvenile onset. Now we have more than octet, now 14. Toxins are recently playing major role in the causation of diabetes. Dr. Arvind Gupta is going to highlight on that. Let us listen to him. Then we will have, as usual, dialogue and discussion after his talk. Over to Dr. Arvind Gupta.
Thank you. Shall I share my screen now?
Yes, sir.
Yeah. So, slides are visible?
Yeah, visible.
Okay. Thank you, Dr. Panneerselvam, for the kind introduction. And at the outset, I also thank Dr. Vijay Kumar and 3D Con team for inviting me for this beautiful discussions, which I have just witnessed just now before my lecture. What I'll be talking today on a very different kind of topic, that is urban stressors, pesticides, environmental chemicals, all are known as environmental toxins, and how these are related to diabetes, whether it is a cause of diabetes or it is something different. So it is definitely, whatever it is a challenge to mankind. And we have to see, please take my lecture as a pinch of salt. This is very important, and we should be very serious about some things which I'll be talking just now. For disclosures, nothing potential conflict of interest. We know that this is nothing new for this August gathering here, that the obesity and diabetes in the developing world is a growing challenge. And we, as Dr. Panneerselvam just told just now, that ominous octet, 10, 12, so many pathophysiological defects are there, so many reasons for the increasing epidemic of diabetes. And now we are actually witnessing two pandemics, twin pandemics of COVID-19 as well as the diabetes. COVID is now added one of the pathophysiological defect, the causes for increasing epidemic and the diabetes. So, but we should think out of the box. That is my idea of presenting this topic. And we know India is now having the very second number as far as the number of diabetics are concerned. We knew everything about all these things, affluenza, the diet, the physical inactivity, urbanization, everything related to diabetes. But some very important causes which we never think of that they may lead to diabetes. They are known as urban stressors. So what I'll be dealing with these smaller points, stress in the city dwellers, actually the people who are actually migrating from rural to urban areas, they are more, they develop more stress when they live in the city. Living alone, will you imagine the people who live alone have more incidence or more prevalence of diabetes. The sleep disturbance and chrono disruption, I'll be telling little bit details about this thing, how the sleep disturbance, if people are not taking proper sleep, less than 6 hours sleep, and they sleep on a different hours, the chrono disruption means the daily routine is changing, that may lead to diabetes. Sedentary lifestyle, we all know. Long-term noise exposure, that is again very, very important. If you have, you are receiving the loud noise most of the time, I don't know how the youngsters go to listen this DJ and the disco. I don't know how this affects their brain and but ultimately affects the diabetes also. Then the psychosocial stress in adulthood, that is very important these days. And our young generations are having this much of psychosocial stress. And of course, there are certain social risk factors like financial constraints, geographical constraints, again, very important. People are living 3, 4, 5 persons living in a very small flats, that may also lead to diabetes. And of course, people always say, we don't have any time for our health. We don't have any time for the diet and the food and everything, and they have time constraints. And probably all these urban stressors lead to diabetes. And let us see how this stress in city. People are not relaxed. That is very important. People are anxious always. They are annoyed unnecessarily. You must be witnessing these days that people are annoyed unnecessarily. We don't know the reason for that. People are insecure when they live in the city. And of course, they live alone most of the time. And the stress goes on like increasing like anything. And the important thing which I want to highlight here, it is the one of the striking findings in the cities changing diabetes study, or very popularly known as Copenhagen city changing diabetes study. And what this study suggests was that the living alone is an indicator of vulnerability to diabetes. Instead, they end up in choosing easy solutions such as bread, frozen, and so because of certain reasons, they don't have family to live with. In the Copenhagen, researchers found that those people living alone are nearly twice likely to have diabetes. Now let me just change my things here. Yeah. So the sleep disturbance, which I was referring to you, we are also working into this directions, that it is associated with 2 to 3-fold higher risk of late onset of type 2 diabetes. And what is maybe the reason is that it may be because of the increased sympathetic nervous activity associated with sleep disturbance that causes glucose intolerance and may increase the risk of type 2 diabetes. And it was published in Diabetes Care in 2004. The sedentary lifestyle, what we see here, that may also lead to increased risk of diabetes. And at the global level, absence of physical exercise and sedentary lifestyle are the 4th largest risk factors for the mortality. So there may be other thing. Now this is very particular thing. When you are actually exposed to noise, that noise acts an environmental stressor leading to activation of hypothalamus, pituitary adrenal axis, and that increases the cortisol level and may inhibit the beta cells and ultimately affect the insulin secretion and also affects the peripheral insulin sensitivity. So the high level of noise is maybe one of the important trigger for increasing diabetes. Psychosocial stress, especially in adulthood, that may lead to unhealthy lifestyle behaviors. We see our youngsters, they sleep late in the night, wake up late in the morning. Sometimes they don't even wake up in the morning, and they are totally dietary habits, physical inactivity, smoking, alcohol, what not these adulthood are causing, ultimately lead to again the same pathway, that is hypothalamic pituitary adrenal axis, that is HPA axis, and ultimately leading to increased cortisol levels. And the largest social risk factors, which we never think of, the people who have financial constraints, people who have the resource constraints. I told you about the geographical constraints, because that may lead to increased pollution, maybe some environmental things. And the time constraint, I told you that they don't have proper time, they don't have the timelines to do their work in a date period, that may lead to increase again sympathetic activity and this HPA axis activities. So this is one part of the environmental stress. Another thing is the real things which we never see in that thing, in that perspective, is environmental toxins. And what are those? They are air pollution. You may be surprised to know within a minute or so that air pollution may cause diabetes. Environmental chemicals, and this is very well established in the literature in the world, that endocrine disruptive chemicals like plastics, pesticides, industrial chemicals, and certain industrial byproducts may lead to disruptive, the hormone disruption, and may lead to diabetes and obesity. So let us see how the air pollution causes diabetes. It is one of the remediable environmental trigger, you may know, and the important thing is the particle size. The smallest of these particles, that is aerodynamically diameter less than 2.5 micrometer, that is PM 2.5, are readily inhaled. We never know, when we go out, we inhale these minor particles, and they may cause the endothelial dysfunction, inflammation, and oxidative stress. And let us see what is the pathway. And this is the real pathway. Whenever the air pollution, you inhale the smaller particles, and they may trigger the metabolic derangements inside the body. They either act through the NADPH oxidase, so they trigger most of the MAP kinase pathways, NF-kappa B, AP1, IRF3 in the mitochondria. They may increase to reactive oxygen species, and ultimately, because of these metabolic changes or enzymatic changes, it leads to chronic inflammation and low-grade oxidative stress. And they may cause directly affect the autonomic nervous system balance, and maybe the reasons for increasing reactive oxygen species and reactive nervous system involvement. So ultimately, if you see the lower down, the liver is affected. It may increase to gluconeogenesis, increase lipid depositions, and they may lead to white adipose tissue converted to, that is interrelated, the brown adipose tissues. So they are interrelated. In white adipose tissues, increased inflammation. In brown adipose tissues, there are altered mitochondrial morphological functions and decreases the uncoupling proteins 1. Through the autonomic nervous system, it may affect the insulin resistance in skeletal muscles, endothelial dysfunctions, and plaque disruption. So this is how the whole gamut of metabolic changes occur just by inhaling the simple air particles. So that again, one of the studies clearly suggests to us not only the effects to general population, but gestational diabetes, the pregnancy, if the ladies exposed to these particles less than 2.5, regularly inhaling, that may lead to gestational diabetes as such. Now, my dear friends, I want to emphasize on this particular aspect, the plastics. Plastics are either PFC, the brominated flame retarders, or alkyl phenols, bisphenol A, phthalates. And I'll be highlighting 2 or 3 particles here. The bisphenol A, which is actually present in the plastic bottles. And if this is simple plastic bottles with waters, which we are drinking day and day night. And these plastic bottles, if exposed to half an hour under the sun, they may generate the bisphenol A. And I'll tell you how the bisphenol A actually affects the mechanism. Again, the phthalates, which are actually present in most of the industrial paints and the personal care products and transfusion bags, and they may contaminate food, meat, milk products, etc. So phthalates are also important endocrine disruptive factors. Just a simple news items which was there in the June 2019 in the Hindu, what that says that how much plastics in your weekly diet. And this news item suggests to us, this is a study published. People are ingesting 5 grams of microplastics every week, equivalent to a weight to a credit card. So we are actually involuntarily inhaling the plastic particles and ingesting the plastic particles, equivalent to a credit card every week. This is something very strange. And how this bisphenol A, if we are actually ingesting this, you can understand, I'll not go into the details of these mechanisms, but it may lead to so many effects in the body. Maybe it affects the reproductive system, genetic disorders, connective tissue disorders, neurological disorders, gastrointestinal cancer, and cardiovascular disease. And there are certain studies are there which actually lead to ultimately the obesity and diabetes. Bisphenol A, simple, again, the phthalates, which I told you, which is very commonly present in our day-to-day items. So it may lead to, again, obesity, inflammatory disease, developmental disorders, cancer, and so on. So especially metabolic disorders and obesity, I'll tell just now. And again, a new EDC, which is known as nonylphenol, that also causes so many effects in our body. So before I'll deal with this, how these endocrine disruptive chemicals, EDC, can affect the obesity and diabetes, the exposure to pesticides are again very common. We may indirectly or directly contacting the skin through the inhalation, the skin contacts with the household fly sprays, the coils, mosquito coils in food, water, and drinks, and whatnot. So these pesticides actually ultimately absorbed by, even for the pregnant mothers, this is very important, it crosses the placenta and are taken up by the fetus. So our mothers should be actually free of these environmental chemicals. What is the mechanism of EDC? They disrupt the weight controlling hormones like catecholamines, thyroid, estrogen, testosterone, corticosteroids, insulin, and growth hormone, and leptin. It alters the levels and sensitivity of the neurotransmitters like dopamine, noradrenaline, and serotonin. And that's why they interfere with the metabolic processes, damages the nerves and plastic tissues. And this is very common molecular mechanism. Go the down one, the B, how the endocrine disruptors causes the obesity. Just see here, they are the simple fat sites, that is MSCs. They actually they increases the development of pre-adipocyte, and these pre-adipocyte develops into the mature adipocytes. And this is one of the mechanism, very common mechanism of EDC, which can lead to obesity. Again, if you see here, the metabolic disruption, these are the bisphenol A, phthalates, organoids, dioxins, and PFCs, what they lead to through the different mechanisms, either through PPR gamma mechanism, CAR mechanism, GR mechanism. They causes adipogenesis, increases body weight, and the insulin levels are disrupted. So the clinical pulse for my lecture today is, in this rising pandemic in diabetes and obesity, please think of out of box. There are urban stressors may lead to diabetes and obesity. Living alone, air pollution, financial constraints, and all these things may lead to diabetes and obesity. And what is my take on this particular thing is the coordination of governmental agencies with careful urban planning can reduce this worrisome burden of diabetes, obesity through these environmental toxins like urban stressors, pesticides, plastics, which we are actually inhaling or ingesting involuntary day to day. They may lead to diabetes. And the last I want to say, we have started a project here in Jaipur with the help of medical college. We are actually estimating EDC in urine of most of the general population, and probably soon we'll be having a good data of EDC causing diabetes and obesity. Thank you very much. And sorry.
Thank you, Dr. Gupta. You have very well highlighted about endogenous, that is sleep, noise, and financial constraints, and our environmental like air pollution, environmental toxins like plastics and pesticides. Of course, among pesticides, what I also came to know, along with some amount of trace of plastic inside the PET bottles, some amount of pesticide is mixed to preserve the water or to preserve the soft drink or fruit juices. That pesticide per se is causing beta cell toxicity. That is also another cause for increase in number of diabetics all over the world, because the preservative they are adding to preserve the fluid inside, some amount of pesticide is being added. Do you have any reference or any material on that?
Yeah, we have all the, and there were actually last 2 years back, there was a conference was there in USA on EDC only, and they had the position statement, and I have all the details about how these EDCs, and like you have preservatives and even the tins, the juices tins, the inside wall of the juice tin juices, they actually contains some of the phthalates. So now USA actually banned the bisphenol A. For your kind information, only 2 countries have banned blanket ban on the bisphenol A containing plastics in USA and Canada. Other countries are also thinking of banning these plastics containing bisphenol A, and you just see, you can just have even in your balls and everything, when you are buying the plastics, they are written BPA free. If they are BPA free, means they don't have bisphenol A. But if they are not BPA free, they are dangerous. So even in your household, please don't keep those plastic bottles containing BPA. So this is just with the folded hand, because we have seen this is a very dangerous things.
Yeah, the cause of increase in cancer as well as metabolic disorder, this theory also is getting now propagated, and we all should be very cautious in that, because despite all efforts, cancer and metabolic disorders are keep on increasing all over the world. Right?
Absolutely.
Shall we have discussion afterwards, Dr. Vijay Kumar, after finishing 3 topics?
Yeah, we have 15 minutes space there, so that we can have discussion about with all the 3 speakers. They can
Right. Now we will go to Dr. Krishna Seshadri's presentation. So Krishna Seshadri is known to all of us, not only in Chennai, Tamil Nadu, all over India, and he has become international speaker also recently. Very happy and proud, sir. American Board of Certified Endocrinology and Diabetes Metabolism, Chennai Diabetes and Endocrine Clinic, Clinical and Research Lead Apollo Sugar, Senior Consultant in Apollo Hospital, Visiting Professor Endocrinology and Medical Education, Sri Balaji Hospital, and recipient of P.N. Shaw Oration and Endocrine Society, RSSDI, funded translational research, gut microbiota and inflammation, vitamin D and glucose transport, metabolic abnormalities in PCOS, thyroid nodules and POXO. President, Endocrine Society, Tamil Nadu, Associate Editor of JDDC, Editor-in-Chief of Thyroid Research in Practice, Member, Reconciliation Board, Medical Council of India, UG Expert Group, interest, Chola history, and see, in addition to all our academic activities, he has interest in the non-academic Chola history also. So very happy and proud to introduce you, sir. His topic today is crosstalk between cells, liver, muscle, and fat. Of course, now the crosstalk topic is very well getting internationally. Actually, earlier we used to say hepatorenal syndrome, now cardiorenal, etc. So there are crosstalk between various organs. Of course, one organ is affected, another organ also waiting to get affected, especially in diabetes, because blood goes everywhere, excess sugar also goes everywhere. Some of the organs, it will reveal symptoms. Some of the organs will not reveal symptoms. Some of the organs we pick up by investigation. Some of the organs we may not pick up by investigations. Of course, there is crosstalk between the organs, about which our good friend Dr. Krishna Sethadri is going to talk. Over to you, sir.
Thank you, Dr. Paneerselvam. Thank you so much for the very, very kind words of introduction. I'm actually, the proudest part of my life is being friends with all of you. And it's always a pleasure to be in a program that Dr. Vijay Kumar organizes. It's our own.
You're another friend at Coimbatore also simultaneously organizing today.
Yes, sir. My buddy Balamurugan. So I have to keep a count on what I'm talking where. So very interesting because we have just moved our house, so you may hear a lot of crosstalk in my back. There can be people who are pounding on certain things. I have a hungry crow in the background, which is also doing some crosstalk. So please bear with me. I have no conflicts of interest for this particular talk. It's very interesting, you know, when we look at the ominous octet, you find that sometimes I feel Defronzo underestimated because there are so many more organs and organelles that are involved in the pathophysiology of diabetes. For example, you know, endothelium is probably something that people don't talk about. The bone is something people don't talk about. The macrophage is something that people have begun talking about. What is interesting is that what do I mean by crosstalk? I've been famous for doing crosstalk and interrupting people, but really crosstalk is basically either an endocrine or a paracrine or an intracrine or communication that is sent by an organelle or an organ to a completely unrelated organ and making a change there. And this seems to be a very important way in which metabolic disease occurs. What I'm going to do is I'm just going to give you examples of some interesting crosstalks because, you know, I can take an entire hour and I would have still not finished about the various crosstalks. So for each organ, I will give you some interesting sub-bites. Insulin and glucagon, of course, are the most important crosstalks. And those of you who listened to me this morning, I spoke about alpha cells and how they relate. But just to understand, this is the alpha cell boundary, this is the beta cell boundary. And can you see the number of connecting channels that each of this has? And anything that happens in the alpha cell happens in the beta cell and vice versa. In fact, we know so little about the alpha cell, we know so little about the delta cell that there is so many things that are happening in each of these. For example, look at it here, it is insulin. Insulin has an insulin receptor in the alpha cell, and this actually goes and decreases cyclic AMP and pKa signaling. And then this, at the same time, can you see here, there's a beta adrenergic receptor. The delta cell also has stimulatory effects on the alpha cell. So can you see that it's either a balance, sometimes it's a balance, sometimes it's a predominance of one over the other. Sometimes there are co-modulators that change the response, but there may be particular responses that are all or none. That even if there are multiple positive responses, sometimes one negative response can override all of this. We are just so much beginning to just understand many of this, but it's important to know this also. Let us just again, one more minute spent at the alpha cell. This is insulin secretion by the beta cell. This is glucagon. This is normal. This is normal. Then when the glucose is going up, can you see here? This is the glucose. The insulin goes up, and it's as if like a mirror is kept here. The glucagon goes down. Then the glucose drops, insulin drops, glucagon goes up. This reciprocal reaction is only possible if there is a distinct connection between the alpha and the beta cell. And indeed there is. That the electrovoltaic changes in the beta cell are reproduced in the alpha cell. Indeed, diabetes, as Dr. Roger Unger would say, is as much a disease of glucagon as it is much of insulin. And you'll notice the most important thing that happens in diabetes is the relationship between the alpha and the beta cell is lost. Since this is whole about crosstalks, let me do some examples. One of the things that fat secretes is leptin. Leptin works at the level of the pituitary. Leptin there makes you eat more or less. But leptin also has signals that go directly from the pituitary as well as from leptin itself into the pancreas. Indeed, a few years ago, people were thinking about using leptin as a treatment for type 1 diabetes, right? So this is very important. Leptin seems to have a direct connection as an inhibitory action in the level of the pancreas. And remember, these are different. If it is secreted in a particular way, it causes one reaction. If it is secreted in another way, it causes another reaction. If it is secreted along with something else, it causes a third reaction. So it's actually a very complex thing that we try to oversimplify. Adiponectin, on the other hand, is stimulatory to the pancreas, and we know that adiponectin is a good hormone. Adipsin is a third one that works to something called C3A peptide, and it actually works at the level of the beta cell. Remember that one of the most important ways cells crosstalk with each other is through nutrients. Free fatty acids have an inhibitory effect on the pancreas, right? Palmitate, the most important one of them. But remember that free fatty acids are also stimulants or inhibitants at the level of the brain. Free fatty acids can work at the level of the liver, where they cause insulin resistance. Without free fatty acids in the liver, there is no insulin resistance, isn't it? But what is interesting that we have learned is that it is not just these. The bone itself seems to be an important controller of the pancreas. You would think that the bone is a dead tissue, but it's one of the most active hormonal agents in the body. This is osteocalcin, and osteocalcin stimulates the formation of insulin. But even more interesting, the production of osteocalcin itself is controlled by insulin. In insulin resistance, the bone cycle changes. So that is one of the reasons that while diabetics have a higher bone density, they have greater bone fragility. So just, can you see how complex this is? This is fat cells, leptin. Leptin works at the level of the pituitary. It influences osteocalcin, and osteocalcin production changes insulin secretion. Now I want you to think of millions of such connections that the body deciphers, and an alteration in these connections, an alteration in the signal, how it sends the array. So how the whole disarray occurs in terms of the metabolic markers. It's like a single change creating a bunch of light emitting diodes. That's exactly the signals is. That is why we have so much difficulty in interpreting this data, because we don't know what is the cause and what is the signal. My favorite hormone is glucagon. And can you see that I'm just going to use one of the actions of glucagon. But glucagon's main action is in the liver. But interestingly, one of the things it does is it actually stimulates the production of a hormone called kisspeptin. Those of you who are into endocrinology and who follow puberty, remember kisspeptin is actually mediated by the pituitary, and it is altered by estrogen. How did this come into the pancreas? Nobody knows, but it looks like that the liver is one of the sites where kisspeptin is made, and it's influenced by glucagon. But also remember, it's influenced by estrogen. Of course, there is the intestine. But let me give you another bit to this. Interleukin-6 is inflammatory, right? It can cause suppression of the pancreas. But when you exercise, interleukin-6 increases. That interleukin-6 stimulates the L cells of the intestine, causes it to produce GLP-1. And GLP-1, as you know, works in the level of the pancreas. Very interesting. Macrophages, on the other hand, are stimulated by the adipocytes, and the macrophages can cause so much inflammation in the pancreas. I have done enough and enough talks on inflammation that people think my life is inflammation, which it is. I'm also quite toxic. So remember, I won't spend more time on inflammation. So can you see this bunch of crosstalks? There is an immune system, and I'm not spending time on the immune system. That's a real big type 1 talk, which I can give maybe next year. Remember the brain, the skeletal muscle, the cardiac muscle, which everyone's now talking about, adipose tissue, bone, estrogen, gut, and I haven't talked about a gut microbiota. Remember, gut microbiota can, for example, a gut microbiota change can cause toxins. These toxins can actually work through the L cells of the intestine. They can inhibit or increase GLP-1 production. Thyroid, in thyrotoxicosis or in hypothyroidism, there are changes. And of course, we know a lot about the liver because this is big. A little bit about the endothelium. Remember that endothelium and epithelium are also important. One of the important ways that fibrosis occurs is by what is called mesenchymal transformation at the epithelial level. These are interesting. So this is a summary of it, and I want to move a little forward. So can you see how just the beta cell can be affected by leptin, by free fatty acids, by interleukin, by TNF-alpha, by kispeptin, by adiponectin, by osteocalcin. And I can tell you, this is just the beginning of the story. We haven't heard the end of the story. Just to understand the complexity, I thought I'd put up the slide. It doesn't matter. It's not going to come in the exam tomorrow. Let us take one tissue and maybe that it provides one ligand. Remember, tissues provide multiple hormones or receptors. Let's say it produces one ligand. Can you see what happens if you take an animal provided with a high fat, high sugar diet, and this is adipose tissue all the way up to the skeletal muscle and spleen. See, on day 1, this is the level of interaction. Day 6, how the interaction has changed. And day 14, how the interaction has changed. So this is a dynamic process involving multiple organs, multiple hormones, and the signals can be a sum, it can be additive, it can be subtractive also. And that's why we need more and more techniques, some including machine learning, some including modern techniques to even understand how this is working. To add to this complexity, we now know that one of the great ways that the body takes care of this messaging and doing this crosstalk is not just hormones, but by expressing what are called miRNAs. These are very, very small, non-translatable things that can be inherited. They can be epigenetic modulators, they can be transcription factors, they can be signaling molecules. And what they can do is they can go into the cell and cause biological diseases and metabolic disease. This is just an idea of showing how they can work together, or even one can create a lot of havoc. Another thing that people are talking about is something called extracellular vesicles or exosomes. Now, what seems to happen is every time something is secreted, the body, we know about endosomes, endocytosis, but the body also sends out information in packets that are called exosomes. These could be microvesicles, which have DNA, RNA, etc. This could be virus-like particles like viral DNA and GAG, but there can also be exosomes where RNA is sent, microRNA is sent, G proteins are sent, inflammasomes, which is interferon inflammasomes are sent. For example, in type 1 diabetes, the exosome that is sent out by the beta cell that is being affected is responsible for the antigen production, antigen antibody production. The GAD antibody itself is created because the cell sends out an exosome. These exosomes can go from the pancreas to the liver to the muscle, and they are a bunch of information that travels from the damaged cell. And we now know that these exosomes, and these are all the organs that we know today, that exosomes are probably working. And these are the crosstalk specialists of today. So it looks like these exosomes carry microRNAs, and they actually enhance the change. So this is where I'm going to stop, because this is something that is nascent, that is something that we are just learning about, that this crosstalk that we are hearing is only the beginning of the crosstalk. We are only seeing the WhatsApp of crosstalks. There's a Snapchat. There's a deep dive. There is a underworld of crosstalks that is going on. Ultimately, the cell has mechanisms that puts this together, and each of this is a reaction to one change that happens. Maybe the coffee that I just had, maybe the smile that Dr. Venkatraman has, maybe the smile that Dr. Paneerselvam has. But each of these maybe it is a good thought that a mother has when seeing a photo of Krishna when her baby is in her belly. But each of this has a way of changing, and each of this is a signal. How the body interprets that signal, how does it take and convert it in and responds to it, and how at some point of time it's overwhelmed and it becomes disease, is the real story of crosstalk. And maybe next year I can give you more information. Just thank you very much. I can see Dr. Ramchandran ready. I hope I'm not too much behind time. Thank you so much for having me to speak this.
Thank you so much. Thank you so much, sir. You have very well highlighted about crosstalks of various organs and various cells. It's a new area for many of us. You have gone to the subject in depth and explained in simple way. Very happy, sir. Thank you so much. At the end, we can have discussion. Then Dr. Jayakumar. So next topic, Dr. Vijay.
Yes, sir.
SARS next topic, yeah?
Next topic is Dr. Ramchandran. Yes.
The carb confusion. Hello, Vijay Kumar.
Yeah.
Oh.
Dr. A. Ramchandran.
Yeah. You know, in this program you have given Dr. B. Mohan. Right.
No. I think you are looking at the older. I think we have sent you the new one also. Anyway, I'll tell that Dr. A. Ramchandran sir is going to speak on changing profile of a diabetic, opportunity or challenge. That's when he's going to talk.
Right. Sir, Dr. Ramchandran is very well known internationally, and recently he is selected as one among the top scientists. We are all feeling proud and happy about it, sir. Professor A. Ramchandran is the chairman of Dr. A. Ramchandran Diabetes Hospital and president of India Diabetes Research Foundation, Chennai. He has served as regional editor for Diabetes Medicine Journal, UK, and editorial board member of Diabetes Care. He is current member of editorial board of Journal of Diabetes Research and Clinical Practice. His awards include the Best Investigator Award by World India Diabetes Foundation based in the US, the Thomson Reuters Research Excellence Citation India Award in 2015 in medicine, the prestigious Organization of Pharmaceutical Products of India Healthcare Access Award 2017 for the highest level of contribution in the field of diabetes, healthcare, and Minarani Award from World Community for Prevention of Diabetes 2018 in Edinburgh. We can keep on talking about him for a whole day also. We all very well know about him, his work for more than 40 years in the field of diabetes. He made India proud in the field of diabetes internationally and nationally. Over to Dr. Ramchandran, sir.
Thank you, Pani.
Thank you, sir. Thank you, sir.
And congratulations, Vijay, for another interesting and successful meeting. And nice to see all of you, Venkat, Sesh, Krishna, etc. Krishna, that is a very sweet and nice talk, yes, but sir. I learned a lot of things from that talk. I thought you should have talked for another 20 minutes more. I would have cut my talk. Okay, let me share the screen. I'm just going to talk to you about something called Trends in Diabetes that you see today, which is actually based on 4 papers we published both in 2019 and 2020. A little more on the epidemiology, some new information which probably you have not seen or heard, and also some clinical profiling changes which we published this year actually. So, of course, you know diabetes in India is growing, and this is from the publication that we did in 2010, where we showed that there is exponential rise in the prevalence of diabetes both in the rural and urban population, starting from the first study in Kudramukh and the British Medical Journal publication, where we published 5%, and then it has been going up. A couple of them are national studies, but most of the time we have been actually concentrating on studies in the south. Of course, the ICMR study showed diabetes is prevalent in 7.3% of the population, and 10.3 have pre-diabetes. In fact, they said there's a higher prevalence of pre-diabetes, which has got a lot of implications. But what we find is that it ranges from about 4.3 to 14.6 in Bihar to Punjab. So there's a lot of heterogeneity in the prevalence of diabetes within India. So what I want to concentrate is this part, where we have been doing last 3 decades epidemiological studies. So you will know what is called the trend. We call it the secular trend in the prevalence of diabetes. So we've chosen these 3 places, Chennai, Kanchipuram, and Pandurti. And the reason for choosing these 3 areas is, one actually represents a cosmopolitan city like Chennai, which is about 20% of the population in India. Kanchipuram represents town, which is the 2-tier town, which represents about another 40 to 50% of the population. And Pandurti represents another 60 to 70% of the population. So therefore, it represents urban, semi-urban, and rural populations. This is the publication in Diabetes Care, which was published in March, and it came online in March and came out in sometime in August in Diabetes Care. So what is interesting was that in the city, it went up from 18.6 to almost 22%. In the town, from 16.4 to 20%, and in the village, from 9.2 to 13.4. Now, all of them are significant, of course, with the large numbers. Most important part of this is that the towns are catching up with the cities. So if you call it urban, Kanchipuram and city must be put in one basket. Interestingly, we found that statistically speaking, the increase in the prevalence was not significant in the male population in the urban areas, while it was significant in the female population, in the women. In the village, of course, men and women both had significant rise, 10.4 to 17, 8.80 to 10.1. So that is an interesting finding, which was published last year. So therefore, now we have almost gone up again. Now, the point is that the question that you have to ask now is that, have we reached the peak of the prevalence of diabetes? And from now onwards, we may not have more prevalence, because if all the people who are susceptible and who have the gene to get diabetes all develop diabetes, then you should see a plateau, which is seen in the PMI Indian populations and other populations in the world. So now we wanted to examine what are the reasons for the increase and what are the differences. In fact, if you look at a simple percentage, you find that it is actually significant both in the town and in the village, but not in the city. Now, this is a simple statistical t-test. But if you look at a little more complicated one, which is called the Poisson regression analysis. Now, this has taken into account all the other variables, which I don't want to go into the details. In fact, this particular analysis was done in the Medical Research Council in the University of Cambridge by Stephen Sharp, who is one of the top statisticians. And what he said was that actually, if you look at the PR or prevalence ratio, it is significant only in the town and the village and not in the city, thereby showing that perhaps there is, from this prevalence study, you may say that city is probably plateauing and further increase in the city may or may not be seen. So now we have to look at other signals, but what's going to happen in future. So if you look at the risk factors, see, very interestingly, the BMI has gone up significantly in all the populations. Waist circumference has also increased in all the populations. And of course, the total calorie intake has also gone up. Now, you want to look at which one has actually contributed to the prevalence, increase in prevalence. Then again, you have to go for, now this is the change in the mean BMI. As you can see, city, town, and PUV, all of them shown significant increase. This is the change in waist circumference. So it is not only that people have become more obese, but people also have developed bigger fat, much more fat in their tummy. So their central adiposity also has shown an increase. Now, the analysis showed actually it is the waist circumference increase which has contributed to the increase in the prevalence of diabetes and not the BMI. As you can see here, if you look at the BMI, it's only 1.11 and 1.09, And actually, it was just significant only in the city because of large numbers. But the PR ratio, the prevalence ratio is only very small, 1.09. But look at the waist circumference, 1.2, 1.3, and 1.5. In fact, in the villages, although the BMI is pretty low, the increase in central adiposity was a most important contributing factor for the increasing epidemic of diabetes that you see. Interestingly, if you look at physical activity, both in the urban population, the physical activity was not changing much and not related to diabetes. On the other hand, the PR ratio is 1.36, showing that another important risk factor which has contributed to the increase in the prevalence of diabetes in the rural population is decreased physical activity, especially in women. We found there's an increased hours spent on TV watching. The screen time, especially in women and the rural population, have substantially increased. So this was published in 2019 in March online in Diabetes Care. The other important point also was actually published in Diabetes Care as a letter, and that is what we want to know. Of course, you showed that the prevalence has gone up, and it looks as if it has not significantly gone up, statistically speaking, in the city, but still has gone up both significantly in the last one decade. We're talking about 2006 to 2016. Other signals of future increase or the tsunami of diabetes. So we have to look at two things here. One is trend in pre-diabetes, because if the pre-diabetes is high and going up, then you'll have more diabetes in future. The second thing is incidence, and I'll talk about incidence in a moment. What you can see here is the total prevalence of pre-diabetes, which is a combination of impaired glucose tolerance and IFG together, has gone up significantly high in all the populations. In Chennai, it was 12.4 to 19. In Kanchipuram, from 6.1 to 21, and in Pandoti, 7.8 to 14.6. So this is an indication that we have not come to the peak prevalence of diabetes in any of the populations. Of course, we have split up this into isolated IGT, isolated IFG, and IGT plus IFG for the publication. This shows that there was no difference between male and female, and of course, in both of them, there was actually an increase in pre-diabetes. I'm just going to go with something new, and this is also published as a letter, and the table is published in Diabetes Care last time. Incidence of type 2 diabetes is something new. Now, we have been always talking about prevalence because that is easy to do. Take a sample size of the population in Chennai or in a city, do a screening, you get the prevalence. Now, prevalence is the number of people with diabetes today, while incidence is the number of new people developing diabetes within a year, perhaps in the last year. Prevalence could go up by even increasing incidence as well as by increased lifespan of individual with diabetes with improved care. In other words, when the prevalence goes up, it may be that we are making people with diabetes live longer. We are reducing mortality because it may probably indicate or reflect a better care for diabetes. So in many populations, the prevalence going up may be a good sign. However, the actual risk of diabetes in the population can be judged only by incidence data, which is not available in most of the populations from this part of the world, especially in India and low and middle income countries, because if you want to actually calculate the incidence, you should know the background population to be followed up year by year, looking at the incidence of diabetes and want to look at the mortality. Interestingly, a few advanced countries have recorded stabilization or even decreasing incidence, and I'll show you a couple of examples. Now, we were looking at these two populations in 2006 and 2016, and therefore we could actually look at the changes between these two in the prevalence. Now, how did we look at the incidence? And I want to come to that at one point. Now, interestingly, one of the first countries to show that the incidence has decreased is actually United States. What you can see here is the prevalence on the left-hand side. This is actually published from CDC and is a combination of factors. This is trends in the adjusted degree. In the US population, the incidence and prevalence of diabetes doubled from 1990 to 2008 and plateaued between 2008 and 2012. So what you can see is that the incidence has come down and the prevalence is plateauing, which is a good sign, because in future, there could be a decrease in the prevalence when people with diabetes have die or have mortality because you're not fine. It may be a good reflection of a better public awareness regarding obesity, physical activity, and improved dietary habits, just like what they have seen in the occurrence of coronary artery disease because of decreased smoking. So this is a good sign. The other population which has actually shown a decrease in the incidence is Israel, where also there's a very structured total population healthcare. So what did we do for India? How did we calculate the incidence of incidence of diabetes in the Indian population? Very interesting, and we could do that. What we did was, incidence, of course, are those persons developing diabetes clinically diagnosed within a year period from the population without diabetes from the baseline. In other words, when you do a cross-sectional study in 2016 or 2018, you look at what are the number of people who were new diabetes clinically diagnosed in that last 1 year. And that will be the incidence based on the baseline population who did not have diabetes. So you have to do some jugglery here, because incidence was calculated from cross-sectional survey as a percentage of survey participants with a self-reported history of known diabetes with less than 1 year or just equal to 1 year of duration among the total survey population minus the number of known diabetic cases with more than 1 year of duration of diabetes. Now that is a calculation. Now this calculation has been employed by CDC in the United States, and I took the clue from them how to do that. Now the good point is, it is not only that we have the incidence in 2016, we could go back and look at the data in 2006 and then look at the incidence in 2006. So we have the incidence rates of type 2 diabetes in the three populations in 2 times within 10 years apart, in 2006 and 2016. And that is shown here. The incidence in 2006 in Chennai was 1.5, which increased to 3.8 in 2016. In Kanchipuram, 1.2 to 4.1. And in village, it is 1.4 to 1.7. See how interesting it is. In the incidence rates in the rural population is still low. However, the percentage of increase of the prevalence was the highest there. See what is happening in the urban population. We are still undergoing the epidemic of diabetes because the incidence has gone up from 2006 to 2016. In other words, the risk of diabetes in the populations has increased almost threefold in the last 1 decade in the urban population. And this has got very, very severe implications in future, because it can actually, it's a danger signal that we are going to see more diabetes in future. So just to conclude of what I said about epidemiology, the prevalence of diabetes and pre-diabetes has increased over time in urban and rural populations. Rapid urbanization and changing lifestyle contribute to the increase. And I showed you that specifically increase in central adiposity and physical activity were contributing. While few advanced countries were witnessing decrease or stabilizing the incidence, low and middle income countries such as India is witnessing increasing incidence, showing that the tsunami of diabetes is not over. Okay, then I'm going to finish with a couple of other papers published this year. This is a paper we were looking at the trend in the clinical profile of type 2 diabetes in India, which is from our own center, because we have the electronic medical records, and then we were looking at about 50,000 patients in the last 1 year, from 2009 to 2018 is about 8 years. 10 years, 9 plus 18. What do you find is, this is the age distribution every year. And what you see is that there are more younger people with diabetes over the years, starting from 20.8 in the age group of 30 to 49, going to 26.6. Even below 30, it has gone up from below 1% to 1.4%. So this is a little more because the risk of diabetes is higher, so more younger people are developing diabetes. Or in the cross-sections, there are more younger people with diabetes for you to undergo treatment. And look at the BMI. You have more obese people now. More than 30 BMI, we had only 22% in 2009, but you now have 25%, which is very significant. So you have more obesity, more younger people with diabetes in the diabetes population who are coming for clinical treatment or treatment in your clinic. This shows you the type of therapy. And what you can see is that monotherapy was very low even in 2018. It has actually gone down from 13% to 6.5. But look at the right-hand side. Triple or more therapy has increased substantially from 57% to 73%. So it looks as if treatment of hyperglycemia has become more complex and multi-drug over the last 10 years. Interestingly, this is a very new information. The use of insulin in type 2 diabetes has increased from 21% to 31%. This is Chennai population. Of course, we always have 25 to 30% of population from other parts of India. I think we must also say here that exactly similar increase was seen in another paper which I co-authored with Jonathan Shah in the Southeast Asia. We had 13 countries with more than 150,000 patients over the last 6 years. And we found that the use of insulin has gone up from 20 to 30%. And that is exactly mirrored here in our population. So this is happening almost all parts of Southeast Asia, including India. So more people with type 2 diabetes are requiring or needing or using insulin compared to what it was in 2009. The good news is that there's no big difference in those prevalence of patients with less than 7% of HbA1c. But look at more than 9%, it has substantially come down from 35% to 29%. You must see that these patients are treated by about 9 to 10 diabetologists who are independently treating them. So we do not have a control over them, although there are guidelines to treat. So, but there is probably some good news that with the increased efforts, a reduction of more than 9% of HbA1c is seen, only 29% of patients compared to 35% in 2009. So we can say glycemic control seems to be improving a little. Of course, when you're talking about this may look small, but it is large because the number of people are very high. So it is pretty significant. This is interesting. This is about hypertension. You can see there have been an increased use of ARB from 25% to almost 32%. And there's also increased use of calcium channel blockers. This is an important slide, and that is showing you the use of statins. I was involved in another study called the World Study, Global Study, which we are not just getting published. Again, that was more than 100,000 patients from 8 countries from South America, Eastern Europe. And we have found exactly the same. The use of statins have increased substantially in almost all the populations. 209, we had 36.5% using statin. And now in 2018, we have 55.2, significant. Of course, accordingly, there is also a decrease in the cholesterol and LDL. So it looks as if we are treating cardiovascular risk factors better over the years in our population. The last 2 slides. I think some of you are involved in this. There have been many studies looking at clinical audit and looking at cross-sectional studies, a number of patients attending the clinics in India, and then looking at the mean HbA1c, the mean BMI, etc. Now, these are patients who have been treated by physicians, and then we say that diabetes patients are not under good control. But there is a positive data on clinically diagnosed new diabetic patients who are drug naive. What is the characteristics of patients who are coming to your clinics over, in your clinic population? That is, when do you clinically diagnose people with diabetes in the clinics? In what stage and what are the characteristics? So what we did was we chose 12 centers from 3 southern states, And the subjects were drug naive and represented the clinical profile of newly detected diabetes in clinics from the urban population. Of course, diagnosis was based on WHO and was done by the diabetologist there. We also did this biochemical. And we, of course, we also could compare the data with those from the undiagnosed diabetes in the population from the epidemiology. In other words, we are now first looking at the characteristics of clinically diagnosed patients. So the mean age of onset is 45 and the mean BMI is 25, exactly similar to what you've seen in epidemiological studies. And these are the ways of comparison. And now we are comparing that with the diagnosed during screening. Now, these are the undiagnosed patients who are walking in the population. Now, these are the people who have attended the clinics. So these are patients are drawn from here. The only difference that you find is people have lost weight with hyperglycemia before they actually come in contact with the physician. But in the next slide, show you a little more interesting data. And that is, what is shown here is how late they come to the clinics. The HbA1c, the average HbA1c of patients who are attending the clinics in the southern states is 9.1. And look at this, 68% of them have an HbA1c more than 8%. 45% have an HbA1c more than 9%. So clinically, we are capturing these patients pretty late. Now, on the right-hand side are the undiagnosed patients who are in the population. So if you go and screen them, you may get them at an HbA1c of 8.3, and only 40% will have more than 8. Only 26% will have more than 9. In fact, if you compare that with the US, only 20% of them more than 8% in the US population, because there is a system by which people are screened for diabetes. In other words, what we found in this study was that clinical diagnosis of diabetes is very much delayed. 68% have HbA1c above 8, 45% have above 9, while it is only 22% in the US. Initial treatment itself would need more than single agent. This may be interesting most to the pharmaceutical companies. The late diagnosis has many implications, high possibility of having diabetic complications even at diagnosis, and high risk of increases, high risk of increase if they contact infections such as COVID infections today in this scenario. So to conclude, the tsunami of diabetes is on, and you are seeing increased diabetes, pre-diabetes, and incidence. There is changing pattern in the clinical profile. Major concern is younger patients with diabetes, higher use of multiple drugs. Of course, you need a higher use of insulin. And of course, the good news is that you are treating cardiovascular factors better with more statins and multiple anti-hypertensive drugs. There is considerable delay in clinical diagnosis of diabetes, which is the last study I showed you, where I showed you that 68% of the patients have HbA1c 8 or more, and 45% have more than 9, which is a little an eye-opener. We probably have to do targeted screening of populations at risk in order to diagnose diabetes early in the life or the natural history of diabetes. Thank you.
Oh, thank you so much. As usual, we all enjoyed the talk. So there is various component of epidemiology. Every time you will learn from you, sir. So the latest information is your clinic analysis also, the central analysis. What you have told is correct only. Despite all this effort, like what USA did, when are we going to flatten the curve or bring down the curve? We do not know. Even vascular events are all for the past 7 or 8 years. The CVA, CAD, everything is coming down in USA. But unfortunately, in our country, many young people are every day we come across. Even COVID season, many young people are getting affected. But whatever it is, we are taking all our steps to bring down the incidence, but it is keep on increasing. So our sincere thanks to you, sir. As usual, we enjoyed your talk, sir. Thank you, sir.
Thank you.
Vijay Kumar, now question and answer through chat box. Unmute on.
Dr. Arvind? Arvind Gupta. Good evening to you. So there is one question by Dr. R.H. Lakshmi stating that seafood and diabetes, because seafood are even water bodies in the cities where pollution of the water because of the plastic and other things has been there. And she's asking a question that whether seafood or fish generally is diabetogenic because of the pollution of water.
Yeah. So I think the answer given by Dr. Sheshadri already in the chat box, what I have seen, microplastics are very, very important thing. And these microplastics are presented not only in the seafood and other things, but also in the so many common items which we use day and day night. These microplastics are actually converts into the BPA I told you, and BPA is a very, very dangerous thing. That's why we all ask here during the conferences, in your houses, please keep the steel bottles or give your children the steel bottles instead of the plastic bottles. And also don't keep these plastic bottles in your house. Copper vessels are very, very, they are available, so they are good. The steel bottles can be given to your children. I don't know exactly because there are no studies available as far as seafood is concerned and fish microplastics, but there are some studies which are already published in diabetes care also. This is regarding microplastics. And I told you at the Hindu publication, we are ingesting 5 grams of plastics equivalent to a credit card size per week. So probably this may lead to this BPA and obesity and diabetes.
Sir, Dr. Ramchandran, sir, I have a question, sir.
Go ahead.
So what is your message, sir? Now that you have shown that even the villages, because of the physical activity coming down and visceral adiposis is going up, it's a challenge as well as an opportunity to prevent diabetes in these people. What is your message? So that the doctors who attend would like to spread the message to their patients as well.
Yeah, it is not that easy, but I'll make you refer to, we published the Lancet Commission on 14th of November in Lancet. I don't know how many of you were able to read that. There are good messages in that, and in fact, I'm going to talk about
yes, sir. We read, sir.
All right.
Yeah, Hindu also
So,
is the news.
the answer to the question Vijay Kumar asked is given there because we are given a lot of answers and the gaps that you have, how we go about that, and how we are going to make the stakeholders in charge of that. It is not easy, Vijay Kumar. We cannot just have one answer to your question. We have to work at the governmental level, at the state level, at the population level, at the community level, and at also the doctors level. As for the doctors are concerned, we have suggested 3 things. And first is that we have suggested change in the curriculum, both in MBBS, and then we have told that that should have specialists for this. And we also finally written, please read Lancet Commission. Diabetes should be a specialty separately, which we have been trying to talk about. So the Lancet Commission has written that. And of course, in future, you need a lot of other things like change in urban planning, and people have to be walking more, and change in transport system. So it's a very comprehensive way of looking at that. There's an advocacy to the government. There should be change in food policies by the government. There should be a higher penetration of health insurance. Lots of things have been gone into that. It is not enough. Only the doctor community work on this. The doctor community alone is not that powerful as far as the whole population is concerned. You have to start from school education, right, all to the medical education. And then you have to talk about the health policies, food policy, industrial policy, urban planning, a lot of things. So I don't want to, I'm sorry that I don't want to specifically answer a question, but the answers are multiple.
Yeah, like your COVID pandemic, every department got involved.
Correct.
So like that, it is not threatening the population. So everybody is negligent. Regarding one question to Dr. Arvind.
Yeah.
Regarding pesticide, you can some more highlight you can give. There are some articles saying that pesticides are directly toxic to the beta cells and causing insulin dependent, sometimes type 2 diabetes also. pesticide being consumed as what to say, suicidal tendency. Some of them are consuming, and especially now COVID season, because many pesticide and many sprays are there. The consumption or the inhalation of pesticide is more in the population, and pesticides are present in the foodstuffs also, vegetables, etc., etc. So you can throw much more high lights on pesticide and diabetes.
Yeah, just I want to give an example how this EDC came into the highlight. This was in the America. This is in the Mississippi River, and near the Mississippi River, the staple diet was the basically corn, and the people were consuming corn. There was during some studies, it was found that there was sudden increase in the incidence of diabetes and obesity near the Mississippi River. So the scientists studied the dietary habits and most of the things, why this sudden surge of diabetes and obesity. Ultimately, what they found, there was actually pesticides, specific pesticides were used for the corn during that period, 2 or 3 years period, and the people were consuming actually corn with the pesticides. When this pesticides was actually studied in the rats, and it was found that the people who have the overall weight of the rats were same during this pesticide given to the rats, but what they found, they actually their pancreas, they damaged the most of the pancreas. And one of the studies later on, not during this study, this was published study, what I am telling you, the Mississippi River experiment. Another studies which clearly said that actually it actually changes from brown adipose tissues to white adipose tissues. So obesity is one of the very important side effects of the pesticides. The people who are actually having the indirect inhalation or ingestion of these pesticides, they may have the conversion of brown adipose tissues to white adipose tissues and may lead to obesity. This is, and there are certain mechanisms there I've showed in my presentation through the inflammatory, maybe increase in the inflammation in the liver, it may be increase the gluconeogenesis. So there are, and even in the vasculature, the increased endothelial dysfunction. So whole cardiometabolic derangement occurs with the ingestion and inhalation of pesticides. And just I want to emphasize here also that room sprays, very commonly, which we are very happy to have the room sprays for the fragrance. The aerosol sprays otherwise also, the coils and so many things. We don't know these are they contains harmful toxins.
Correct. Any questions, sir? Yeah, yes, sir. Venkatram, sir.
Yeah, I just want to have a comment. Of course, all the 3 sessions were beautiful, and epidemiology, as usual, Ram, you have taught us a lot. Now, with Krishna's talk, I was just thinking about, I think when Krishna goes to the fundamentals, it's always such a learning experience. Some of them you revise your fundamental knowledge, some of them you learn for the first time. I was extrapolating into the clinical situation. See, the paracrine effect, especially in the older textbooks of endocrinology and diabetes, they used to highlight a lot. See, when you talk about type 1 diabetes mellitus, probably the loss of this paracrine effect, because there are no beta cells, the alpha cells do not react appropriately. The vulnerability to hypoglycemia. That's number 1. Number 2, Krishna, I thought somatostatinoma is a good model to talk about the paracrine effect of the various hormones, because not all of them develop diabetes, but some of them do have features of hyperglucogonemia. They can have polylithiasis. In other words, it's very, very interesting to what extent the stimulatory effect of one hormone on the other, the paracrine, and also what about the inhibitory effect. I think the clinical situations could be, of course, much and more studies on the type 1 diabetes, obesity, as well as the rare condition of somatostatinoma. I think just thinking, loud thinking, and I thought you can share your thoughts on that, because your talk was so stimulating, and it's just a beginning. The understanding is in the nascent period or in the infancy, we need to learn a lot. But extrapolating from the few clinical situations that you can comprehend, I was just trying to extrapolate whatever you talked about in the last few minutes with these three situations, and I just thought I'll initiate some discussion or maybe continue it in some other platform.
I just add one comment. It's very interesting because when you study in vitro cells, right, there's a dispersion of beta and alpha cells. When there's beta cell damage, the alpha cell function is intact when the alpha cell is far away from the beta cell. But let us say you take a donor, unfortunate person who's died in a road traffic accident, and then you take their pancreatic cells and you look at it, and let's say they have diabetes. The alpha cell function is completely different. It is changed. So you know, it is the commune. It is the commune that is important. Just like the somatostatinoma. A somatostatinoma is an abnormal thing, but here you're looking at an alteration in physiology where the beta cell is underfunctioning, right? If the alpha cell is away from it, it functions well, but when it's close to it, doesn't function well. And that's actually one of the most beautiful examples of how crosstalk works in this. I wanted to give different examples, and I didn't want to go too much into alpha cells, but this is exactly what happens. And you're right, Dr. Venkataraman. It just I think the next generation is going to be even more lucky, simply because we were lucky because we moved away from just one hormone to 2 to 3 to 4. Next generation is going to be dealing with miRNAs and exosomes and you know, just the exponents of knowledge. It's a great time to be a diabetologist.
Like your webinar.
Sir, I think we are.
Webinars are more than seminars.
No, Dr. Pannisalam, sir, I think can we close the session?
All three topics we enjoyed. Dr. Adil Gupta as well as Dr. Kishan Sadri and as usual Dr. Ramchandran. I think all participants might have enjoyed the talk very well. So our sincere thanks on behalf of organization, especially our Dr. Vijay Kumar for giving us the opportunity and giving me this opportunity also to share this presentation. Thanks to one and all of you, especially Dr. Venkataraman at the end. He participated and wrote his side news. Thank you.
Sir, Dr. Ramchandran, sir, thank you. Dr. Arvind,
thank you.
Thank you.
Thank you.
And Dr. Krishna ji.
Thank you.
I'll be back.
Okay. We'll go to the next session. It will be chaired by me and as well as Dr. C.R. Anand Moses. Dr. Anand Moses is a well-known person all over the country, not only in Tamil Nadu. He is a former director of Institute of Diabetology from Madras Medical College and Rajiv Gandhi Government General Hospital. He has got about 80 papers published in various journals and is also the formerly Senate member of Dr. MGR Medical University. He's also an important member in the RSSDA national as well as the state chapters actually. So I am Dr. Vijay Kumar, a diabetologist from Chennai. Incidentally happens to be I am the organizing secretary of the 3D meeting. So welcome you all again for this session. And to stay tuned today and tomorrow, all the delegates, and then participate in the discussion and in knowledge sharing. Now we have today the session starts with the session is on basically on insulin. We have my very good friend Dr. Hemant Thakur. Hemant Thakur. He's from Bombay, a very well-known personality and is a diabetologist and a great physician. I always enjoyed my company with him. We used to have a lot of talk with each other. It's very interesting the way he explains everything and all. He's a great speaker. He's attached to Breach Candy, Jaslok, Bhatia, and Reliance HN Hospital. He's a specialist in cardiometabolic disorders and fellow of American College of Physicians in Clinical Endocrinology. Besides being a teacher for postgraduate, DIPNB, he has been the principal investigator for numerous international and national clinical trials. And he also runs his own research center. He's a pioneer for antibiotic stewardship, and under his guidance, the policy was designed in 2009 and released at Bhatia Hospital. He's the founder member of the Preemptive Disease International Forum and the foundation chairman of the South Bombay Physicians Club. He has presented cases of and numerous posters in world conferences that includes ADA, AACE, and so many other things, and has delivered orations and lectures in cardiometabolics, diverse platforms from multiple artists across the globe. He has innumerable publications in index journals and has contributed many chapters to the APA textbook of postgraduate medicine, and is awarded the Giants International Award for his outstanding contribution in the field of medicine. Apart from that, you must have seen him too often on TV when the COVID has started. He has been a voracious, he has been a most sought after on the TV, national TV. He has been given very, very valuable opinions. You must have heard to him on various national channels as well, news channels. But Hemant Thakurji, thank you for joining us, and please go ahead. So you have to unmute. You have to unmute.
Good evening, everybody, and thank you, Dr. Vijay Kumar, for those gracious words. It's an honor to be part of your 3D program, and without wasting much time, I'm going to go to my topic. My topic is on basal insulin, something which is interesting. It's called tackling time in range. And as we all know, time in range is something which is a concept which is new, but is now very well accepted. And what this time in range does to diabetes and how best it is tackled and how best it is put into perfection with newer basal insulins. I'm going to give you first the concept of time in range and its clinical implications. Remember, we have moved from the diabetic triad of A1C, fasting sugar, and PPG, which was the glycemic triad, to hitting a sixer, the glycemic hexad, where in addition to the A1C fasting and post-lunch, there is nocturnal hypoglycemia, and the most important, glycemic variability. And glycemic variability as a concept is something which is emerging as a very important factor in the treatment of diabetes. It refers to the fluctuations in blood glucose levels, both peaks and troughs, because this glycemic variability refers to the within day and day to day, which means intraday and interday variations, and leads to high oxidative stress if it is not properly looked after. So glycemic variability, either intraday or interday, if not tackled, leads to high oxidative stress and leads to increased risk of severe hypoglycemia. If you look at establishing A1C and its control through glycemic variability, you will see that there are many phases of A1C at 7. If you see, it could be a low, it could be a in range, and it could be high as far as time that is spent. So in the first case, you have 58% of the time high, with 18% in range and 24% low. And then you can move to 63% in range, which is what is more or less sought after, or you can be all the time in range. Now, that being the question, if you see all of them have A1Cs of 7, but look at the glycemic variability, look at the peaks and the troughs. You have hypos and you have spikes. You have troughs and you have such high peaks that you're going to have very poor glycemic control as far as variability is concerned. Now, how do you know all these things? And the best way that we have known now is through CGM. CGM has helped us define time in range, what's above, what's below, and what's in range. So we now believe that people with diabetes should spend at least 17 hours a day and more than 17 hours, 70% of their time, in a blood glucose range of 70 to 180, which means 70% of their day should be within 70 to 180. And the aim of this is we have to minimize the excursions above glucose targets, which can be high or very high, 180 to 250, and very high being 250, which is level 1 and level 2 hyperglycemia. More than 17 hours, which is target in glucose range. Excellent. And like I said, 70 to 180, which is the time in range. And at most, you can have less than 1 hour below target glucose range, where level 1 hypo is 54 to 69, and level 2 is very low. So this is the concept of time in range, what's above and what's below. And what are the outcomes if this TIR is not maintained? Retinopathy increases by 64%. If time in range is deranged by a mere 10%, nephropathy risk increases by 40%, neuropathy risk increases by 25%. So initial evidences also show increase in the surrogate markers of macrovascular complications like abnormal carotid intima media thickness. Now, having established and defined what this concept of time in range is and what the clinical implications are, let us look at the recommendations on TIR for different diabetes populations. For type 1 and type 2 diabetes, as we just saw before, it should be about 70% with the defined parameters, which I said. If you look at older and high-risk type 1 or type 2 diabetics, you find that the time in range is brought down from 70% to more than 50%. There's a little more allowance for higher, which is what fits in with our concept that today older patients or high-risk patients, 7 is not heaven, but 7.5 is closer to heaven. The same thing is for the high-risk patients. If you look at pregnancy, especially in type 1 diabetes, they have more or less brought it down and tried to merge it with the traditional norms of type 1 and type 2 diabetes described earlier. And if you see pregnancy with gestational and type 2 diabetes, they want you to be in range for a substantial period of time. So these are the 4 pillars which ATDD 2019 has recommended on time in range. If you look at the ADA 2019 and 2020 highlights on time in range, it says that the time in range is associated with the risk of microvascular complications and can be used for assessment of glycemic control. Additionally, time below target, which is less than 50 and less than 54, or above target more than 180, are useful parameters for re-evaluation of the treatment regimen. So this is extremely important to file, to polish, and then give a final prescription, as was even seen a few weeks ago before ADA 2020 publication. Similar, the ACE highlights and the ACE 2020 highlights on CGM clearly showed that it is a highly recommended for type 2 diabetes in the algorithm and executive summary. And time in range is something which is extremely important in managing type 2 diabetes. How does one address time in range? Best with basal insulin therapy. So all I can give you is food for thought, because most of the food is full of sugar. So let's talk about suboptimal clinical utilization of time in range. As time in range is important yet seldom measured, why not go for treatment solutions which take care of time in range, even though not continuously monitored? So how do we go about this? Because time in range is seldom used in practice, can we look at basal insulins to address glycemic variability and time in range? Why do basal insulins effectively address this glycemic variability? Because they take away the peaks and the troughs. The peaks are caused by glycemic excursions post-meal. And basal insulin glargine effectively controls PPG excursions by hitting the base of fasting. So if the base of fasting is chopped off, basal insulin offers flexibility of using PPG targeting OADs. You can combine the basal insulin with the PPG targeting OADs. What about the troughs? Troughs are caused by hypoglycemia during interprandial period. Lesser risk with glargine versus NPH, and definitely lesser risk with glargine versus premix or co-formulations. So let's look at what do we do. How do second generation basal insulins address glycemic variability and help people to be within range? Look at this euglycemic clamp study, which showed lower variability with glargine 300 versus IDEC 100. It showed that the within day variability of the smooth GIR was significantly lower with glargine 300 versus degludec 100 at the 0.4 units per kilogram per day dose. Again, 20% lesser within interday variability with glargine 300 versus IDEC 100. The type 2 diabetes CGM study for time in range of glargine 300 versus IDEC 100. And it compared the efficacy and safety of these two on glycemic control using CGM. They randomized a crossover of patients, 30 diabetic type 2 patients, once daily on each of them, and CGM for 5 days on each insulin treatment. And they looked at the mean percentage of time within the target glucose range of 70 to 100. That was the efficacy point. And the time below range was markedly lower for glargine 300. And you can see very clearly that since it was markedly lower for glargine 300, it also was lower for all categories of hypoglycemia. Anytime nocturnal and severe was more because the troughs were pronounced with degludec 100 and not with glargine 300. And they did the flash glucose monitoring study where they again compared the two. And how did they find? Again, it was the same randomized crossover study with 24 type 2 diabetic patients on once daily of either of the two. And they showed significantly lower nocturnal hypoglycemia with glargine 300 compared to IDEC. So we have clearly seen that time in range is best addressed amongst all the therapeutic regimens that we have with basal insulin. The newer basal insulins help to address it even better. But the percentage of time in nocturnal hypoglycemia or the troughs are more pronounced with IDEG as compared to glargine 300. So this percentage of time, like I said, in the lows was much low with glargine 300. And if you look at EASD, which recently concluded 2 months ago virtually, they showed the effectiveness and safety of glargine 300 versus IDEC 100 evaluated with CGM in adults with type 1 diabetes in routine clinical practice in Spain, which was the OneCare study using CGM. The study design was switch. You could switch the glargine 300 to the other and IDEG 100 to the others. So the adult type 1 diabetes switched from first generation insulin basal analogs to glargine 300 or IDEC 300 within 24 months. The CGM data was analyzed after maintaining the current treatment for more than 3 months. They looked at the primary endpoint and the secondary endpoints of time above range, time below range, and most important, safety with hypoglycemia. And if you look at the time in range profiles of this study, in the full day period, there was similar TIR, TAR, or TBR profiles between the two. So they were comparable. In the nocturnal night period from midnight to 6, the differences clearly favored glargine 300, both for time in range as well as time above range. So the conclusion was, the one case study showed that in the real world setting in adults with type 1 diabetes, the effectiveness and safety of glargine 300, though it was similar to 100 in those switching from first generation basal insulins. However, more people on glargine 300 remained within target glucose range at night versus IDEG 100. So they were on traditional basal insulins, glargines, and then those traditional basal insulin users split themselves into glargine 300 and IDEG 100, and that's how they did the study. So this showed that the second generation basal insulins, more and over and above the first generation basal insulins, performed better as far as glycemic variability is concerned, as far as time in range is concerned. GV and TIR are associated with increased risk of hypoglycemia and diabetic complications and reduced QOL. As TIR is seldom measured, it is recommended to go for treatment solutions which take care of TIR even though not regularly monitored. Second generation basal insulin demonstrated better GV than other insulin regimens. And amongst the second generation, the pick of the pack was glargine 300. Remember, we have migrated from the triad to the hexad. The hexad talks about hypo, severe hypo, and glycemic variability. But it is glycemic variability really controls the control of A1C, FPG, PPG, and the amount of hypos. So this was the concept of time in range. This is what I wanted to bring about and show today, that time in range is a concept emanating from glycemic variability. To address it, we always had basal insulins, but now to address it better, we have second generation basal insulins, of which glargine 300 shines. Thank you for your attention. And thank you for all the chairpersons and Dr. Vijay Kumar for affording me this time.
Thank you, Dr. Hemanji. As usual, a very lucid and informative talk. You brought in importance of the new concept of TR, which is evolving. And also, if you can see that just improving 10% of time in range can bring down the HbA1c by 0.8%. But you know, how many people can do the CGMS? As Dr. Chitra Selvan was also asking about that. It's a difficult thing. But if without if you can achieve the TIR without hypoglycemia, I think the insulin that can do, that the best insulin, especially insulin, which can provide this benefit in spite of not doing CGMS that often to our patients. You have brought it down very, very nicely, sir. Thank you. Please stay tuned. We'll have some discussion at the end of that.
Now we go on to the next part on intensification of insulin. To talk to on this, we have Dr. Chitra Selvan from Bangalore. She's an associate professor of endocrinology at Ramaya Medical College, Bangalore. And she's obtained her DM endocrinology from IPGM of Kolkata. She has more than 30 publications, national and
volume. Anand, volume is
low, is it?
Yeah.
Yes. Anyway, over to Chitra.
Thank you, Dr. Anand Moses, for that kind introduction. Thank you, Dr. Vijay Kumar, for giving me the honor of the invite and the space today. And I will be following up with Dr. Hemant Thakur's talk, where we'll be talking about intensification of insulin therapy and how to do it simply. The outline of the talk, being sensitive to the fact that we are running a little behind schedule, will be to first understand what intensification is and how we are doing when we're talking about intensification. Why should we even talk about intensification? We just spoke about how basal insulin is the thing to do to initiate insulin therapy. And what are some of the steps that we can take to intensify insulin therapy to get to that HbA1c goal and the time in range as we've now learned, and the options available and a quick summary of how that might pan out to take back to practice in our clinic while we go about caring for individuals with diabetes. So intensification just very simply talks about what do you do when you have a person who's been on the maximum dose of oral agents which are available and who's on basal insulin along with it, and yet the HbA1c is off target. At that point, whatever choice you make to intensify therapy to bring him closer to that glycemic target is what is called as intensification. So the first step where you add basal insulin is probably initiation alone, and this step is called intensification. So you can intensify by adding an injectable GLP-1 receptor agonist, or you can intensify by what is called as basal plus therapy, and we're going to talk about that for some time. Or you can go all the way out and intensify with basal bolus therapy, or use pre-mixed insulin twice a day, or maybe even thrice a day to intensify therapy. But since this talk is about intensification with insulin, we will stick to the last two options that I spoke about. So how well are we doing if we do a survey of individuals? I think the thread has been the same, that there remains a whole lot of things to be done, right from Dr. Ramachandran's talk about how the presenting HbA1c is much higher in India, about how time in range is something, again, where there is scope for improvement. Similarly here, we have up to 65 to 75% individuals who are on basal insulin, who are not attaining their HbA1c target, who need to be intensified, and yet there seems to be some amount of lag or delay. So we spoke about resistance or inertia when it came to initiating insulin. There also seems to be some inertia when we're talking about intensification of insulin therapy as well. And I think I want to take about a minute to talk about why it's important that we talk about this. So when we understand the why, the how of it becomes easy. And all of it stems from the fact that, yes, when we get diagnosed with diabetes, we know that there is some amount of beta cell dysfunction. We've learned that through all the talks which happened this afternoon. But what is important to learn is the fact that the beta cell function, which you started out with at the diagnosis of diabetes, does progressively keep coming down with time. So greater the number of years you've lived with diabetes, lesser the beta cell function, and it just gets worse with time, which means type 2 diabetes is a progressive disorder. Why it might be important to pause and acknowledge it as doctors is so that we anticipate that we have to be on our toes. You can't just start a medication and then be okay that it's going to take care of him. We must know that it is going to get worse in a few days' time, and we need to then move on to the next step to intensify therapy, be it add a second agent or a third agent, or be it add insulin or even intensify insulin therapy. Now, why should we have this conversation with our patients? Because many patients tend to look at their HbA1c values, which are off target, and treat it as it is a personal failure, and they blame themselves for it. And that attitude seems to be holding them back to come back to seek help from us to reach that HbA1c target. So it's important to start this conversation very early in the duration of diabetes itself, so that we are prepped mentally when we reach there. This is a study called the DAWN study, which was done many years ago, but I'm sure the findings are relevant even today. They took a survey of all doctors and nurses and asked them, do you think insulin therapy should be started right away, or do you think it should be delayed? And up to 50% of people who were surveyed did say that it should be delayed until absolutely necessary. And this was a multi-country study, and India tops that list. So all said and done, there seems to be some resistance when it comes to talking about insulin, providing insulin from our end as doctors. And it's important that we stop and pause and acknowledge our own resistance and bias, which might be getting in the way of providing better care for our patients. It's also important to review these stages of changes for any change in life. It could be to exercise, it could be to eat better, it could be to start insulin, right? So we go through phases of pre-contemplation, contemplation, then we prepare for it, and then we do it, and then we maintain it. It's important to understand that it might take time for these changes to happen. And why it might be important is, let us say you have started the patient on basal insulin and HbA1c is about 7.8%. You need to start the conversation that we might need to review the situation at next time. Maybe talk about intensification. Provide the patient enough time to process it and come back, maybe gather information, make peace with it, so that we can effect change, which is what we're trying to get at. And also, I'm trying to fit in some of my own interest here. The language that we use when it comes to insulin also seems to affect the way our patients think about insulin. So if you're going to use insulin as, let us say, a punishment, அடுத்த தடவை உங்க சுகர் கண்ட்ரோல் வரலன்னா இன்சுலின் நிச்சயமா போட வேண்டியதா வரும். That is using it as a punishment, right? In fact, if you flip it around and say, if you're not able to control our sugars by next time, தேவைப்பட்ட இன்சுலின் போட வேண்டியதா வரும். So there we are making insulin an ally, and we're trying to use it for our betterment, and we don't get our patients to hate insulin as much. It doesn't help any of us if our patients hate any injectable therapy for that matter. So the words we choose, the tone we use when we talk about insulin is important. That was completely the art, far away from the science, and I'm going to jump right back into science now, right? So when should we stop titrating basal insulin, and when should we think of intensifying basal therapy or add another insulin to the current existing treatment? If your patient has been on a good dose of basal insulin, which is vaguely defined as 0.5 unit per kg per day, and not attaining HbA1c targets, and his fasting sugars are under control, but his HbA1c is not on target, and if you see that the postprandial excursions are beyond what targets you've set for that particular individual. And this is quite logical because basal insulin predominantly targets fasting sugars and does not have in its pharmacokinetic properties to target postprandial spike at all. So when you've exhausted the potential of basal insulin completely, that's when you need to talk about intensifying insulin therapy. So if you take a look at the relevance of prandial insulin, Dr. Hemant did take us through the relevance of glycemic variability, about how it correlates with worse outcomes, be it microvascular or macrovascular, and we should be doing our bit to bring down these postprandial spikes. So ideally, to bring down all postprandial sugars under control, we eat 3 meals a day, so we must be giving a short-acting bolus insulin with all 3 meals of the day, along with the basal insulin. But anybody who's even tried to initiate basal bolus insulin in OPD practice does understand that it's complex. It involves 4 injections per day. You will definitely need to monitor your sugars quite intensely, and also something which is very difficult to probably get your patient to go on right away, right after basal therapy, simply because you need to set aside a certain time of your day to take care of this per se. The bandwidth it consumes is quite high. Could there be an in-between way which can bring us closer to that HbA1c target, but not be so intense in its requirements? This is what is referred to as basal plus regimen, where along with the basal insulin that the patient is on, you add just 1 bolus insulin with 1 meal of the 3 meals that the patient takes that day. It could be the largest meal or the meal which causes the largest postprandial excursion. So with increased use of continuous glucose monitoring, we have all learned now that one person's postprandial spike right after breakfast might be the highest, although he eats the smallest portion for breakfast, and another patient's post-dinner spike might be highest. So of course, we probably better to use continuous glucose monitoring to try and find out which their largest meal is. But if you use 1 bolus alone, you end up with 2 shots per day and probably a HbA1c which is much better than we started out with. The perfectionist in you might be wondering, but why do this at all? Why can't you just put your patient on basal bolus insulin, which is 4 injections, or at least go to premixed insulin, right? At least that makes sense. Basal plus is not even spoken about in textbooks as much. But practice seems to be different from what the textbooks prescribe. And this is from the ADA 2020 Standards of Medical Care. And right after basal insulin, they do recommend the basal plus therapy or adding only prandial insulin right after insulin. I'm going to zoom in a little bit more. So if you have a patient who's been on more than 0.5 unit per kg of and HbA1c is off target, they do recommend that you add 1 prandial insulin alone, either before the largest meal or the meal which causes the largest postprandial excursion. Start with the low dose, maybe 10% of the basal dose or 4 units just to be sure. Titrate every 2 to 3 days. Of course, titration of bolus insulin a little bit more trickier because depending on the carb content of the meal, the postprandial excursions can vary. Increase by 1 or 2 units and bring it down to the target that you've set for your particular patient, right? And of course, if your patient is not able to reach your HbA1c target with the basal plus therapy, you might then talk about going to basal bolus therapy or even premixed insulin. This is the guideline from RxDI 2019. They also seem to provide a protocol which says either you add 1 prandial insulin or you add another injectable or another OHA if that's available, or you can change to premixed insulin twice daily itself. So we are going to now review the use of both of these options, which is either premixed twice daily or basal therapy with 1 bolus therapy, and see how they pan out when it comes to HbA1c reduction and hypoglycemia risk. So we'll move on to contrasting these 2 therapies and what might be the potential advantages, which patient is likely to do better on basal plus prandial or which patient is likely to do better on premixed therapy. So this is a study which studied exactly that, the Galapagos studies, which looked at individuals who received premixed insulin twice daily versus individuals who received glargine plus 1 dose of glulysin. So the number of injections were 2, but at the end of the day, you see that the HbA1c levels are comparable with no difference in the incidence of hypoglycemia, be it overall or nocturnal, suggesting that maybe it is a viable regimen of insulin therapy that you could potentially practice in your clinic. And this is another trial which tried to look at this, probably added 1 more arm to this, where they went on to say that if on basal plus therapy, there were still postprandial excursions with the other meal, apart from the 1 bolus dose, I might add a 2nd bolus dose or a 3rd bolus dose. And they tried to look at HbA1c at the end of 60 weeks. They did see that as compared to premixed insulin twice daily, glargine plus 1 bolus therapy did better, and glargine plus, of course, 2 or 3 bolus therapy did slightly more better than basal plus therapy itself, with reduced incidence of hypoglycemia and a greater HbA1c reduction. But probably the one key difference between basal plus and premixed insulin is this, that basal plus could probably provide the bridge between basal alone to basal bolus therapy. Because you have already started your patient on the bolus insulin once, so let us say 6 months down the line, you see that the post-lunch values are increasing. It might be easier to get your patient to start a small bolus dose for lunch, along with the bolus dose he's taking for breakfast. Of course, the pens are 2 different pens. It's basal insulin is 1 pen and bolus insulin is another pen, right? So if you're anticipating that your patient is likely to require basal bolus therapy in the near future, then you're more better off probably initiating basal plus. Premixed insulin, of course, the advantage is it's 1 single pen. But of course, the problem is that the mixture of the insulin, be it the short and long acting, comes in a specified ratio, either 30-70 or 25-75 or 50-50, which means that you can't just increase the basal dose without affecting a post-meal hypo, or you can't target a postprandial spike without causing an early morning hypoglycemia. So I think it's a very a key difference between the two regimens which are available for intensifying insulin therapy. And this should be something that you must think about, probably just discuss openly with the patient, and you will be able to kind of understand what works best for that particular patient. So the other aspect is, which meal do I start? Do I start for breakfast? Do I start for the largest meal? So this was a question which was answered by this study called the OPAL study, which did one thing. They identified the largest meal and gave the bolus insulin to half the people for that meal, and they just randomly gave it for breakfast for the other half of the study group. And what they identified was the HbA1c reduction was comparable between the two groups. And also, when you're looking at body weight change, hypoglycemia, all of that was not different between the groups which received their bolus insulin for breakfast or for the main meal per se, suggesting that maybe you can take the time to find out which the largest postprandial excursion is. But if you don't have the time, maybe you can just choose one meal, random meal, which is breakfast, and then go ahead with it. Analogs are probably a better choice for prandial insulin because offers better postprandial control. But of course, regular is also an option which is available. Give it with the largest meal and then maybe titrate up if needed. Of course, we did speak about all of this, that you need to have discussions at every single time, review the options available, talk about how it's important that it is a progressive disease and we might need to intensify therapy as it comes about. And here's my summary. So type 2 diabetes is a progressive disease. There seems to be some resistance within ourselves to insulin, and it's very real, it's very here. Intensification of basal insulin therapy is definitely something that we need to prep for because it's a progressive disease. When do you want to have this conversation? When your patient is not meeting the HbA1c targets after complete titration of insulin and postprandial is high, and keep the conversation going for the same. That's the end. Thank you.
Thank you, Dr. Chitra.
Thank you, sir.
Thank you, Chitra. I think there is one question for you. There is from Dr. Ram Kumar. He wants to know why U300 is better than 100. That is what he is saying. One of you can. I hope you can hear me.
Okay.
Chitra, can you hear me?
No, I will repeat the question. Question. Dr. Chitra, thank you very much. As usual, as a lucid and you finished on time. You finished on time. Thank you. There was a question by Dr. Ram Kumar from Guntur. Basically, probably Dr. Hemant is addressing. You can also answer for that query. He's telling that it is very difficult to control diabetes, both fasting and postprandial blood glucose with basal insulin alone. That's what he feels. That is one thing. And he also asked a question that how U300 is superior. I think the answers have been answered, but still, Dr. Hemant, if you are there, please unmute yourself and answer. And Dr. Chitra also will add to that.
So as we wait for Dr. Hemant, maybe I'll take the first section. In Indians, it's difficult to control sugars with basal insulin alone. Yes, basal insulin does target specifically the fasting plasma glucose. So in the early stages of disease, when there is still some beta cell reserve, basal insulin alone might be enough to bring down your HbA1c under target. But considering it's a progressive disease, we are very likely to need support for the postprandial surge as well. So that is the exact instance where we might need to add basal plus therapy or maybe basal bolus therapy. Dr. Hemant, would you want to take the U300 question?
There is another question regarding time and range. Either Degludec or U300, which one is better? Chitra, you should answer this.
Yes, so Dr. Anand Moses is putting me in a spot. So between U100 and U300.
U300 and Degludec.
Tighter spot. Okay. So there are enough. Overall, it should be looked at as these two basal insulins definitely have a much flatter profile as compared to the basal insulins that we've had all along. So which would translate clinically into lesser incidence of nocturnal hypoglycemia. So I would say the jury is out between these two insulins.
Dr. Chitra, in fact, adding to what you have answered, adding to what Dr. Ramkumar has asked, generally we think that basal insulin can control only fasting blood glucose and it may not be able to control postprandial. That's why he has been thinking about it. One of the things that we need to understand is that if you take a postprandial blood glucose, it is not just the glucose which is absorbed from the gut, from the food. Not only in a fasting state, even in postprandial state, there is hepatic glucose output of 40% of the contribution. Now we know that basal insulin, the hepatic glucose output is very easily and effectively reduced with a small increments of insulin compared to what you can do with postprandial blood glucose. So not only in the fasting, in the postprandial, the hepatic glucose output comes down effectively with insulin, whether it's endogenous or exogenous insulin. I think in that way it will control the postprandial as well. In fact, there are some various Indian studies which have come about 10 years ago. If I remember right, it's IDEC study, where it has been proved that it is able to reduce that is glargine, basal insulin, is able to reduce the both fasting and postprandial blood glucose equally and able to control postprandial as well, along with HbA1c without causing much hypoglycemia. So I think the concept of having hepatic glucose put in the postprandial state also to be considered so that it can, at least in the initial stage, as you said that initially we may be having some good amount of beta cell reserve, and that probably will take care of the postprandial spike because of the elementary glucose absorption as well, probably. I think in that way, I think it can at least initially. And one of the studies is laptop study, which has come out, says that clearly that it is, we can continue, at least they have continued for 3 years. Basal insulin has been effective in getting the HbA1c less than 7 in most of the patients, in laptop study. So the study ended there actually 3 years, and probably we don't, in practice, we see many people continue to be at least even 6-7 years also with basal insulin having a good HbA1c and fasting and postprandial. And other thing is sometimes we may have a problem with postprandial in spite of basal insulin. Patients would not like to have 2 injections. So we can utilize the services of DPP4 inhibitor or even alpha glucosidase once a day so that it can bring down the major postprandial blood spike that can happen. This is what we do in practice. I think to certain extent it may explain like what Dr. Kumar has asked.
Can I add a point?
Yes, sir. Please go ahead.
Yeah. Thank you, Dr. Chitra and Hemant, for excellent presentations. Thoroughly enjoyed it. In fact, we had a meeting yesterday, and then the similar thing was just quickly a couple of points which Ramkumar asked. Now, in fact, there are some studies, Indian data, which Ramchandran shared yesterday, to suggest that if you are able to capture a patient, a patient is available to you soon after 2 or 3 drug failure, which a surrogate could be HbA1c of say around 8 to 8.5, then basal insulin might work alone. On the other hand, if the HbA1c is 9.5, then you know that so much of time has been lost. In that context, probably basal insulin alone may not be sufficient. That is one aspect which we have seen in our practice as well. Number 2, the components of HbA1c. You can have 2 patients with HbA1c of 8.9 with a fasting of say 170, 180 and a PP of say around 280, or another patient with a fasting of say around 220 with a PP of 280. Maybe in the second case, certainly you have to target the fasting first, certainly go aggressive, titrate, and then see to it that probably the introduction of the prandial component can be postponed. Whereas in the first case, with a fasting of around 160 or 170, you know that the fasting pushing to around 110 is not that difficult a job. But the postprandial may not come down from say a 300 to, it will land at 230 to 240. I think this is a clinical discretion which all of us do it. I just thought I'll share this this audience.
Thank you. Thank you, Dr. Hemant, Dr. Chitraji, for your excellent talk and inputs from Dr. Venkatraman. So shall we close the session because we're 10 minutes behind the schedule. Thank you very much. Thank you.
Thank you. Thank you.
Next session.
Sir, inge vaanga sir.
Hello. Yes. We now move on to the next session, that is Jugalbandi, and I have my co-chair with me, Dr. Ramanan, who's a consultant diabetologist at Madras Medical Mission, M Hospital, Chennai. Dr. Ramanan, you are there?
Yes, sir. Yes, sir.
Dr. Ramanan, yes, Dr. Ramanan is there. And as you all know, Jugalbandi is not a debate, actually. It's a dialogue. It's a dialogue between two people to bring out the best in the topics. And the topic we have today is on hypoglycemia, clinical significance and newer insights. We have two speakers today. Can I have the profile of Dr. Binayak Sinha? Yes, Doctor. I'll introduce Dr. Binayak Sinha, and Dr. Ramanan will introduce Dr. Manoj Chawla. He's a consultant endocrinologist trained in the United Kingdom, and is a former consultant diabetologist in UK. And he has a number of papers to his publications, and he's an excellent speaker, one of the most sought after speaker throughout India. I invite Dr. Binayak Sinha. Welcome, sir. Dr. Ramanan, you can introduce Dr. Manoj Chawla.
Hello, Dr. Manoj Chawla, sir. He's a director and consultant diabetologist at Lina Diabetes Care and Mumbai Diabetes Research Center. And he also goes to Asian Heart Institute and Research Center. And he's a founder president of United Diabetes Forum. And apart from this, he's honorary visiting faculty at DY Patil Medical Science, Navy, Mumbai. And he awarded RSSDA Fellowship for the year 2017 and for the Fellowship of Royal College of Physicians, Edinburgh, for the year 2019. And he's also a principal investigator in various global MNC clinical trials for NCEs and devices. I welcome you, sir.
Dr. Binayak, you can start. One of you can start. I think you would have made some arrangements.
Yes, so I think I will start because I am in a worse off position than Manoj Chawla, who's sitting in Goa with such a wonderful background behind him. He's enjoying.
It's a virtual or a real background,
Manoj? A real background, sir. Some people are lucky in this world.
I see.
Dr. Moses, can you see the bikini-clad women and the beard on the side?
Able to, you're blocking. You're blocking everyone.
Okay. So we're going to be talking about hypoglycemia, and this is basically a discussion between Manoj and me. We've got some slides which we will be showing you. It's basically showing you what happens in hypoglycemia, what are the reasons why hypoglycemia takes place, and we will be using some cases to illustrate what goes on in patients with hypoglycemia. And of course, any questions, we will be answering them in real time. And Manoj will be bringing out aspects of the discussion while I'm talking, and I will be talking about Manoj's discussion while he is talking. So this is two patients who I have seen in the last week who I quote, and one of them told me that it spoils my whole day, and the other person said, I have stopped taking medicines. So hypoglycemia is real, hypoglycemia is valid, hypoglycemia is indeed probably the most painful problem that patients with diabetes face, with symptoms which are early symptoms like hunger, tremor, sweating, irritability, dizziness, headache, and palpitations. There might be other problems like difficulty in thinking, speaking, confusion, and this may proceed to seizures and coma. These are the neuroglycopenic symptoms. The first lot are called the adrenergic symptoms. And when this happens in the night, it might be nightmares, this might be wetness of the pillows and the sheets, and tiredness and irritability, and very typically headaches on waking up. There are always, with hypoglycemia, there is always a controversy about what is the level of hypoglycemia. And though there are fixed levels, which I will be coming to in a minute by various August organizations specifying what the level of hypoglycemia should be. But, people feel unwell at higher levels if they have, if they're somebody's used to a blood sugar of 300, you bring down the blood sugar suddenly to 120, the patient might start feeling symptoms of hypoglycemia as their body is used to higher blood glucose levels. And people who have intensively controlled diabetes, people who have been really on top of their diabetes often do not feel their blood sugars going low, well, lower than 70 when they've been used, their body has got used to levels between 70 and 100. So a recent hypoglycemia can cause symptoms of hypoglycemia to occur at lower blood glucose concentrations as well. So these are the consensus levels, less than 70 or 72, whichever is your level that you would like to choose. And this is based on what happens in the blood because of the hormonal changes that take place. So this is insulin secretion stops at roughly about 82 milligrams per deciliter, with glucagon secretion starting at 68. And then, as you can make out, the epinephrine starts off at about 67 with growth hormone, cortisol coming in. And you start getting adrenergic symptoms at roughly about 60 milligrams per deciliter. Once it goes down to 50, you start getting neuroglycopenic symptoms like confusion, slurring of speech. And then if it goes down lower, there is mental disorders, while the liver starts to regulate at about 30, and convulsions and coma are common at 27. Now, these are all ballpark figures. Manoj, I think you'll agree that we can see these kind of findings even at higher levels or lower levels in certain individuals. But this is what happens in the laboratory when you actually look at the glycemic threshold for glucose counter regulation. And what
sorry, if I can just
Yeah,
stop
sure.
you there, and if you go back to the previous slide that you were showing, and going through it, one always wonders these levels that we talk about at which hypoglycemia has been defined, or when insulin secretion is stopping, or when the counter-regulatory hormones are coming in. Would you believe that these studies are largely been done in people without diabetes? And if so, can those levels exactly be the same? So what we refer to as reactive hypoglycemia for somebody who was at 300 and drops to 120. If purely by definition we go in terms of release of counter-regulatory hormones, do we have studies which are showing that what's happening to somebody who was at 300 and dropping to 120 vis-a-vis 70?
Yeah, so that's a difficult. Though I take your point, Manoj, that this is something that we really don't have data on. These are actually laboratory studies which have been done on people who are mainly healthy. The problem remains that it would probably be unethical to kind of do these kind of studies when somebody is inducing a hypoglycemia to that level to try and see what happens, particularly in diabetes patients. So I think that this is the best we have at this point of time to go by.
Mm-hmm. And would you think the levels, again, like today we are aware for RxEvents.co.in also that there are ethnic differences in different kinds of population. For say the Indian population, would the numbers be the same, Vinayak?
Difficult to say because Indians are very insulin resistant, So with this level of insulin resistance, maybe I think Indians probably would be a little bit more sensitive to hypoglycemia because of the resistance to the insulin. And if you get over that and come down to a level where the blood sugars are so low, it might actually lead to more symptoms at a higher level. And that, I think, is all our clinical experiences, isn't it?
Yeah, I'm not sure whether because of insulin resistance or not, but clinically, in terms of the fear component, even the value of below 100 or below 90 for most of the patients would be hypoglycemia, even if it's not technically hypoglycemia.
I agree with you. I totally agree with you on that one. So I'll move on a little bit, and these are the risk factors of hypoglycemia: excessive doses, inadequate food intake, alcohol, excessive exercise, nocturnal high insulin administration at bedtime, and diminished counter-regulatory hormone release and symptomatic response during sleep. I'll not be delving too much in detail in the nocturnal hypoglycemia because, Manoj, as you know, you will be talking in detail about the nocturnal hypoglycemia side of things. But what are the consequences of hypoglycemia amidst a lot of things which might be, risk of dementia, coma, hospitalization? One thing that stands out and is very commonly debated and discussed in many fora is the cardiovascular complications which might arise due to hypoglycemia. And these cardiovascular complications may be due to abnormal cardiac repolarization with QT interval prolongation, increased epinephrine and norepinephrine concentrations, and as we know, increased insulin can lead to hypokalemia. There is a reduced myocardial perfusion with hemodynamic changes which increase the cardiac workload in the work and heart rate. There is increased atherosclerosis and prothrombotic strain, and these have been shown in vitro in multiple studies. These are the mechanistic effects of hypoglycemia. And hypoglycemia is actually a different kind of entity during the day and during the night, because during the night, the sympathoadrenal response is completely blunted. And all this translates into, if you look at this beautiful paper, which was published in 2014, this is the incidence rate of arrhythmias during hypoglycemia compared with euglycemia in daytime and nocturnal periods. Now, if you look during the daytime, only ventricular premature beats are higher if you have hypoglycemia compared to euglycemia. So you can get some ectopics during the day, that's all. But if you look at the night, there is bradycardia, there is atrial ectopics, and there's ventricular premature beats, which again highlights the fact that one of the most interesting areas and one of the most feared areas is hypoglycemia during the night. And Manoj will be talking to you about that. But what I'm trying to highlight out here is that one of the important parts of hypoglycemia is nocturnal hypoglycemia, which is very important. And the other aspect is severe hypoglycemia. And I'll take you through this very interesting paper. This is a meta-analysis by Kaushik Rai. And you look at, sorry, did somebody want to say something? No. So So these are all the big studies, EucoPDS, Proactive, Advanced, VADT, and Accord. And you look at the number of events of coronary heart disease events, and you find that intensive treatment, whereby there was more hypoglycemia, does not have any kind of deleterious effect on the number of events of coronary artery disease. It's just the same. In fact, if you look at it in a little bit of detail, it would seem that no more number of hypoglycemia is associated with better outcomes. But if you look into it in a little bit more of detail in the advanced study, this is just severe hypoglycemia. We're taking aside all hypoglycemias. We are now talking of only severe hypoglycemia. And you look at people who had severe hypoglycemia, and you look at people who did not have severe hypoglycemia. These people had hypoglycemia, but just non-severe hypoglycemia. You find that people who had severe hypoglycemia had increased number of CVD, number of total deaths, microvascular events, macrovascular events. So again, I think what I'm trying to come to and show you is that it is not just nocturnal hypoglycemia, it is severe hypoglycemia, which is dangerous, because as the study from Diabetes Care in 2014 shows you, that macrovascular events, coronary heart disease, and myocardial infarction was statistically significantly high over a 4-year follow-up in patients who had had a single episode of severe hypoglycemia. So one severe hypoglycemia can increase your risk of a myocardial infarction and a coronary event. So again, I think what I'm highlighting to you is not only is nocturnal hypoglycemia important, it is severe hypoglycemia which is important. And again, I will show you these severe hypoglycemic events to the ARIC study, which showed that there was increased risk of coronary artery disease, as you can make out. And if you look at it, there is an increased risk of all-cause mortality, cardiovascular mortality, cancer-related mortality as well, that you see in patients who have had one episode of severe hypoglycemia. And with this severe hypoglycemia comes glycemic variability and nocturnal hypoglycemia. And as you can see, people who have nocturnal hypoglycemia are people who have worsening of the glucose variability curves throughout the day. With that, I will take you on to a patient. This is a gentleman, this is a real life patient, and this is basically trying to advise physicians, advise our colleagues as to what to do when you're faced with patients who have come in with hypoglycemia. And this is a diabetic patient who has had diabetes for 19 years, has osmotic symptoms and weight loss, his A1C is high, he's normotensive, he's started on a premix of 20 and 10, and he's advised to do a SMBG. But he does not buy a glucometer. He rings me, he's having severe hypoglycemia, needing his wife to get him orange juice, etc. repeatedly, and he has been having biscuits and rasgulla and cake and rice, and none of them seems to make him feel better. Now, Manoj,
Can I? Yeah. So I think a couple of interesting things you provoked me to ask. So should the definition of severe hypoglycemia be different in India? Because purely the definition of severe hypoglycemia is where you require third-party assistance. And in India, as you said, our gentleman would be sitting there and fully able to do the needful, and yet who will shout out to his wife to get him a glass of whatever juice or rasagulla. So when he shouts out to his wife or he shouts out to a maid in the house, is that third-party assistance severe hypoglycemia?
well, for lack of anything better, Manoj, we have to go by this, because you see, it's third-party help is the definition is read in such a way that, you know, somebody's handed you a glass of orange juice, so that means it was a severe hypoglycemia.
But this could be it could be pure laziness that I don't want to get up and take it myself, and I'm asking somebody to give it to me.
Which is very possible, but there is no numerical value at which you can define severe hypoglycemia. So severe hypoglycemia, the definition from, of course, this has come from all our Western colleagues, which says that the patient is so incapacitated that he can't take the glucose himself and needs to take help from somebody else to get the glucose for him. And that is probably the only definition we are stuck with at this point of time. Though I totally agree with you that this gentleman, I know him very well. He's been a patient of mine for a long time. He's probably sitting around and ordering his wife to get him biscuits and rasagollas and things like that. But the point is, we don't have any better definition to go by.
True. And the other thing, when it comes to, you know, so I'm sure somewhere we're going to be talking about how to really prevent severe hypoglycemia in terms of management or even hypoglycemia. When we're talking so much about it, are our patients appreciating it? So this gentleman that you're talking about, and I'm sure everybody would have instances, I'm just saying one anecdotal instance, where a patient of mine who was on a premix regular human insulin, and because of hypoglycemia, I suggested that we move to something else, which was of course 3 times more expensive. And the patient just said, you know, doctor, when I get hypoglycemia, I feel that I keep this pouch of sugar in my pocket, which costs me not even 1 rupee. And if it's hypoglycemia, I can manage that with this little sugar that I can ingest. You're asking me to take an insulin, which is 3 times, 4 times the cost. How's that the rationale?
So that is a very short-sighted way of looking at it, you know, and unfortunately, because of the financial constraints that many of us face here in this country, this is something which is very difficult to get away from. But I think a very frank discussion at that point of time that it is not just a question of expense in the term of having a packet of sugar. Severe hypoglycemia or a nocturnal hypoglycemia, which you will be showing and I will be showing, actually translates into more hospitalization. It translates into more cardiac events. It translates into more dementia. And as we all know today, diabetes, though we might deny it and debate this sitting here, there's incredible amount of research showing that the cost of medicines or the cost of monitoring is the least part of the expenses of diabetes. The main expense of diabetes is hospitalization and procedures and complications arising out of diabetes. So those are the things that we've got to start addressing with our patients and explain to them that, yes, this is 1 rupee, but if you get hospitalized into the hospital for a 3-day period with myocardial infarction, you will not only be spending a lot more money, there will be also additional cost of loss of earnings, etc., and the impact it will have on your family. So those things need to be put into perspective again.
So thanks, Vinay. Before we move, there's a question, sorry. There's a question by Dr. Chitra that in case of relative hypoglycemia, how do you manage that?
So I'll come to that, Chitra, in a minute, but I want to finish off talking about Mr. SG, who's 56 years of age, and I'll come back to you, Chitra, I promise you. So this is a very interesting thing, because you see he's been having sweet food and carbohydrates, and he's continued to feel awful. And I think this is a very important thing that we have to counsel our patients about, that when you go hypoglycemic, it is no point having sweet food like rasgulla, which contains so many other things, or a biscuit which contains so many other things. You actually need to have glucose or simple carbohydrates, which is what this patient is missing out on. He needs to have glucose tablets or something like sugar or something like that. Having something like a chocolate, actually the body does not realize that this is a sweet, and it takes a lot of time to break it down. And while in the time that you are breaking it down, the blood sugar is not coming up, and the patient continues to feel very bad. So relative hypoglycemia, Chitra, it's a very important point that you bring up. My suggestion about relative hypoglycemia is for the patients to consume something like a snack rather than having a simple glucose intake. Most of the time, you'll find that you have to counsel the patients that this is going to come in your way and it will slowly go away, because once your blood sugars are better controlled, you will have lesser episodes of this happening, and therefore this will not happen so many times. And eating a small snack, or maybe bringing your meal forward, is probably the best way of addressing the relative hypoglycemia. And this is also a recommendation of American Diabetes Association, which also recommends that if you're taking AGIs, you need to take glucose because nothing else will work. This is something I think is a very important teaching point for most physicians when they're faced with hypoglycemia in patients who are taking acarbose or voglibose or drugs like that.
Can I add something?
Yeah, sure.
Okay. So I think another aspect during relative hypoglycemia would also be an indicator for the clinician to go a little slow. So relative hypoglycemia would typically happen when sugars are dropping, and probably we're using SUs or insulin, and rapidly the sugars are coming down. So it's kind of an indication that take a step back and go a little slow because the patient is having that. And one other aspect in terms of the treatment of hypoglycemia, something that is important clinically, is the fact that patients need to be reminded that once they have an episode of hypoglycemia, even after consuming 15 to 20 grams of glucose, even if the sugars come up on the glucose meter, they are not going to feel well immediately. Very often they're going to take about half an hour to feel well, to get out of that feeling of lightheadedness or feeling low. And that's where they tend to overreact, even if whether they check or they don't check, because they're not feeling well, they feel low, they continue to consume more and more of sugars or carbs, and that's what results from a 50 to 300 or 400 very often.
Mm-hmm. I agree with you, which is why the ADA says that you should recheck after 15 minutes, and if hypoglycemia continues on a numerical basis, do you take more glucose?
True.
And I think it's also important, particularly when people are taking long-acting sulfonylureas, they need to eat something before the next planned meal, maybe some kind of a complex carbohydrate. So we'll go on to our next patient, who's a 71-year-old.
Can we have a comment now, or you want us to interact at the end of the...
No, please interrupt us as
Thank you, Vinayak and Manoj, as usual, brilliant. So I just want to know your reaction for this situation, which I'm sure all of us have faced. We know about the entity of hypoglycemic unawareness. Yeah, we are aware of it.
We are coming to that, Dr. Venkataraman.
No, I'm just telling a comparison. Okay. Other is, people are used to a certain level of hyperglycemia. Even when you, like Manoj pointed out, you try to even bring it slowly, they react very badly. So do not push my sugar below 120 or 130. I will go in for hypo. In other words, is it the mindset, or is it the relative hypoglycemia that is troublesome? Is it the panic associated with the risk of a real hypoglycemia? The small subset of patients, they just prevent you from up-titrating the dose of the medication. However much you explain to them, support them with the SMBG data, still they say, no, doctor, for me, this level is comfortable. Have you come across such situations? If so, what will be the explanation?
I think a large amount of it, is psychological. I'm sure it is a strong entity in people who've been running high blood sugars, and you bring the sugar down rapidly. And as Manoj said very rightly, let's go slow. So going slow is something that I am very much in favor of. But there comes a stage when you see somebody who's continuously having high blood sugars, yet very resistant to increasing the dose of insulin or medications because no doctor, this is fine by me, I don't need to have anything less than this. The risks have to be spelled out, because I don't think relative hypoglycemia lasts for such a long time. Once you're bringing it down, if it's a long period of time, somebody's come down from 300 to 200 and then doesn't want to go below 200, I think it's time to force the issue and say, no, you have to do it, kind of a situation.
So, Dr. Venkataram, I'll just add to what Dr. Benayak has said. One of the other ways of trying to convince, so it's more fear in a lot of patients, it's not even relative hypoglycemia. It's the fear that if you bring it down or you increase the dose of my insulin or meds, I'm going to go. What I've seen working and helping is the use of CGM. So in such patients, doing a CGM, and then of course making sure that there was no hypoglycemia during that period, and then sitting down with the patient and explaining the entire report, showing, look here, this is the lowest, if at all, you've been, which is like 120, 130, you've not really dropped below, helps very often in convincing the need for increasing medications, and they tend to accept that better than just the little SMBG that they'll end up doing. So, yes, Vinay.
So we'll move on to our next patient. This is again a diabetic who's been diagnosed very recently on glimepiride and metformin, cold, clammy, and tachycardic, confused and disoriented. Now remember, he's confused and disoriented, and while he's having a CBG check, he has a convulsion. His CBG is not particularly low, it's 64. So this is the debate that Manoj and I were having a little while ago, that do Indians have more hypoglycemic symptoms at a higher blood sugar level? And also whether those tests which have been done, those studies which have been done mainly in physiological settings, is that something that we can apply to pathological settings? So this is 64. The nurse tries to give him glucose water and he aspirates. So now this is a very important teaching point, that if somebody is having neuroglycopenic symptoms, as in the form of confusion, etc., this person needs to be resuscitated with IV glucose. Oral sugar food is only if the patient is conscious, has no neuroglycopenic symptoms. If the patient is unconscious or neuroglycopenic, the patient will need to have intravenous glucose. And any blood glucose less than 70, it's a very simple algorithm. It's 50% dextrose, 100 minus blood glucose into 0.4. So this is 64. So 100 minus 64 is 36 into 0.4, which roughly comes up to about 12 or 14 milligrams, 14 milliliters of dextrose. So we do not treat these patients with oral carbohydrates. We do not withhold insulin when blood glucose is normal. And of course, this is in patients who are on IV insulin, never try to resuscitate hypoglycemia with oral glucose. And of course, that is a bit of a no-brainer, because somebody would be on IV glucose because they would be very desperately unwell. I'll take you through my third case as well and then hand over to Manoj. This is a widow who lives with a son, 20 years of diabetes, hypertension, proteinuria, macular edema, heart attack, was on insulin, EMPA, and metformin. She's been feeling sweaty and unwell and distressed at 2 to 5 a.m. regularly, keeps candy at bedside, sometimes calls out to her grandson who fetches glucose water. She's commenced a basal bolus insulin just to get her blood sugars under control, and probably given more flexibility, and was listening to Chitra's talk a little while back. She's put onto insulin glargine U300 and a small dose. You see 12,444. She's advised intensive SMBG and advised to take a bedtime snack to try and prevent a nocturnal hypoglycemia. A few days later, the son brings her into A&E. The found collapsed in the kitchen, cold, clammy, and unconscious, a CBG of 36. And this lady clearly went down to 36 throughout the night without realizing, and then woke up in the morning for a snack and completely collapsed. And this is hypoglycemia unawareness, which affects type 1 diabetes mainly, and type 2 diabetes of long duration, particularly people who are older with a longer duration and a lower HbA1c. And a risk of severe hypoglycemia in these patients, particularly because of their unawareness, is 6-fold greater. The spectrum of severity may be reversible, and there is no international consensus on its definition. This is thought to be due to the failure of the counter-regulatory response to hypoglycemia. The brain, when it is exposed to hypoglycemia, does a few things, working on the autonomic nervous system, the letting out norepinephrine and acetylcholine, also letting out cortisol. The liver is doing things to increase the glucose output. The muscle is decreasing the glucose utilization. All these things are happening as a physiological response. But this seems to be blunted in people who have had diabetes for a long time, and their beta cell failure is accompanied by a complete failure of glucagon as well. So because of this, it leads to what we know as HAF, the recurrent hypoglycemia with defective glucose counter regulation and a complete unawareness of hypoglycemia. This, I think I'll stop here, Manoj, and I'll let you take over, because I think this is more your part of the story, where you'll be showing how we assess hypoglycemia and how we use the recent guidelines and recent management tools to manage hypoglycemia. Is that right, Manoj?
No, I think you can go on, Binayak. I just, in fact, wanted to add. So, when we go about hypoglycemia awareness, you showed the reasons or risk factors is long duration. But I have seen one of the risk factors, which you also mentioned, being extremely tight control, especially in some type 1 patients. And we know our type 1 patients, sometimes they could be either extremely negligent or those who are very, very careful, or even to the extent of being obsessed with tight control. So I've had patients who are on the insulin pump, checking continuously CGMs now, and wanting to keep their A1C at 5.6, 5.7, and sitting in front of me, absolutely asymptomatic, and with a blood sugar reading of 35. So to the extent that, you do the reading and you get scared, listen, you're not going out of my clinic because he claims to have come on his motorcycle and so on. But one of the contributory factors is really tight control, extremely tight control, more than just the duration part of it.
Yes, absolutely. I totally agree with you. There are some people, it's like Dr. Venkatraman saying that people resistant to
bringing it down.
Yeah. I actually have a patient of mine who's actually the wife of the professor of surgery in our hospital when I was a medical student. Now, she's quite elderly, and she's had diabetes for 40 plus years. And she has chronic renal disease, and her HbA1c varies between 5.9 and 6.2. And if it ever comes above 6.1 or 6.2, she's on the phone rushing to my clinic saying that, look what will happen to me now. I will need dialysis, and I will need my eyes taking out because of so much of rise of blood sugar. So this is definitely a very strong thing. It's diabetes is something which needs to be managed with the mind as well. So these are the things I think, Manoj, you're going to be talking about. So I'll leave it off out here, and I'll let you have control of the.
Okay, I'll start sharing the screen, and while I'm doing that, I'll answer Dr. Mohan's question about. Yes, I agree, sir, that everybody doesn't have access to CGM. So what is the next best way? It's going to be the use of SMBG. So frequent SMBG that a patient can do is going to be helping us where we don't have access to just a sec to CGM. I'm trying to look for something.
While you're looking,
can I just
take the other question while I'm.
Can I just have a query before Manoj, you sort out your slides?
Please.
Binayak, you nicely gave the algorithm for correction. Now, when a patient goes in for neuroglycemia, he becomes stuporous and then deeply comatose. So the old textbooks of medicine used to say, when a patient is stuporous because of, say, presumed hypoglycemia, the swallowing, the deglutition, the swallowing reflex is the last to be last. So it is worthwhile taking the risk of aspiration and then giving it orally, because sometimes recovery happens, and I have seen this. Anecdotal reports of patients were reported to be unconscious, and then in a panic they mixed the sugar with water or juice and then poured it. The patient has recovered, then they were brought to the hospital. Why I'm making a mention about it is sometimes the time taken by the time the ambulance comes, the patient reaches the OP, and then they give, it could be very, very detrimental to their permanent damage to the central nervous system. So as clinicians, do you think that this time-old suggestion that when a patient is stuporous, of course, it's very difficult for a third person to identify the level of coma, whatever it is, but still it is worthwhile. That's what the old textbooks of medicine used to say.
Dr. Venkatam, if I can just say that, sir.
And give it orally. Yeah.
Sorry,
yeah, please go ahead.
Somebody who's not able to swallow or clearly not in that position. One of the things that is also mentioned in the books and has worked clinically is giving instructions of taking little sugar, putting a little water, making a paste. So yeah, so like paste and then rubbing it on the buccal mucosa. So clearly the absorption from the buccal mucosa is faster, and that in fact has helped a lot of them, revive or recover from the hypoglycemia. So that's something which we normally advise the type 1 patients or their families and parents to take care of that. But sometimes even in the elderly on insulin, that could be useful.
In the West, actually, there are tubes available which you can just squeeze into the mouth.
Here also, Vinayak, there are now glucose gels available.
What about glucagon injections?
Glucagon injections can be used. The problem with glucagon is I personally have used a lot of glucagon injections. First of all, the problem is glucagon is only for insulin dependent diabetes.
Dependent type 1.
It's not really going to work in type 2 or particularly in patients on oral hypoglycemic. So that is the MSD used to make it, or Novo used to make it. Novo used to make it, and their kind of sell by date is something like 1 month, and it's pretty expensive. So it's not worthwhile asking patients to buy a lot of glucagon injections, keeping them in the fridge, and most of them would actually go out of date, and people would feel that this is a huge waste of money. And then I think Novo took it off the market as well. I think that is what happened.
Lilly has an intranasal glucagon under development. Again, once it gets available, one will have to decide the cost effectiveness of and the shelf life, of course.
The shelf life is a big problem. I'll just answer
have
one
some
question.
glucagon spray. I mean, glucose spray. The buccal cavity instead of rubbing a spray.
Yeah, that's what Dr.
Dr.
Anand Moses. That's what Manoj was talking about.
Yes. There is some glucose sprays are available in the market.
There is a very
25% glucose spray which you can spray in the buccal cavity.
Okay. So there's this very question from Dr. Mohan: is that any study about long-term diabetes brain atrophy is possibly vascular and hypoglycemia awareness? I had shown you this data on the cardiovascular events from this Edinburgh group, which showed that there is an increased risk of myocardial infarction and coronary artery disease events. In fact, they have a similar kind of study which showed an increased risk of cognitive impairment and increased risk of dementia. Atrophy. It's the same paper. I think this was also in Diabetes Care in 2015 or 2016. So it's a very interesting paper. It's a randomized control trial from the Edinburgh group. So you might want to look that up, Dr. Mohan. So Manoj, I'll let you get on with it.
We have another 5 minutes, Manoj.
Oh dear.
Maybe another 7 minutes.
Sir,
you have enough time in Goa. You can.
Sir?
No, okay. Whenever you want me to stop, we'll stop, Dr. Moses. Not an issue.
Sir, Vinayak, sir, one question, sir.
Let Manoj speak, otherwise he'll be upset.
No. Please go ahead. I think we're having good discussion. That's what is important. Dr. Ramanan, go ahead.
You can go ahead, Ramanan.
Sir, actually, in my experience, what I feel, the reactive hypoglycemia is more common in long-standing uncontrolled diabetes who are on SUs than gliptins. What is your take on that, sir?
Well, I think this very yes. What you've said is very correct. There's gliptins. The rates of hypoglycemia with gliptins is very, very low. I think it's very low with gliptins, and
it's definitely a weak hypoglycemic agent when compared to a sulfonylurea.
Even the reactive hypoglycemia, the symptoms also is not seen with the patient who are on gliptins.
I would agree with you. I think that as a hypoglycemia thing, it's very, very low, very low.
Yes, Manoj.
Okay. So I think I'll stick to nocturnal hypoglycemia and finish by 6:30 the given time, unless you need to buy time. We'll stop earlier. So what exactly is nocturnal hypoglycemia? As defined as something which occurs during sleep. It disrupts the sleep quality and quantity and the next day functioning, affects many more with type 1, 16% with type 2, and about 50% of all severe hypoglycemic episodes. So Binayak was talking about that it's not only nocturnal, but severe hypoglycemia, which if you do sub-analysis of advanced or even accord for that matter, which is shown to be detrimental, well, 50% of severe hypoglycemia seems to be happening at night. So the combination of severe and nocturnal is a huge issue. Pathophysiology is from relative and absolute insulin excess and compromised physiological defenses, which is the compromised counter-regulatory hormone response. And the reasons for nocturnal are insulin levels do not decrease, the glucagon levels do not increase, and increase in the epinephrine level, which is attenuated or decreased. So all those protective mechanisms are gone. Pathophysiology of nocturnal, previous episodes of hypoglycemia may lead to nocturnal CNS adaptation leading to decreased sympathadrenal response, and of course what we spoke about, impaired awareness of hypoglycemia or hypoglycemia unawareness. The consequences: disruption of sleep, impact on the daytime events. Obviously, nocturnal hypoglycemia leads to the next day's decreased work productivity, possible absenteeism and lack of productivity. Long-term impacts of poor concentration, again, linkage with dementia and cognitive dysfunction, and of course, the economic impact of missing work, etc. Binayak has already shown this. This is impact of hypoglycemia in general, more so with nocturnal. Consequences, anxiety, loss of vitality has been reported. So that's another contributory thing towards ED. Physical injury because of falls, etc. during the night period, poor quality of life. Hypoglycemia is a 24-hour concern. So it's not just in the night. You will have issues that you're going to take over to the next day or experiencing a severe nocturnal hypoglycemia. In fact, and Binayak can come in here, and then everybody here, in fact, who's listening in, and that when we talk about initiating insulin in our patients, the biggest worry or the question that comes to the mind that they would ask us, especially when we started using basal insulins and we said, let's give it at night, and that's the standard way of taking. The first question or the biggest scare for patients is, will my sugars drop when I'm asleep? Will I die? Sometimes it's an exaggerated thing, ki raat mein hi low sugar okay, will I die? Will I never wake up? So isn't that the commonest fear that we come across?
It's so true, and and maybe it's not really uncalled for, because see, there's the hypoglycemia in the night can be, if you just think of a little old lady lying in her bed alone with no help nearby and waking up suddenly feeling weak or sweaty, with a headache and feeling shaky and not having access to any kind of thing. And which is why I think it has led to this development of this aphorism of, start low and go very, very slow. And I think that is probably the best way we can tackle this. But I totally agree that this is a very common thing that patients come up with, and be realistically so.
Sure. So the levels of hypoglycemia that we talk about, level 1 is when the sugars are going less than 70. Level 2 is when it's going less than 54. And level 3 is severe hypoglycemia, which I think we've discussed the definition, and whether in India we should be changing the definition of severe hypoglycemia in future. Now, this is an interesting part which I want to discuss, which is about what exactly is the nocturnal window. Davis and all have said it's an episode occurring between evening injection and breakfast. Diamond and all have said episode between bedtime and breakfast. Eposito has mentioned between bedtime and getting up in the morning or being awake. Some others have mentioned 11 p.m. to 8 a.m. and Rosenstock and all have mentioned between evening injection and getting up. So there was huge heterogeneity and disparity. We of course are aware that in the more recent studies, especially for the newer basal insulin analogs, the switch, addition, begin, bright trials, they've all used the nocturnal period as between 12 a.m. and 5:59 or 6 in the morning. So that 6-hour window, but there is not the final word. And there are reasons why when you look between 12 and 6, there are different aspects. The early part of the sleep is where 30 to 40% of nocturnal hypoglycemia occurs. A bedtime snack can help prevent sugars between 12 and 3 going down. In the latter part, from 3 to 6 is the REM sleep. 60 to 70% of nocturnal hypoglycemia really happens here, and the bedtime snack is not going to be effective. So the milk and biscuits that we talk about will help more from the 12 to 3 period, but not much in the 3 to 6. And that's why this period of 12 to 6 has been used in these trials. Well, tools to capture questionnaires, history taking, SMBG and CGM are the tools. These are some of the questionnaires to mention, and these are the means of evaluating the hypoglycemia awareness. So there were some questions in the chat box on the same. You have the Gold and Clark methods, and then you have HypoAQ, which is a 33-item questionnaire, which is one of the best ways of actually trying to assess the presence of hypoglycemia awareness. The RSSDI and ESPAD guidelines have also mentioned when to really suspect nocturnal hypoglycemia, when there is nighttime sweating, hunger, anxiety, nightmares, early morning headaches. I think these are some very important symptoms that we should be asking, or if the patient complains, start suspecting hypoglycemia and start looking at finding it out. Agreed, and a lot of questions and comments that CGM is not affordable or possible. Please, that's where we continue to do SMBG or 2 or a 3 AM and SMBG. So prevention and management of hypoglycemia has been mentioned in terms of the things to be done. I think Binayak has spoken about whether it's reduction of insulin or bedtime snack or more required monitoring, limited alcohol intake, looking at the kind of medications and insulin the patients are on. And of course, some amount of counseling and education to the patients who are who are experiencing hypoglycemia and who are where the treatment is being intensified. You require counseling for these patients. There are means of medical nutrition and injection therapies. Let me just get down to the aspects of what needs to be done. One is change the targets where there is hypoglycemia and nocturnal hypoglycemia. You need to take a step back. Don't be aggressive with your goals. Start looking at goals of 7.5 and 8 in a lot of patients who are experiencing hypoglycemia, especially nocturnal hypoglycemia. You will decrease the bedtime prandial and some amount of basal insulin. That's what the RSSDI ESI 2020 recommendations are talking about. And finally, let me conclude so that we have a minute of comment from Binayak and others about that nocturnal hypoglycemia is an interesting and important aspect of the overall hypoglycemia. In fact, there was an expert group recommendations meeting on 7th October, and that manuscript is work in progress. And hopefully, we will start focusing more on nocturnal hypoglycemia and means to prevent it, along with prevention of hypoglycemia in general. We on our part, in fact, celebrated just yesterday, 20th November, as World Hypoglycemia Awareness Day. As part of the United Diabetes Forum initiative, we've been doing it for last few years. 20th November, because that happens to be the birthday of Dr. James Collett, the co-discoverer of insulin, who, to his credit, has the first description of the phenomenon of hypoglycemia during his experiments on the rabbit by injection of the purified pancreatic extract. So with that, I'll stop sharing.
Thank you, Manoj. And before we end, one final question to Binayak. One question. Hypoglycemia during pregnancy. At CGMS, I found people with 30-40 without any symptoms. Pregnancy. Women during pregnancy tolerate hypoglycemia better. And any comments on that?
Sir, I think that is very well known.
Yes.
A common thing is the glycemic load of pregnant women is much higher because the baby is exposed to almost twice the amount of glucose that the mother is. So if the patient has a blood sugar of 60, so the baby is probably being exposed to a blood glucose of about 120. So
you mean you need not worry much about it?
I'm sure we have to worry about it. I think that's why we should set our targets. We know we have.
But I've seen people with 30-40 without any symptoms.
It is dangerous, and I am always loath to, though I appreciate the need for up titration of insulin during pregnancy to a very large extent, but I get very careful when the blood sugars, particularly pre-meals, are starting to be in the 80s and 70s. I start getting very careful. I start pulling back.
Completely agree. I think, Dr. Moses, these are the places where we need to remind ourselves not to get obsessed by that aggressive control in pregnancy and start taking a step back. So.
Yes. You know, and
the nocturnal hypoglycemia is more common in acute hepatitis patient and also in patient with liver cirrhosis.
So I think clearly when the glycogen storage or any of the hepatic function is going to be altered, that's going to be a problem.
Vijay Kumar, you can find.
Have any come across? Yes, sir. Venkatraman. Unmute yourself, sir.
Dr. Venkatraman wanted to say something. Unmute yourself.
Unmute yourself, sir.
Venkatraman, unmute yourself. Venkatraman.
If you happen to do your blood sugar in non-diabetic pregnant subjects, you see values of around 58, 60 and all occurring at all. In other words, the capacity to withstand the so-called levels of hypoglycemia in pregnancy, somehow I think it's a physiological adaptation. Of course, when it comes to manipulation with insulin or other agents, certainly you have to react, but we can rest assured that the system, I think the physiology of the pregnancy is in such a way, they are in a way able to adapt themselves to change, to drastic reductions of the blood sugar, which we'll deem it as absolutely dangerous. I just thought an observation I'll share in this one.
Vijay Kumar, GVK.
Thank you, Dr. Binayak and Dr. Manoj. As usual, it's a wonderful discussion we had. Are you able to hear me?
Yes, of course.
Okay.
And
other thing is that, you know, as our logo says, that discussion, dialogues and discussion, it's a very nice one. Before we close, there's one chat question also you can answer.
Dr. Vijay Kumar, you muted yourself.
Which question do you want us to answer, Dr. GVK?
Sir, Vinayak sir, one more question, sir. Have you come across anything correlation between hypoglycemia and hyponatremia? Because in
oh yes, this is not uncommon at all, because you see a lot of the times there is an effort to try and, you know, thinking that this is dehydration. People try and put a lot of water into the body, particularly, and you know that this might be a combination of polypharmacy, and of course we have to keep in mind things like hypoadrenalism, which is something which might be precipitating hypoglycemia.
Yeah, patients with hyponatremia, they are highly sensitive to insulin. In fact, when a patient is in hypo, you'll always find out that you require less amount of insulin. Of course, associated nausea and vomiting will preclude him to have a good diet. But in spite of that, my observation is, I think even the literature suggests that they are highly sensitive to insulin when there is hyponatremia.
That's a very strong point you make, actually, Dr. Venkatraman.
Now, can I ask a question?
Sir, it is your conference.
UKPD has told us how to treat diabetes, and Akkad told us how not to treat diabetes, right?
Yeah.
And you know, though it's a negative study, we have learned a lot of things from Akkad trial because of hypoglycemia. A lot of morbidity and mortality has happened. Now, if you look into the cross-section analysis of Akkad trial, it has shown that those people who have been very resistant to getting under control, those who had for a long time very high blood glucose levels, in Akkad trial, there is not protocol, but only thing they said was within 6 months you bring down the blood sugar, hook or crook. And those people who have not been at a very good control for years together, when they were brought down to hypoglycemia, to normal and low sugars at a very short period, these are the people who went into morbidity.
Yes.
Now, this is, I think a practitioner should also look into that, bring that blood glucose slowly in such people. It is always better to do that. You know, this is one of the things. And they also suggested that what is called as that.
Hello.
We lost you there, Dr. GVK.
Lost you, Dr. Vijay Kumar.
Hypoglycemia preconditioning. Are you able to hear me?
Yes, now we can hear you.
Yeah, hypoglycemia preconditioning. You know, the Akkad trial, cross-sectional said that hypoglycemia preconditioning, something like ischemic preconditioning we talk. What is your take on that?
So there's, Manoj, do you want to take it or shall I take it?
No, go ahead, Vinay.
So there's been animal data, if you look at it, animal data is actually fascinating with preconditioning. You find that in mice, if you've exposed the mice to hypoglycemia, thereafter, if you give them hypoglycemia, they respond much better to any kind of cognitive testing and things like that. And in humans, as far as...
Thank you, both the speakers, for If someone is talking, Vijay Kumar, Vijay, I got instructions from the organizing secretary. The other two speakers are waiting.
No. So essentially, there is data to support that preconditioning probably does that. Dr. Moses, let's take
Actually,
you.
Matthew Riddle's hypothesis
Yes,
to account
that's the
for
paper.
people who have not been exposed to hypo, once they have a severe hypo, it is Riddle's hypothesis that
Yes.
Something similar to ischemic preconditioning, hypoglycemic preconditioning. I think it's a good point. Yeah.
Yes.
So, well, at the end, let us thank the organizers. I'm thanking on behalf of Binayak for taking this topic because it's not a commercial topic, and hence hypoglycemia very often doesn't get center stage. So thank you for this Jugalbandi on hypoglycemia.
The background glue is waiting for you.
Absolutely. Thank you so much.
Have a drink on me, Manoj. You guys have fun.
Sure. Thanks.
Bye.
Thank you, guys.
Vijay Kumar and myself are in a hotel, so we are going to 9 o'clock this hour.
Bye.
Time.
Hi, Dr. Jyoti. Hi, Piyush. Bye-bye. Bye, everyone. Bye, Dr. Venkataraman.
Now we go on to the next session that is on contemporary topics. There is a small change in the chairpersons. Dr. Krishna Sheshadri is not here now. So Dr. Venkataraman, can you take up the chairperson post?
Sure. Certainly. Why not?
You can take up now.
Thank you. I think Anand, Krishna, and I should thank GVK for giving us this huge opportunity to be part of the scientific committee and then incorporating our some inputs which are molded into a Paka program, which all of us are enjoying. Thanks, Vijay, and congratulations. And in this session, what I thought was I'll just give a prelude to the couple of topics which are going to be given by Piyush and Jyoti. So I think if you look at the combination therapy diagnosis very early, maybe about almost 2011 or 12, AAC was the first international guideline to suggest that once the HbA1c at baseline at diagnosis more than 7.5, you should think of a combination therapy. At that point of time, I think we are all slightly skeptical about such a recommendation itself. Even though the DP4 inhibitors and Metformin was available, at that point of time, we thought it could be captured with a single molecule. Why about a combination therapy? Now I think the verified trial has given the answer for that, and the guidelines have gained impetus and strengthened by this data. And number two, the second topic is going to be on technology. I think who else can talk about it except in Jyoti? Because when you talk about technology, technology has a role in treatment, monitoring, as well as in education. I'm sure it is a huge topic. Now, at this point, I'll stop and then I'll request Dr. Pichumani and Kannan to introduce both the speakers and probably a word about the topic in sequence so that I can come back in the end and then we can have a discussion. So I request a co-chairpersons Pichumani and Kannan to introduce one speaker after the other and also the topic.
Thank you, sir. Respected teachers and respected mentors and dear organizing committee and dear my friends. At the outset, I would like to thank my mentor, Dr. GVK sir, for giving the great opportunity. Today, the speech is on this one contemporary topic. It's a very important topic for the practicing physician and upcoming diabetologist. Why this important topic? Because we are discussing, we're going to discuss on the yearly combination therapy. See, in the UK, it is already mentioned about the at the diagnosis of diabetes, almost 50% of the beta cell have been eroded. So, in our clinic, if you see a new diabetic patient, almost the new diabetic patient will almost gone for 50% of the beta cell exhaustion. And so we are starting with the metformin, the lifestyle modification. Unnecessarily, we will delay the treatment pattern itself. So what the UKPD states that go for the early combination, early intensive therapy that will improve the glycemic legacy and also very good metabolic memory. And therefore, this rewinds the UKPD's hypothesis as well as the verified trial hypothesis. To detail about this, we have the excellent speaker, Dr. Piyush Desai from Surat. He is a young and dynamic endocrinologist. He is the active member of prestigious American Association of Clinical Endocrinology, so-called as AACE, and is a great academician and researcher. And he did research on prevalence of metabolic syndrome in Western region by March 2008. He published many articles, including the hypothesis on autoimmune hypoglycemia by 2012. He is a great orator and delivered many scientific talks in many local and state level and national level CM and conferences, and is going to shower and render the academic first piece on combining drugs at the diagnosis. Welcome you, sir.
Yeah, thank you. And I will not take much time to start the lecture because I think we are already delayed by a few minutes. So is it visible? Slides are visible properly?
Yes.
Yeah. So good evening to all, and very well introduction to the topic that UKPDS has shown us how to use metformin first, but at the same time, ACE, American Association of Clinical Endocrinologists guideline, were the first to say we can use combination therapy as far as guideline is concerned. Because as a clinician, especially in India, we are happy. We are always welcoming combination therapy, not for diabetes, for everything, malaria, TB, hypertension, everywhere. Even we are using telmisartan with amlodipine combination far more for last few many years than Caucasian population or Western countries. But when we are talking about diabetes, and as far as complications of diabetes concerned, there are macrovascular and macrovascular complications where genetics are also important, blood pressure is also important, and glucose is also important. But along with glucose, it is not always glucose. It is about inflammation, it is about insulin resistance, and it is about maintaining all other parameters, and that is ABC, even cholesterol, even body mass index, even age factor, which is also contributing, some modifiable factor like smoking and smoking, alcohol intake, which also to be addressed. And as far as natural history of type 2 diabetes is concerned, it is never a single cause. It is insulin resistance which starts with, and it remains at the plateau for rest of the life. Then there is insulin production which is also compromised initially. But after few years, it starts even going down. And what happens that initially lifestyle will work. Initially metformin, glucagon will work where insulin resistance is the cause. But when beta cells start dysfunctioning, you need secretagogue like SU or DPP4 inhibitor or even GLP-1 analog, and ultimately you need insulin. But when you are taking this one by one therapy, sensitizer, then secretagogue and insulin from at the last, we are missing very important drugs. I will say 5 years back when we were talking about which is the best therapy in diabetes, there was only one answer: insulin therapy. But if somebody asks me which is the best therapy in diabetes, today we have very good two therapy in form of GLP-1 receptor agonist and SGLT2 inhibitor, which not only lowers glucose, but they are beneficial to cardiac and renal risk reduction also, which even insulin does not cause. So every drug is now having their appropriate place. So if beta cell dysfunction is there, even in beta cell pancreas, that is alpha cell, which is also contributing in form of hyperglucagonemia or increased glucagon secretion. So there are few drugs like GLP-1 and DPP4 which acts on alpha cell also. Sulfonylurea acts only on beta cell. We have SGLT2 inhibitor which mainly acts on kidney, but now we know that it is having action on heart also directly, irrespective to glycemic control. Well, glucagon is more active on adipose tissue as well as peripheral resistance and less action on liver. Metformin is having more action on liver and hepatic blood glucose output in comparison to peripheral tissue. GLP-1 analog to some extent work on gastric emptying also, but here alpha glucosidase inhibitors are also there, and only GLP-1 analog is having action on neurotransmitter. Yes, bromocriptine is having, but it is not much accepted as a routine anti-diabetic medicine. So when we are talking about combination therapy, why combination therapy, that I will come later, but when you are talking about combination therapy, you have to weigh efficacy. You have to weigh the hypoglycemia risk, weight gain is there, which is more than others. That also important. At the same time, cost of therapy. If you are adding SGLT2 inhibitor to a metformin therapy as a combination therapy, definitely it is increasing the cost considerably. So all things you have to think of. But on the other side, how the HbA1c, how high the HbA1c is, and what is the target. From HbA1c 11, if you are targeting 7, then you need combination therapy. If HbA1c is 7.5 to HbA1c 7, then no, you need not to go for combination therapy. Metformin alone is important. But at the same time, age and duration of diabetes is also important, because early age, with short duration of diabetes, people will respond better to initial line of treatment, which later on, patient after 5 years or 10 years of therapy, they need multiple. So when we are talking about combination therapy, always think in that way, that one therapy should target insulin resistance, the other therapy should work in a different way, especially if it is improving beta cell function, or if it is reducing the renal glucose output, and thereby the combination therapy over and above of monotherapy, we can have another additional 0.5 to 1% of reduction by using combination therapy early. And what is the routine HbA1c in India? It is around 8.2 to 8.9. And when it is reached with metformin monotherapy, only it is 25% of will be controlled. So they actually need combination therapy. Even the UKPDS, who has shown us how to treat diabetes, you can see after 3 years, half of the patients were on combination therapy. And at 9 years, 3/4 of the patients were on combination therapy. And when we are talking about the goal, the overall routine goal usually remains at 7, but it is not 7 for each and every patient. This is sometimes 6, 6.5, or even less than 6 as per the patient age. But ADOPT trial suggests that when we are using single agent, except rosiglitazone, you can see all sulfonylurea, metformin are failing after a few years. We know that not a single diabetes drug which will have a constant effect for more than 2.5 years. Usually we need to add some combination therapy. So ADA standard of care suggests that we should have HbA1c of 7, but when we are targeting HbA1c of less than 6.5, especially in a young patient with no complication, with longer life expectancy, with no cardiovascular risk, such type of patient may need polypharmacy. By giving metformin alone, they will not reach HbA1c goal of 6, which usually I do. I'm very happy to deliver this lecture because this is exactly what I am targeting, by giving combination therapy early. I am targeting HbA1c of 5.9 or 6.6 or 6.1 in type 1, new onset type 2 diabetic patient without hypoglycemia. So you have to be very precise that patients should not develop unadvanced hypoglycemia by targeting stricter goal. Yes, for later age, with more duration of diabetes, that is fine. But even today, just 1.5 years before the guideline, even after the base data with GLP-1 and SGLT2 suggests that after metformin therapy fails, so first line treatment is metformin alone, and lifestyle modification along with metformin. And if there is ASCVD or CKD, which recently they have changed, that this respect to HbA1c control or whatever the level you are targeting, if ASCVD risk is there or CKD risk is there, you can use GLP-1 and SGLT2 therapy for the benefit of patients. So now this first line therapy only with metformin is changed, but still the HbA1c criteria are very much prevalent, that we are still not using combination therapy unless until HbA1c is 8 or above. So even today, the routine logic behind giving anti-diabetic medicine to a new onset diabetic patient remains to only one cornerstone, that is metformin, 1 gram, 1.5 gram, 2 grams, sometimes 3 grams. And we are waiting that patient will fail the metformin therapy, and ultimately then we will put on combination therapy. So when we are talking about early combination therapy, is it a good approach? Is a strategic approach? So we need documentation to support all these things. So early intensification is good because we can reduce the declining of beta cell. We are achieving the better HbA1c early in the diabetic life, and we have to see for the side effect, especially hypoglycemia. Also, hypoglycemia is concerned. So when we are talking about this, now we have very good trial to support this. Verify study, and I will say everybody is behind CVOT outcomes trial and how we are reducing CV risk. But we should not forget that a new onset young diabetic patient is not at very high severity when there is not multiple risk factor. They actually require a stricter glycemic control and exactly verify. Villagliptin people has done this study where villagliptin was compared to metformin alone to find out these two outcomes. The primary question is to us type 2 diabetic benefited having combination therapy at the beginning of pharmacological treatment, and secondary outcome they are wishing for that is helping them to reduce complications of diabetes, especially severe. So all this study we are talking, we just before my talk, there was talk for hypoglycemia and everybody was talking about ACCORD study because ACCORD study is the first study who told that intensive control may harm also. But that harm happens after 8 years of diabetes. But what happens in first 5 years of diabetes? We have only one study, ADOPT study, and the second larger study is UK. That's all. So Verify is the very third study which is showing us the early control with the medicine without causing much side effect. So the study design was double-blind, two-arm parallel group study where primary failure and secondary failure was seen over the period of 5 years. Here the patients were between 18 to 70 years with BMI from 22 to 40. So all type of BMI group is involved and HbA1c was 6.5 to 7.5 because obviously these people are young enough, new enough with eGFR which is normal, diabetes for less than 2 years and they were treatment naive or either they were on metformin, maximum 4 weeks of metformin were included. And then they were divided, they were randomized to two groups, either metformin with villagliptin or metformin with placebo. And they were seen for primary failure. If patient is having primary failure, then they were shifted on villagliptin combination and then they were seen for secondary failure. And there is always definitely a group where there will be no failure who are maintaining HbA1c of less than 7 even after 5 years. This is the study done in 34 countries at 2254 center and more than 2,000 people were enrolled. And all the parameters as far as diversity is concerned, the baseline characteristic is concerned, they were comparable in early combination to monotherapy. And you can see that initial monotherapy, the treatment failure was at 36 months, while early combination therapy treatment failure was not up to 5 years. So the hazard ratio suggests in favor of early combination therapy. Time to secondary failure was also reduced to some. So this combination therapy ensures early and later glycemic control. At the same time, it is durable with low risk of hypoglycemia by giving DPP-4 inhibitor to metformin, no body weight gain, therefore improving patients' adherence to treatment and possibly reducing clinical inertia also. So now in 2018, ADA, ASD consensus statement and now the 2019 ADA recommendation also allow this combination therapy depends on the need and your approach. The strength of the study that new onset diabetic patients were there, diverse, geographically distributed, multi-ethnic population was there. Duration was pretty long for 5 years. It was well tolerated with no unexpected new safety signals that we should worry about, and it reproducibility and glycemic durability in international heterogeneous population. But here the HbA1c was between 6.5 to 7.5, so we need more thing. If it would be better if actually the HbA1c range was more, and only one treatment combination in form of DPP-4 was there because SGLT2 at the time of this initiation it was very new. So now we have very well establishment of GLP-1 analog and SGLT2 inhibitor, but I think that we will have even better study with that. So the key findings suggest that if you early start combination therapy, you improves the durability of treatment, you improve the treatment failure by 26%, and it is well tolerated. So definitely it is proven. We have very good study to back that DPP-4 with metformin you can start in early diabetic patient. But along with that, I would just added 2-3 slides last that It is not always early means new onset diabetic patient. There is one another therapy because to use insulin early is also important. But giving GLP-1 analog to basal insulin, because as an endocrinologist, we are saying that it is like a basal bolus therapy. You can start with GLP-1 analog. So definitely they are costly, so it is not for each and every person you want to start with. But basal insulin with GLP-1 analog is one of the things that you can start. Definitely, you will not start in severe insulin deficiency patient, especially type 1 patient, but it causes less hypoglycemia. It actually causes weight loss also sometimes, and it is having lesser weight gain in comparison to mealtime insulin. You can see the data where glargine plus rapid acting analog, so basal bolus therapy was compared to exenatide with glargine, and you can see the with similar kind of HbA1c, weight was actually reduced by giving GLP-1 analog. So this is another study with liraglutide, where liraglutide basal insulin combination was studied in comparison to basal bolus therapy, and you can see A1C was reduced far better with more weight loss, and overall insulin doses was also less by 18 units. So definitely there are number of agents which are there for diabetes management. Hyperglycemia to be treated not only with a single drug, with early combination therapy. We have now substantial evidence. The only thing which I would concern that always think of weight gain and hypoglycemia, because these are the two things which may happen at any point of time, and always think about side effect first when you are giving any damn combination therapy to a diabetic patient. Otherwise, if you use it judiciously, like DPP4 inhibitor or SGLT2 inhibitor along with metformin, or even for India, I can say low dose of pioglitazone, or sometimes acarbose, voglibose combination with metformin therapy. These are the therapy it will not cause hypoglycemia. Except pioglitazone, all other drug will not cause weight gain, and they will have better outcome as far as cardiac and renal risk reduction is concerned also. And when you are treating in a later stage, 8, 9, 10 years of diabetes, when you are thinking of insulin, combination of GLP-1 insulin therapy is also important. So this is what all about combination therapy, where we can use as early in the diabetes therapy, and we can improve the outcome. Thank you.
Thank you, Piyush. I think since we are running short of time and both the speakers
unmute, sir. Unmute, sir.
Engagement, I request
you unmute,
to introduce Jyoti Dev. Yeah.
You have to unmute, sir.
Pichmani, can you introduce Jyoti? And then a brief. Pichmani is on.
Yeah, good evening, sir.
Yeah.
Able to hear me, sir?
Good evening. Good evening. Yes. Please go ahead.
Good evening, sir. Yes, sir. Good evening, Dr. Anakaman, sir. At the outset, I would like to thank Dr. GVK, sir, for having given me the opportunity to be part of 3D. We are all missing the great gala in person in the hotel, sir. Next year, I probably hope all of us will join over there for the gala meeting, sir. And I'm very honored and pleased to introduce Dr. Jyoti Dev, Keshadev, who is from Trivandrum and who has finished his UG and PGs in Trivandrum, and is a fellow of Royal College of Physicians. And of course, he's running his RSSD IDF recognized Jyoti Diabetic Center, and who is known for his technology. And long time before all of us started with telemedicine, he started with telemedicine in diabetes, and is a pioneer in using the latest technology in diabetes. And technology, of course, has taken over the diabetes management past 2 decades. And with the COVID being very COVID not unable and patient unable to reach the hospital, the telemedicine service has been very good. So the telemedicine service, which has been there for it's been used by Jyoti for quite some time. I think he'll be able to show he will be able to highlight many of its uses in the current therapy in diabetes, as well as we have heard about him talking about CPMS, and he was talking about more about the glucose meters and the various users. So let us hear from Jyoti, sir. Over to Jyoti, sir.
Thank you. Thank you very much. Thank you very much for the nice introduction, Dr. Pichmani. And hello to Venkataraman sir. Hello, sir. Missing Chennai. And I can see Sadashiva sir also there. So Thank you, Dr. Vijay Kumar, for this opportunity. And I was there for quite some time and it's going very well, very well. Congratulations. And in the next few minutes, I will be discussing, and this is a topic which is given to me. And this is a very contemporary topic as introduced by Venkatraman sir a while ago. Can computers or technology or together help us for better care in diabetes? Of course, we have been experiencing the same during the COVID era. And I would say that the status of diabetes as a disease, it has been escalated during the COVID. And diabetes earlier used to be a disease resulting in cardiovascular diseases, but now, since more than 90 to 95% of the COVID patients all over the world, including in India, those who died have diabetes, the status of diabetes has transformed as never before. And COVID has also taught us how to treat diabetes virtually. So I'll be discussing this in the beginning. So 99% of our patients can reach the goals of therapy if you are exploiting rather than simply using technologies. And when we are using technologies for treating diabetes during COVID, there is absolutely no chance of virus exposure, neither for us nor for the patient. And I would say that you require minimal tools, maybe a small phone, and the patient also probably will require only an ordinary telephone. And hence, the technologies or telemedicine can be implemented in the resource-limited settings as well. So this is a case, a real case which we have seen during the COVID. A 19-year-old male with diabetes of 1 year duration, and that was type 2 diabetes. And after the lockdown, he was very lazy. The boy was at home, eating more, not exercising at all. And this is the scenario when this boy visited us. It was a very, very brief visit to the hospital in the month of June, just 5 to 10 minutes for the laboratory investigations. And then he was later on seen only via the telemedicine. A glycated hemoglobin of 13.5 and with some incredible values. He was enrolled in our DTMS with a customized frequency for SMPG, and the diabetes team started following up very meticulously. And he turned out to be COVID positive in the month, in the later on, and the COVID was also treated virtually. So we are running a virtual COVID IP where the patients are being monitored for all these parameters once in every 4 or 6 hours. And this is run by a group of doctors and by the nurses. And he performed very well. And for the 7 to 10 days when he was acutely ill with COVID at home, he required multiple boluses as well in addition to the basal insulin, including the correction boluses. And this is the baseline, and that was in the month of June, and this is 3 months later. The A1C from 13.7, it has dropped down to 7.1%. And currently in the month of November, this is the scenario. We have stopped insulin and he is on a tiny dose, 125 milligrams of metformin with almost complete remission. I would say the remission of diabetes, not complete remission, remission of diabetes. And this has been possible through telemedicine with virtual consultations, very frequent virtual consultations. And the biggest challenge when using insulin, hypo, it has never occurred, not even a minor episode of hypoglycemia. Telemedicine, by simplest definition, is the use of telecommunications to support healthcare, ranging from a simple phone to highly sophisticated devices. But with broadband internet connectivity and with the use of new smartphones, probably you don't require any sophisticated machinery or devices for practicing telemedicine. And this is an editorial which I wrote for IJD on harnessing the multitude of possibilities of telemedicine for consultations in COVID crisis. And definitely telemedicine, including these virtual continuing medical education programs, are going to continue even beyond the COVID era, because this is much, much more efficient and many more doctors can participate. And I know many of you are using similar platforms. Some of you are using your own platforms, and even Zoom, which we are currently using for education. They do have a healthcare customized platform. And this is our telemedicine, and this is a publication in 2012 where we have proven the cost effectiveness of using this, and how the electronic medical records can be shared over a telemedicine program or during a consultation. Highly motivational when I can show the values and the trends over several decades. And this is a patient being on follow since 2008. And how technology can prevent the progression of diabetic kidney disease. And this is probably more powerful, and the evidence is much more robust than many of the currently available newer therapies which can prevent the progression of diabetic kidney disease. And these are some of the tools which are used for titration of basal insulin. This is an FDA approved diabetes management companion, and this is Insulia. And Insulia is not currently available in India. It will be soon arriving in India along with a popular biosimilar basal insulin. And for Insulia to be executed, the doctor requires a desktop or a laptop where we can customize the goals of FPG, the PPPS and the A1C. And then you have to put in the details of the patients, including any history of hypoglycemia. And the patient can download the program in his mobile phone, and then he's all set to go for auto titration of basal insulin. And this is a user-friendly, highly patient-friendly protocol for patient-driven, and of course, the final decision will be taken by the doctor, including remainder on consultations at the doctor's office. And of course, many of us are using this My Dose Coach for the titration of basal insulin, such as Landis and Tojo, a popular mobile phone app. And now I move on to the connected devices for remote monitoring. I am a fan of Apple Watch. Most of my friends are aware of this, and I am a fan of Apple Watch. And Apple Watch is used by many of my patients. So this is one of the emails that I received the day before yesterday of my patient sharing the daily activity, the move goal, the exercise, and the new watch can also measure the SpO2, the blood oxygen levels. And he has also transferred a electrocardiogram. It's of course a single lead ECG, but it's amazing. The total duration of exercise, the heart rate variability, the average duration of exercise over weeks or over months or the days, and the number of steps per day, and so on. And this is the most apt description by Apple. The future of health is on your wrist, on your Apple Watch. That is the future of health. And during the lockdown period, this I have posted in my Facebook. I had this experience, and this is one of those patients, and he's not my patient. His father is my patient, and he had a discomfort while climbing stairs. And I knew that he's having an Apple Watch with ECG enabled, and I told him to send an ECG, and this is the ECG at the bottom. The ECG was normal. And I told him to climb the stairs again and then repeat the ECG. And half an hour later, he sent me this one, and that is at the top panel. And of course, this was showing significant STT changes. I immediately referred him to a higher center, and there were multiple blocks in the vessels. It was a multi-vessel disease, and he underwent percutaneous coronary intervention, and his life was saved thanks to the remote monitoring. And the connected devices, some of them are exclusively for diabetes, and some of them are life-saving, especially in an era where even the American Diabetes Association has endorsed ambulatory glucose profile, and this is a model report to be handed over to the patient on AGP and the DIR. And we do have the new devices from Medtronic, the new generation of Guardian Connect, which will provide you with the glucose value once in every 5 minutes and can be shared with many of your friends, with your doctor, and the patient can share with the diabetes nurse, of course, nurses makes a difference for diabetes, and that is the theme for the year. And the same can be shared via the watch and the trend arrows denoting the percentage of increase in the glucose or the percentage fall in the glucose. And these CGMs are also capable of generating the AGP. And this is the time in range. We know that time in range AGP is the property of International Diabetes Center. It is not the property of any company. So any company can procure this, and then they can have the report which is published by the American Diabetes Association. So the report should be similar. So imagine a scenario. Imagine a scenario where the patient is unaffordable. He cannot afford an expensive device for performing continuous glucose monitoring. And probably more than 90% of our patients in India cannot afford a CG unless the cost comes down. And this is when you can have your connected glucose meters, and with more frequent measurements of SMPG, you may be able to have quick averages. And this is shown either in the phone, or you can have the web app for the patient or for the doctor. So both are available. For the physician's office and for the patient, separate web apps are available. So these are some of the branded connected glucose meters, fairly very accurate and very, very cheap. This extra functionality is available free of cost. And the color coding for hypoglycemia, for hyperglycemia, and this can be for research, or this can be sent as a glucose digital diary to the physician's office. And these are some of those examples of mobile phone apps and how the technology has been transforming over the years, and this has become extremely popular during the COVID crisis. And this is My Sugar app, the most popular mobile phone app for patients with diabetes, used to by close to 3 million patients in more than 57 countries, including it's available in India, including for free download in India. And this gets wirelessly connected to the glucose meter such as AccuCheck, and you can log in the data on insulin and with a plethora of functionality. So this has got enormous functionality, the My Sugar app, carb counting, insulin carburation, and so on. And soon, in another 3 to 4 months' time, we will have the connected insulin pump pens in the Indian market itself, connected pens. So this can either be a near field communication enabled pens, and the NFC enabled phones can communicate with each other, and they can get connected to the My Sugar app or the SmartPick software or the Gluco or the Diascent, or this can be Bluetooth enabled caps, and the pens can communicate with continuous glucose monitoring devices such as Libre or with other devices. And this is in pen. So some of you probably are aware, I have also presented several times before, and very recently in the month of August, Medtronic has procured InPen. So InPen has its own algorithm in the phone, and this can now communicate with the Medtronic continuous glucose monitoring systems, and it can semi-automate the dose of insulin. And Novo, Lilly, all of them are having the NFC enabled, and these are the connected insulin pens, the durable insulin pens with 800 memory, with a long battery life of 5 years. And these are the two NovoPen 6 and Eco Plus. Eco Plus is meant for children with half a dose possible, 0.5 units is possible. And these can also communicate wirelessly with other devices for automating both basal insulin and for the rapid acting insulin. So the multiple daily injection users can also semi-automate or can use the algorithms from their phones. And this has opened up the era of opening up the pumps. So earlier, the insulin pumps will get connected to the sensors and algorithms only from them. But most of the major manufacturers, such as the T-Slim insulin pumps, the Medtronic pumps, they have now the option to connect to the third-party dosing algorithms, the third-party continuous glucose monitors. So a pump from one manufacturer can connect to the CGM from another manufacturer. And this has been probably thanks to the big movement we are not making. And this is do-it-yourself artificial pancreas, which uses commercially available insulin pumps, re-engineered, usually the older generation pumps. So this is one example of an old Medtronic pump, re-engineered, connected to a new sensor from Dexcom, and this is a Riley link, and this three together will create an open source algorithm which is there in your phone, and it can automate the delivery of insulin. And we have recently published a review on the do-it-yourself artificial pancreas. These are the three main types, and if some of you are interested, I would request you to go through this review in detail, because in the currently available hybrid closed loop systems, you can probably achieve a time in range of up to maybe 70 to 75%. But with the do-it-yourself artificial pancreas, which is not regulated, which is not approved by US FDA, and these are all created by the patient communities, it's able to reach a time in range of up to 90 or even 95%. Incredible achievement. And this is where we have reached the newest in the market for insulin pumps, soon reaching India. And this is from Roche Accucheck, the small 2-free micro pump. And this is the diabetes manager, and this is the modular design of the patch insulin pump. Now, this is going to be the first patch insulin pump coming to India with no tubes and strings attached. And the diabetes manager is the Aveva Solo, which is a remote controller as well as a glucometer. And what is new? I'm going to have a small demonstration. Of course, many of you could have already used this, and this is the new Libre real time. And this has been used in more than 100 countries now. So this is the demonstration I'm going to give. So I have a sensor over here, and this is how in a second you will get a value. So I am reaching 140 very soon, and this is 139, and it shows that it is horizontal. So a horizontal means the value is stable over there. So if you have an arrow pointing upwards, that means the glucose is going to increase by 2 milligram per deciliter per minute. So in another half an hour, it will be increasing by 60 milligrams. And I can also use it with the help of my phone, and that is Libre Link app. So there is another, and this will be reaching India in another 3 months' time. Libre Link app is currently not available in India. So I would like to conclude with a comment that all the technologies need not be used by all the patients with diabetes. So you need to customize who all will require the right technology. So thank you very much, Dr. Vijay Kumar, my dear friend, for this opportunity, and thank you for your patient hearing.
Thank you, Jyoti. I think it was when you go to a consumer shop, electronic shop to buy a TV, I think you're amazed at the variety that is available. The same feeling I had when you went through the gadgets. I understand that you are in a hurry, so also is Piyush. Maybe a couple of quick questions or comments. Vijay, can we take another 5 minutes, or we want to close down because we are running?
5 minutes. 5 minutes. Sir.
5 minutes. I think to sum up, I think Piyush's presentation highlighted the aspect of combination therapy at diagnosis, how the verified trial has given the clinicians the confidence to initiate combination therapy, because this combination is devoid of hypoglycemia and weight gain, and it addresses the secretory defect right from diagnosis, because once you're going to be on metformin, you're correcting the insulin resistance. But diabetes is precipitated by the insulin secretory defect. So there is a scientific rationale to start combination therapy at diagnosis, and verified trial has recruited patients with a mean HbA1c 6.8, and there is no extra hypoglycemic risk. What else do you want? And also he touched upon some of the other combinations that are very attractive down the line with basal insulin and a GLP receptor agonist, I mean SGLT2, etc., etc. And Jyoti, I think you ran through a, what shall we say, a scenario of the technological development. It was wonderful, wonderful. As I told, the comparison was when I walked into a consumer electronic shop and see the range of TVs and other gadgets available, you do not know what to buy because you are amazed at the technological development. Yes, in fact, one of my patients from Kumbakonam, a type 1 diabetic, she is on Libre Pro, and the way she has been controlled beautifully. In a couple of weeks, we were able to control with high blood sugar and acute presentation of type 1 diabetes mellitus. I'm sure people would like to listen to Piyush and Jyoti in the next few minutes. So, questions? Are there any questions already?
No questions, sir. So far, no questions.
So there are no questions. Any other comments from VG or co-chairpersons Pichumani or Kannan? Anything that you would like to add?
Actually, I would like to thank Joseph as usual. He has really rocked. Sir, actually, we used to listen to all the conferences about insulin trends, of course, about various technologies they used to use. They are always fascinated. The same also has proved us, and I've learned quite a lot today, sir. Thank you very much, sir.
So only thing is a word of caution. The way technology is growing, some of us may be totally or partially jobless. Thank you.
Dr. Mohan has got a comment.
I have a question to ask, sir. Is there any way of finding out on whom what drug will work so that we'll know which combination to use first?
Genetics. I think that is going to be a long way. I think precision diagnosis and precision medicine, which we have discussed quite often, probably it is now applicable only for types of MODY and rare types of diabetes mellitus. But for the general type 2 diabetes mellitus, which you are asking, maybe the future will identify the phenotype. I think the clustering of diabetes is the first step towards any. We have to go a long way. Maybe the future will identify. What about your take, Jyoti? About identifying.
Yeah, same. That is a precision medicine, and maybe it will take another 5 years, so that we can find out which medicine will be applicable for which particular person. You are right, sir. Yeah.
So I think, shall we close down? I think I would once again thank Piyush and Jyoti for excellent presentation. Beautiful presentation. I think nobody would have any doubts. And also thank my co-chairpersons Pichumani and Kannan, because the first time I think I'm listening to Kannan, and it's a wonderful opportunity to co-chair with you. Thanks, Vijay. I hand over the podium to you for the first.
Thank you, sir. Thank you.
Thank you, Dr. Piyush. In fact, he has just accepted. You know that yesterday only I asked him, "Can you come in?" And he readily accepted. So thank you very much, and it's a wonderful seeing you and meeting you. And you got a great lecture. As usual, Jyoti, he rocks always. Thank you. Thank you. All the best. God bless you. Good night.
Thank you.
Dr. Sada. Now I think we'll go to the next session. The next session will be on another important aspect, that is on diabetes and lipids. You know, I don't think we can go away without speaking about diabetes and hypertension both. So today we thought that we can have a symposium on diabetes and lipids, and we have Dr. Y. Sadashivarao. He's a good friend of mine. He's the first diabetologist of the Andhra Pradesh, the Costa area, what we call as Costa region. He's the first diabetologist, and is most popular as well. He's blessed with two wonderful daughters who have done DM endocrinology as well. They're rocking actually. And he's a past president of APDF, Andhra Pradesh Diabetes Federation, twice, and we're all together in APDF. And he will take this next session, a journey into the diabetes and lipids. Dr. Sada, go ahead.
Yeah, thank you, Dr. Vijay, for the kind introduction. And today we have with us three panelists, Dr. Teja Shah, Dr. Chandrasekhar Shanmugam, and Samit Ghoshal is also there.
Samit, I think is not joining.
Okay.
Tejas, Chandra, and
Teja Shah is a very young, dynamic diabetologist from Rahija Foods Hospital, Mumbai, and he has a diabetic care centers in Malad and Andheri, and is a visiting teaching faculty for fellowship in diabetology at Dr. D.Y. Patel Medical College, Navi, Mumbai, and is the founder and treasurer of Initial Diabetes Forum and organizes a scientific committee and faculty of CID 2014, 2015, 16, and till today. Yeah, faculty is also practicing diabetology for the past 20 years. And so next we have Dr. Chandrasekhar, who is a professor of medicine and executive member of the Chennai chapter, API treasurer, Tamil Nadu and API, and is a joint executive member of South India, D Club founder secretary, special interest in diabetes, infectious diseases, published around 22 articles in various journals, and has been invited to and has been a regional faculty and given about 175 talks. And Shanmugam, I think he has already been introduced. And somehow again I'll introduce him. He's Associate Professor and Head of the Institute of Diabetology, Government Channel Medical College, Chennai, and the Consultant Diabetologist, Chendur Diabetes Specialty Center, Ashok Nagar, Chennai. And he's received fellowship from the American College of Endocrinology, and has more than 10 years of teaching experience in the field of diabetology, and published papers in peer-reviewed national and international journals. So I have three eminent people to help me out with this diabetes and lipids management. Today, actually, the most important part of diabetes treatment is management of lipids. And the management of lipids in Indians are slightly different from that of Western counterparts. And you know that according to one Indian study, there is about 82% of prevalence of dyslipidemia in diabetic population, and almost and it's felt as you know that diabetes is a cardiovascular risk equivalent, and once the patient has dyslipidemia, certainly the risk increases by almost 3 to 4 folds than the non-diabetics. And so here we will be discussing on, is it worth targeting triglycerides, and after that is HDL a marker or a target to treat, and then we'll be talking on the newer agents on the horizon. Yeah, now I request Teja to take over on triglycerides.
Now, can I see one of the reasons why we have introduced these two questions, triglyceride and HDL, keeping in mind the Indian phenotype of dyslipidemia. We know that we have generally, though LDL is slightly elevated, we have always having a marginal triglyceride in almost every patient of what we see. And also we have also got a low HDL. So these are the two things that we thought we need to discuss, and that is the reason this introduction. So that you can just ask one by one their comments about each question.
Vijay, that's what I told you, that the management of dyslipidemia in our country is far different from that of Western counterparts because of the Asian phenotype. And you know that what is the heterogenic dyslipidemia? Chandrasekhar, you can take over. Yeah. What is heterogenic dyslipidemia? What is characterized by, especially in our Indians?
Yeah, the thing is, like, we Indians, we are quite different from the Westerners in terms of like the different phenotype, the Asian phenotype what we have. Particularly with the more burden of the diabetes, like we do have a lot of patients, almost some of the studies in Indian studies, it shows that like 80 to 85% of the men and women having diabetes are having diabetic dyslipidemia part of it. Like, so this diabetic dyslipidemia is unique, and it's characterized by increase in the triglyceride and increase in the small dense LDL and decrease in the HDL part of it. So this is a very important thing. Like all along, like we have been looking for a LDL target. Like, so this is what we have learned in the recent past. But for the past 1 decade, the scenario is quite changing, and we do see lot of evolvement in the understanding of the diabetic dyslipidemia. Now the targets are again revised. So particularly after this Lipid Association of India came into the front for like 2016, they have released a nice guidelines on how to manage the diabetic dyslipidemia, and they have put forth a lot of the revision in the LDL and the triglyceride target, of course, HDL targets, and they have been more proactive. So more even before ACC or AHA come with some strong recommendations, like our own guidelines, like Lipid Association of India has given a lot of insight into that. We may discuss little bit later on that part of it, but this typical increase in the triglyceride, increase in the small dense LDL, and a decrease in the HDL is the characteristic thing we do see in patients with the Asian phenotypes.
Certainly, now practice we have high LDL, and we try to target it. So most commonly we use either atorvastatin or rosuvastatin in our practice. So what do you usually use, each of you, in practice? How do you go about treating LDL or the lipid management?
So, can I start? Yeah.
Yes, please.
when it comes to LDL, as Dr. Chandrasekhar also started off with, that primarily, and the guidelines also tells us that for a patient with lipid or dyslipidemia, it is always first necessary to target the LDL and bring down the LDL at the desired level, which is below 70 for our diabetics. And primarily the recommended drug of choice is any of the statin, whether you start off with a rosuvastatin or an atorvastatin. They have been classified as high intensity statins per se. And the entire dosage, of course, would depend on patient to patient, but as such, one of the two statins are the ones which we most commonly start off with, depending on the requirement of the patient. So at present, this is what the guidelines tells us, and our aim first target is to bring down the LDL to the target level of 70 and below in most of our diabetic patients, is what we are first aim is. And then once the LDL is at target, and then we go on to look at other factors or other lipid parameters which we want to bring into target. We'll be, of course, coming to the talk on talking about triglycerides later. I think if anybody wants to add on this, Dr. Shanmugam.
Yeah, Dr. Shanmugam sir, can you please add on?
Yes, sir. As Dr. Chandrasekhar also pointed out that diabetic people we have a classical diabetic dyslipidemia where like triglyceride and small dense LDL is quite high, though we are not measuring that. And ultimately, whatever LDL we are having, all the LDL are dangerous LDLs because all are having small dense LDL specifically in diabetic population. So having said that, the LDL reduction is quite mandatory while managing type 2 diabetes mellitus. That is why the ADA also recommends that if you're dealing with type 2 diabetes patient, older age group, higher risk group, particularly male, having a smoker or having a family history of CAD, we need to have an intensified statin. Intensified statin means we need to have at least 30% reduction in LDL, whatever the baseline LDL it is. 30 to 50% LDL reduction is mandatory. And having said that, what medication we have to go for with atorvastatin or rosuvastatin? Based upon the LDL reports, if you want to have a better LDL reduction, I used to go with the rosuvastatin, which have a more efficacies than atorvastatin. Atorvastatin, undoubtedly, it has proven because of lipophilic activity, it is be well used in cardiac patients, those who are having all ACS, acute coronary syndrome. We do use atorvastatin, but as a stable patients in routine clinical practice in type 2 diabetes, stable diabetic, we want to have a primary cardiovascular prevention. I would vote for rosuvastatin, that to 10 milligram. The first dose will be a quite high dose so that we can have a significant reduction, 30% reduction. So if a patient can be able to maintain that LDL, we can reduce the doses of statin on a maintenance basis.
Yes. So after discussing, yes, please.
Venkatraman sir want to say
something. Can I add a point?
Yes.
Can I add a point?
Yes, sir.
I think we have to categorize the patients as candidates for high intensity statin therapy and moderate intensity.
Yeah.
Anybody who has had a cardiovascular event is a candidate for high intensity. There's no doubt about it. And you calculate the 10-year risk. I don't think you need to have a calculator or anything. If somebody is a diabetic, hypertensive, smoker, and dyslipidemic, I think his 10-year risk is very high. He is a candidate for high intensity. All the remaining will be candidates for moderate intensity, which means how much of LDL reduction you want to achieve, either it is 50% or more than 50%. If it is more than 50%, certainly high intensity statin. So the risk categorization and the quantum of reduction that you want to achieve, that dictates. And when it comes to the statins, it is only 1:2. For example, Rosuva 20 is equivalent to Atorva 40. Rosuva 40 is equivalent to Atorva 80. So it depends upon whether you want a moderate intensity or high intensity statin. Just whatever I think Shanmugam, Chandrasekhar and Teja said, I just thought I'll summarize and then give it in a nutshell. I'm sure some more points need to be added. Yeah, please go ahead.
Thank you, Dr. Venkatram. And then I think...
Sorry, sir. Madhavan sir also in the line.
Yeah, yes, sir. Please, sir.
Yeah, I would like to know whether the so-called moderate and high intensity statin for the Caucasians is the same for the Indian phenotype. Very often you see that our patients do not tolerate a very large doses of statin. The side effects are so high that we are forced to reduce the dose. That is one clarification I would like to from any one of you.
But yeah, I totally agree with you. But if you have somebody with a, with an event, an MI, a PCI, a CABG, the cardiologists stay put on rosuvastatin 40 milligram at least for the first 1 or 2 years for stabilizing the plaque. So we are much more concerned about the number. But from the point of view of the pleiotropic effects of statins, I think the stabilization of the plaque and then the protection that it offers with the high intensity statin, sometimes the side effects are so glaring, and even the cardiologists are aware of that, but they are so much convinced about the benefits, they try to push it as much as possible. In fact, I've referred quite a few patients have interacted with the cardiologist. I said he's having a muscular pain. Yeah, done the CPK. It is no. Let us continue. In other words, they want to. Having appreciated the benefits of the statins, knowing fully well there is going to be certain amount of side effects, and then leveraging it. The balance of evidence and the balance of practice is in favor of as much statinizing the patient as possible. Of course, certainly from the point of view of the LDL cholesterol, you would like to. Now I think LDL of, if somebody has an event, LDL of 45, 55. The other day, one patient of mine, he has had a CABG with a LDL cholesterol of 62. The cardiologist said, no, it's not sufficient, less than 55. In other words, yeah, because the evidence is there. I think the lower the better. I totally agree with you. Certainly tolerance is an issue. We tend to down titrate the dose, but probably not in the first 1 or 2 years of an event or a procedure. That's
Dr. Shanmugam, does rosuvastatin has an effect on A1C? Does it worsen A1C?
Yes, sir. As with the
right from the Jupiter trial, it has been there. It's a very, very small price that you pay for the enormous benefits that you derive from the statins.
That's what it mentioned, that you need to correlate with the benefit, and against the benefit, the harm or the chances of developing progressive diabetes is very, very
inducing
less.
diabetes or not.
Yeah.
And having said that, and the advantages, Professor Venkatraman sir pointed out, the advantages of statin is phenomenal. Rather than inducing a diabetes, it is very minimal in number.
No, I'm not talking about inducing diabetes. In a non-diabetic worsening.
Yes, sir. Dr. Mohan.
Sir, I have a question.
There was a 3 or 4 milligram increase in the fasting plasma glucose. In which case, somebody who has been normal might have been pushed to IGT, and even diabetics would have had a marginal rise or requirement, but that is.
Sir, the same line. Does high intensity statin mean? Does high intensity statin means higher diabetogenicity? That's a question I want to ask, because even a very small dose of statin will give you in terms of cardiac benefit it gives. Plaque stabilization, everything happens in a smaller dose. Higher dose is for the pleiotropic benefit. So would the higher intensity of statin also mean higher intensity of diabetogenicity? That's a question I wanted to ask.
No, I'm not too sure, because it is a class effect. The rising. In fact, the Jupiter trial, the dose that was used, if you remember, is rosuvastatin 10 milligram, which is not a high intensity statin at all. But still, there was a signal that could be a mild worsening or precipitation of new onset of diabetes, which was very, very mild. So I think the mechanism is not very much understood. As much as I know, you have some hypothesis, working hypothesis, or hypothesis generating explanations. But the fact is, yes, it is a what shall you say? It is a class effect. May or may not be dose related from the point of view of carbohydrate intolerance. That's my understanding. Please correct me if I'm wrong.
Yeah, Dr. Chandrasekhar.
Yes, sir. So I do agree with what Professor Venkatraman sir has said. Because the thing is, anybody who is having a normoglycemia or the impaired glucose tolerance, they do have some clustering of the risk factors that is prone to develop diabetes in the future years. So that is one thing. Coming to the previous question, which Madhavan sir asked, so we need to know because the Lipid Association of India has given us revised the guidelines. That's why I said they have been more proactive in reducing the LDL target, because recently concluded the Fourier trials with evolocumab, it has said that even when you are bringing down the LDL to less than 30, still there was some substantial risk of developing future events, almost to the tune of 14.4%. So that in that case, now people were looking to bring down the LDL target, even it is revised to less than 30 in patients with the diabetes, particularly with polyvascular disease. With target organ damage, it's preferable to have a LDL target of 30 milligram per deciliter. That is one thing. Second thing is this statin intolerance we have been talking for a while. So before we talk about the statin intolerance, so there have been many hypotheses and many different styles of practicing, initiating statin for that matter. Like if somebody is developing some muscle symptom, that is a very common thing which we are worried about. So we need to know the drug interaction. So there are certain drugs can interact with the statin and it can bring down, can cause more muscle pain. Look for the hypothyroidism, look for hypovitaminosis G, particularly the vitamin D, low vitamin D levels are more prone to get muscle symptoms. So the thing is the 75% of the patients who do take statin, they develop these muscle symptoms in the first 3 months. 90% of them, they do develop these muscle symptoms in the first 6 months. So we need to educate our patient appropriately. We need to choose the moderate dose or high intensity dose. See, in that case, there are certain group of people, they are at risk of developing muscle symptoms. Say, for example, elderly people, people with low BMI, people with already having some organ dysfunction, or females, patients with hypothyroidism. So there are some subsets of people who are likely to develop these muscle symptoms. In that case, if the patient is having substantial evidence of myositis, then we can withdraw the drug and we can reintroduce the drug one by one, slowly. So that is one thing. But more important thing is nowadays we do have ezetimibe. So we can combine statin with ezetimibe. So that's a good alternative, a good good choice of the combination of drug. In case if we are worried about the statin intolerance part of it. So there have been some good trials, particularly the IMPROVE trial have shown that when ezetimibe is added to simvastatin, it has significantly reduced the LDL level, and overall compliance and other things also improved. So these are all some of the options we do have.
Besides the list that beautifully, Chandrasekhar, you nicely highlighted the risk for myositis and muscular myalgia. One thing is co-administration of fibrates, especially the CKD. So I think if you have such a good molecule, probably Sada is contemplating to discuss about hypertriglyceridemia later.
Yeah, next. So that's it.
So co-administration of fibrates, especially you start the patient on a statin plus fibrates, he continues for years together. The creatinine from 0.9, it comes to 1.6. Still the prescription is getting repeated. I think they are at also increased risk for, please.
Yeah, thank you, Dr. Venkatraman and Chandrasekhar. And so certainly most of you must have heard the technology man, Dr. Jyotidev's lecture, wherein he has showed that the patient of type 1 diabetes, 19 years, had total cholesterol of 535 and triglycerides of 5,304. So now we focus on triglycerides. So after taking care of LDL, or if the triglycerides is high, we certainly focus on triglycerides, and the drugs that we have are, as has been mentioned, please carry on, Dr. Shanmugam or Chandrasekhar or Tejas.
Yes. As far as triglycerides is concerned, the first most important is glycemic control. So if a patient having bad triglyceride, we should look for a sugar. If the sugar has been adequately controlled, then only you have to start treating the triglyceride. Having said that, triglyceride may be due to diabetic dyslipidemia triglyceride or sometimes familial hypertriglyceridemia. So we need to manage two different pathways. If a patient is a diabetic dyslipidemia triglyceridemia, so we have to control the glycemic control. Second part, basically statin. Whatever statin we start with, statin have an effect on the triglyceride reduction. If statin cannot able to bring down the triglyceride, the alternative medicines can be added, something like niacin or fenofibrate or the PPR alpha agonist like saraglitazar can be added to have a better triglyceride reduction. Having said that, as Professor Venkatraman sir also pointed out that if you combination of triglyceride and fenofibrate, you should keep watch always of myositis. There is slight increase in the serum creatinine. If we need to catch it up yearly, we have to withdraw fenofibrate in that case. I have familiar triglyceridemia. In my personal experience, I think PPR alpha agonist, glitazar works better than a combination of statin and fenofibrate combination. I would, if a patient have a familial hypertriglyceridemia, I will vote for glitazar rather than a fenofibrate.
So,
what about non-pharmacological therapy, or mainly diet? Diet
Yes,
does play a role.
obviously, diet has a major role. Lifestyle modification has a major role in diabetes and lipid management. All that medications are after lifestyle modifications.
So the entire
there is always a controversy regarding the level at which you interfere for triglycerides, because cardiologists strongly believe that there is absolutely no need to treat unless it is above 500. Even then, they say it's only to prevent pancreatitis, because the benefit you get by reducing triglyceride with reference to cardiovascular mortality and mobility. There's not long-term studies except one. So, but as diabetologists, I think Venkataraman will agree with me. We always believed in the department that triglyceride of less than 150 is very essential for diabetic patients. After, of course, after care of glycemic control, as you said very well.
Like to add, yeah. Sorry to you, sir.
Vijay. No, Dr. Vijay wants to add.
No. You, Tejas, you finish and I'll come back.
Okay. No, so the entire talk and controversy regarding triglyceride treatment is from the fact that there are not enough data and studies which have shown that by reducing triglycerides we reduce the ASCVD risk, and that's from where the entire point of discussion is. The clinical studies which have shown which have been done with the triglyceride lowering drugs are not very successful in showing that they reduce ASCVD if they reduce the triglycerides. And so the primary importance of reducing triglycerides is to prevent pancreatitis is what the guidelines tells us. With the same thing, what it says that the highest risk for pancreatitis comes when the triglyceride levels are more than 800 or 885, and the highest and almost the incidence is more than 40% if the triglycerides are more than 1700 is what the literature tells us. And the risk for ASCVD is more or less seen for moderate hypertriglyceridemia is somewhere between 299 to 450 or 500 is what again it is showing. But that is a moderate risk is what the studies have shown. Most of the, however, saying that the Mendelian studies have shown that there is a benefit if you reduce triglycerides. In terms of molecules, it is mainly the if you look at the two recent trials with omega-3 fatty acids, that is the REDUCE-IT and the Cellis trial, which showed that by using omega-3 fatty acids at a higher dose, it helped in reducing the primary endpoint of ASCVD risk when they used and when they brought down the triglycerides. So omega-3 fatty acid is something which is an important molecule now, without the side effects of phenofibrate or without the side effects of fibrates, you can say, which is being now targeted to reduce the ASCVD risk.
The problem with omega-3 fatty acids is the high dose that is needed to reduce triglycerides, 6 grams, if I understand correctly. And many patients develop side effects like burping and
in Improve-IT they use I think around 4 grams is what they in the REDUCE-IT. REDUCE-IT they used around 4 grams is what they showed benefit with. And Cellis, I think they use more than 2 grams or more than that.
Yeah, Vijay, please.
And I think, as all the other speakers have suggested, unfortunately, all the studies that have been done only in the Western population. And that is the reason they don't realize, because such a phenotype is not seen in the Caucasian population or other populations like what we see in India and other Asian countries. So that is the reason we don't have data. But if you look at Dr. S.V. Madhu's data, he has done extensive work on triglycerides. He is very sure the data that whatever he has got, including the inflammatory markers and so many things he has done, it seems to be suggesting that it's a useful thing to bring down. And all of you know that residual risk. What else you can do that? Say if you give a statin, you reduce the risk by about 30 to 35%, max 40%. What about the residual risk? We have only the triglyceride reduction or HDL improvement is the only thing that we can do. And apart from that, if we can see that the Accord lipid arm and Dietary have shown that if you have a low HDL and slightly elevated, more than 207 triglyceride, in spite of statin, if you have such a situation, that is even in the Caucasian population, and that seems to be beneficial actually. So I think we cannot throw away that not to treat triglyceride. That's what my personal opinion is.
Yes, sir. Yes, as rightly said by Dr. GVK, so the triglycerides are no longer an innocent bystander. They play a vital role in creating an inflammatory milieu. So that's what SAR has also said. The accordion follow-up trial. So they have shown that the people who have taken, particularly in the subgroup where the triglyceride is elevated and with low HDL, like people who have taken fenofibrate, have shown some significant mortality benefits. So that is a very important thing. And there have been many small studies. Of course, maybe in the years to come, we may come to learn more about these triglyceride. In fact, the Lipid Association of India has given clear guidelines how the triglyceride level should be managed. And they ask us to preferably in a diabetic to keep a optimum triglyceride level of less than 100. So that's what they say. So the scenario is nowadays with the recent understanding with changes in the guidelines, we come to know the importance of these triglyceride. Of course, there have been, it's very clearly shown that increase in the triglyceride is directly proportional to the increase in the small dense LDL. So that has been shown since 1977 to till date. This one thing is very well drafted and documented. So the importance of triglyceride is one should not forget. Of course, we give most priority to the LDL reduction, but despite LDL reduction, people are getting the eventuality, the morbidity and mortality. So that's why we talk about holistic approach, like a combined approach, where we target triglyceride as well.
Sada, can we, because we are running short of time.
Yes.
We'll start the discussion on triglyceride. Shall we go for quickly 5 minutes for HDL and 5 minutes for the new agents in the horizon?
Yeah.
Finish it off. 10 minutes.
Yeah, Shanmugam, what is now? Should we treat low HDL?
So we like to treat low HDL, but unfortunately, we don't have any good drug to increase HDL. And thing is, after LDL correction, we want to have a good HDL before looking into triglycerides. So, as Vijay Kumar sir also pointed out that some NEJM, there is a letter to editor 5 meta-analysis has been proven that if HDL is less than 38 and triglyceride more than 204, you have to treat it to have a cardiovascular benefit. So as far as we have some bringing down LDL, bringing down the triglyceride, definitely the HDL will go up because chylomicron rich in triglyceride will reduce the HDL quantity. So by treating fenofibrate, by treating triglyceride, definitely the HDL will go up, and we don't have any specific molecule to use. Even with the molecules, whatever we do, say with the rosuvastatin or molecules, it increase 5 to 10%. It in 30 milligram, 5 to 10% is 1 milligram or 2 milligram. In a mechanical errors, it may missed out. So walking, diet, exercises, and with some statin control, if at all adding a triglyceride control, will elevate the HDL.
Yes,
As
we don't
said,
have much time. Yeah, Chandrasekhar ji, please.
Yeah, I'll be brief, sir. So we have to remember that HDL is the only thing which is anti-atherogenic. When we look upon the lipid profile part of it, HDL is the only thing that is anti-atherogenic, and it is important to keep the levels above normal. But whenever we talk about HDL, not to forget the importance of lifestyle measures like smoking cessation and regular physical activity and diet. So there have been 2 studies, one is Interheart and Heritage. These 2 things have shown the importance of regular physical activity and diet and improving the HDL part of it. Of course, we do have limited experience or trials with drugs therapy.
Last, I think we don't have much time. One word about the newer agents on the horizon, PCKS inhibitors. Can you anybody give an outline on that?
Yep. Tejas.
So there are one is the PCSK9 inhibitors, which have shown promising results in terms of extra LDL reduction. Also, what is there? Apart from that, specifically, if you are talking about triglycerides and HDL, there is something called a pemafibrate, which is being studied extensively. It's a PPAR gamma modulator again, which is being studied in one of the major trials. Then there is another form of omega fatty acids, I think, which is called Epanova, which is being studied, I think, by Astra, which is being studied. Then the future directions, I think, are going towards more of apolipoprotein C3 inhibitors, which might work primarily again for improvement of triglycerides. All these have shown a reduction of almost 35 to 40% reduction extra in terms of triglyceride, as well as some amount of benefits in LDL cholesterol also. So these are the future, I think, directions.
Yeah, Vijay.
Yeah, Doctor.
Vijay, would you like to add?
Yeah, use of SGLT2 inhibitors.
Yeah.
They are also beneficial reduction of triglyceride increase in HDL. I think that's also, I think we need to take into consideration.
So one word from Dr. Venkatraman and Dr. Madhavan sir about these newer agents.
So the biggest impediment for the extensive use of PCSK is the price factor. I think in a country like ours, I don't think we are going to use it in a widespread manner. Maybe in a very selective cases, it may be useful, but otherwise the cost is a very big impediment for the extensive use of this PCSK.
I think
Dr. Venkatraman, sir.
in the future, if you remember, if you look at the history in the development of anti-lipidemic drugs, hyperlipidemic drugs, there was a drug called proguanil. It was an antioxidant. They found out that it increased the LDL receptor. In other words, what this PCSK9 inhibitor is doing, to an extent it was done by the proguanil, but unfortunately it was given up because of the side effects. So the future is going to be focusing on LDL receptors. And before I close, I just want to add one point in this whole discussion. Now you take diabetes, you take hypertension, you take hypercholesterolemia. The way we have understood the disease, the way these diseases participate in disease initiation and promotion, the way intervention has been beneficial, has been consistent. Whereas with triglyceride, we have understood the role that triglyceride can play. But unfortunately, intervention so far has not produced any meaningful, tangible effect. So that's why the AD also said it is left to the discretion of the clinicians, because nobody is sure. If you ask for the guidelines, nobody is sure because there is lack of evidence. But in fact, Krishna and I did fight with about this almost for one hour in a journal meeting. When the AHA guideline came about the statins and then triglycerides, you can ignore that. So here you have to strike a balance between the evidence that is available, the way we have understood the pathophysiology, the importance that we are giving, not that we are neglecting the evidence-based medicine, but at times you have to amalgamate the evidence-based medicine with the way you have understood the disease, and moderate hyperglycemia has to be treated. That is my opinion.
Thank you, sir. And I welcome Dr. Krishna Seshadri. One word. Yeah. Krishna Seshadri, please.
I don't know how many of you are aware of this particular data. The use of statins in type 2 diabetes is anywhere between 30 and 50% in the best of hands, right? And in fact, our own data shows that it is not just that low number of people are given statins. When they're given statins, they are given the wrong dose. So when the initial risk itself is not addressed, why we are talking about residual risk. So my suggestion is, yes, these are important, but let's not dilute the most important information, that the reason that cardiovascular disease has come down in diabetes is not because of everything else fancy that we have done, but because of statin use. And we should never let that particular message go away. Dr. Venkatraman, we can fight later.
Yeah, Vijay. Vijay, I think it's time.
No. There are two questions in the chat box. One is that a quick comment on that. Does high intensity statin has higher intensity for diabetes, new diabetes?
Dr. Mohan came and discussed.
Already
discussed.
Okay. Next question is that patient with diabetes and dyslipidemia who is intolerant to statin, what drug should be given? By Dr. Rajendra Gupta.
I think the lowest possible dose of a tolerated statin plus ezetimibe.
Yes.
Why we have not talked about pitavastatin?
Maybe sometimes alternate dosing of low dose of statin will reduce myalgia.
Yes, sir.
Shanmugam, what about pitavastatin?
I do use pitavastatin if a patient complaining of myalgia, sir. Sometimes even with the pitavastatin, patient have some complaints of myalgia. So alternate dosing is the last option. If patients still have a pain, we have to stop it, sir.
In fact, there is actually two studies, and one of them actually showed that even if they are taken 3 days a week or 2 days a week, there is still some benefit when using a statin. So the lowest possible, just make sure it is there. That's all it is.
Sada,
yes.
Sadashirab. See, there's so much of discussion has happened. what is the message that we need to give to the delegates who are attended? A clear message without any.
So one thing is that we know that everybody above 40 years, irrespective of the LDL level, we have to start them on a statin, and whatever statin is used, or depending upon the comorbidities. Now we are not looking at the number, but targeting the other comorbidities, and then we have to use a high intensity statin or moderate or a low intensity statin that has been detailed about. And rosuvastatin or the atorvastatin is widely used, and also targeting the triglycerides, as the Dr. Chandrasekhar has detailed about the Indian guidelines, lipid guidelines, wherein they said that we have to target triglycerides as low as below 100. And so there is one point that has to be remembered, and triglycerides has to be also targeted. Certainly if it's very high, we do it, but even at 300 level also, I think we have to prescribe a drug, or we have to go for other lifestyle modifications, which is very important. So and I think thank Vijay Kumar. We'll close the session as already I have crossed the time. Thank you, Venkatraman sir, Madhavan sir, Dr. Krishna Shadri, Dr. Tejas, Chandrasekhar, and Dr. Shanmugam sir.
Thank you, sir.
Thank you. Thank you very much.
Thank you.
Okay, we have next session is on open house. We are going to meet the experts. I'll be the moderator, and the panelists include Professor S. Venkatraman. He's a senior consultant diabetologist from Apollo Hospital and Surya Hospital, Chennai. Former professor of diabetology, PG teacher and clinical diabetologist for 36 years, publication in peer-reviewed journals, recipient of IDF and Lifetime Achievement Award. And this is, he's a voracious, knowledgeable person, and we always keep learning from him in Chennai. Dr. Venkatraman. And then we have also Professor Anand Moses. He's already been introduced earlier, that senior consultant diabetologist and former professor of Tamil Nadu, Dr. MGR Medical University, former director and HOD of Institute of Diabetology in Madras Medical College, Chennai. He was organizing secretary for RSSDA 2012, chairman RSSDA Tamil Nadu chapter, member postgraduate board of studies, and former member of Senate to the Tamil Nadu Dr. MGR Medical University, EC member, national RSSDA. And we have next Dr. Krishna. Dr. Krishna is already been introduced. And Dr. Krishna Seshadri. G. Seshadri. Somebody. Okay. Dr. Madhavan is a senior diabetologist from Chennai. He has been he was the professor and head of the Department of Diabetology, Government Central Medical College Hospital till about 2011, and also in Dr. Ambedkar Institute of Diabetology, Government Kilwak Medical College. Last position he had was before retirement was Director and Professor Institute of Diabetology, Madras Medical College, Rajiv Gandhi Government General Hospital. 36 years of teaching experience for both UG and PG students. Life member in various organizations. And National Faculty for Public Health Foundation of India, examiner for various certificate courses in diabetology. I've organized several seminars and CMAs, and is most sought after a speaker this part of the country and all over the country as well. Yeah. So I'll be moderating. I'll be moderating this session. We have a few questions to be answered. First thing is that I would like to ask Dr. Anand Moses.
Yes.
The controversy. Recently we had a controversy about the extended release metformin, right? For the information of the delegates, we are trying to cover what we are unable to cover in the main agenda, so that first Dr. Anand Moses will answer the question, and then other panelists also can quickly give your inputs to whatever he says. Sir, Dr. Anand Moses, sir.
Yeah.
the metformin controversy, especially the extended release, recently, it is carcinogenic and
there is some question on the chat box. Someone has put which companies have toxic metformin.
Gauri has
See, the metformin controversy actually started in the United States, where they found a compound known as NDMA, which is said to be carcinogenic in some of the generic sustained release forms of metformin. I believe those companies are not Indian companies actually, and these levels were above the normal acceptable levels, and that is why this controversy came in, and it has been published in the press. And the government, United States FDA had asked them to withdraw the sustained release metformins till this controversy is settled. And one other drug which also had sustained released, drug which had this NDMA level is ranitidine also, I believe. And that's why these two compounds were discontinued. After this news came out, the DCGI instructed all the Indian companies with metformin sustained release to submit a report on the NDMA levels, and none of the Indian companies have this high levels. And India accounts for 40% of the metformin used throughout the world, for your information. And and these companies which were blacklisted also, they were asked to resubmit the fresh stocks with the lower NDMA levels. I think the controversy is almost settled there, and people are using non-sustained release, need not worry about all this at all. And people who are using sustained release from standard companies, I would name the companies, have gone through the DCGI verification, and they are quite safe now. And I don't think there should be a controversy about this any longer.
So you feel we don't need to worry about the safety?
The FDA is 32 parts per billion or some million or something. I think it is less than 6. It's in the single digit in most of the. That's what I was given to understand. And in a lighter way, metformin has got anti-cancer effect. So don't worry.
Yes. So you think even the NDMA levels are increased, it will compensate.
Certain type of cancer can be reduced by metformin. Yeah, been shown.
It's interesting because the thing comes in through the wash process that occurs with these agents, and it's actually a water contaminant for most of these processes. But anyway, definitely the cancer ameliorating thing. We have these storms and teacups too often.
But when anything comes out in the press, it becomes a big problem. Once it comes out in the press, it creates a lot of confusion, and we have been receiving a lot of phone calls from our patients. Shall I continue the metformin? Should I stop the metformin till it is clarified, and so many things. And at one time, people thought it was a conspiracy to throw away metformin by the newer drug companies because to take away metformin from the guidelines.
They could have given a press statement. See, all the companies, so USV, Micro and all, they say this is the upper limit of safety given by FDA.
I think they have given now.
They have given.
They have given.
I think it clarifies for the general public as well.
Yes.
They shared this information only with us. I think they should do it.
Venkatraman, I remember one article in Times of India. It did go through this information.
Good. That's good.
Thing is, Dr. Reddy's lab, they have now come out with their new formulation with reference to vildagliptin. And they clearly mentioned that particular NMDA levels are very low, and it has been accepted by US FDA. That is,
I think what we are suffering from, and this was yesterday. We had a tweet storm with Samit Ghoshal and myself. This is about the controversy with the SGLT2 inhibitors, the new formulation. The important thing is, what is missing in this whole piece is the DCGI being proactive and actually sending out newsletters. It's no longer, it's like, I remember the CDC would do that, the FDA would do that. If you're a registered medical practitioner, these clarifications should really come from the DCGI or some such body, where saying, this is what we're recommending. We shouldn't be looking at FDA all the time. I mean, a lot of time when people ask me FDA, I said, great, it's a surrogate marker for you to look at, but really your country should be doing the due diligence for itself. We shouldn't be looking at EMA and FDA for all our things.
I absolutely agree with you, Krishna.
I think that's what the FDA has, DCGI has done for Metformin. I think they have done a good job.
SGLT2, you mentioned, you initiated the discussion. I think if there is enough bioequivalence data, because being a generic equivalent, it's not a biosimilar, it's a generic equivalent. So bioequivalence study, if it is there, then I think there should be no controversy about the.
Dr. Chandran, you please mute, sir. Because you are speaking when the discussion is going on, you please mute it. Dr. Chandran, please mute.
Yes.
So there, I think the controversy is not about bioequivalence at all. I think there it is more. It's a commercial patent protection that is going on, and we need to see what happens at the end of it. But what I'm saying is, that the DCGI does a great job, but the thing is that it should also communicate to all physicians that, when we open our mailbox, we should have a communication with the DCGI saying weekly, this is what has happened and this is what. I think that's a process that we still haven't done.
Okay. We'll go to the next question. Sir Venkatraman, sir, can you elaborate on the medical nutrition therapy? See, we usually always used to think that medical nutrition therapy in acute situation, regard to enteral nutrition and all these things. It looks like that the medical nutrition therapy seems to be going into even healthy patients in outpatient practice, and there seems to be a lot of evidence to indicate that also. What is your take on that? The medical nutrition therapy, how can it be useful in our practice in the OP?
I think you have decided to extend the session by another 2 or 3 hours, because if you start talking about nutrition, sky is the limit for the time. So my own, I'll just try to summarize my own concept in a in the next couple of minutes. So when you talk about the diet, at least in the context of diabetes, we are conscious of the restriction and the distribution of macronutrients. Micronutrients we are neglecting. Of course, we do have a separate session tomorrow. I'm going to moderate, and there are speakers. So we'll talk on the macronutrients. When you talk about the macronutrients, I think the distribution, I think the ADA and other guidelines are very, very clear. So in a particular individual, you categorize and then calculate the calories and then distribute. Now, there is a caveat. Somebody, supposing a lady who is about, say, 75 kg, she is 5 feet, you will say 155 feet, 1,000 calories plus another 200 calories. To push her from 2,000 calories to 1,200 calories overnight, it is not at all feasible. And it is not advisable also. In my opinion, you have the science, you go through the dietary history of the patient, and gradually you transform this patient, number one. Number two, when it comes to the diet, I think it is more often imbibed right from childhood, the cultural attributes, and then the dietary habits which have been practiced for a longer time to give a diet chart. I do not believe in giving a diet chart which drastically changes the dietary habits of the individual. I'll give an example. Somebody is having 8 idlis. You know that the diet will allow only 3 idlis. Maybe from 8 you go to 6 and then 4 or 3. From 8 to 3 idlis, it's virtually impossible, number one. Number two, somebody who is on an idli, don't ask them to take chapati, because the distribution of the macronutrients should be in such a way you're cognizant of the calories, and also you take into consideration the dietary habits of the individual, which has been happening for decades. So drastic changes should not be there unless some prohibitive substances, for example, huge consumption of saturated fat. So that is with respect to the macronutrients, the carbohydrates. Carbohydrates, I think the chart study, all of us are familiar across the country. In fact, we have done a study, Madhu is aware, in the MMC, Uma did it. Of course, in a very, very lower socioeconomic group, the carb consumption in our OP, which ran into few thousands, was almost 82% of the total calories. 80%. Not 64 or 67, 82%, because they are in the lower socioeconomic group. Number one. Maybe what we can do is strengthen the intake of fiber. I think that can be done, which we are doing it. So that is from the carbohydrate point of view, gradual transition, and then we know about the cap that you can go with respect to carbohydrates. But what I feel is, I think nowadays we are talking about sarcopenia, age-related, diabetes augmented, other chronic diseases augmented sarcopenia. This is accentuated by the protein deficient diet. I think when you look at the diet of the population, especially the Indians, if you look at even people who are non-vegetarian eaters, the protein intake is very, very less. I think probably we need to focus more on the nutrition, because locomotion, the metabolic, I mean, the mechanical aspect of the individual as a whole. We are talking about the metabolic, the mechanical aspect is muscle strength, is bone strength. All these things do matter. And of course, fat, I think even the public are aware of it, because a lot of things have been talked about the saturated fat. I think the portioning of the fat and then the frequency. So I think we have learned a lot. We know how much to give for individual patient with respect to the distribution of the nutrients. Gradual transition has to be there. And quite often, yet another aspect that I found out in the practice, I'm sure all of you will agree with this, whatever diet you give, most of the patients who are either on good secretagogues or on insulin, there's a huge gap in the nutrient intake from the lunchtime, say around 1:30 to evening 8:30 or 9, and hypo happens. So this is where probably the nutritional supplements or dietary supplements are very, very useful. I think nowadays you have scientifically proven, evidence-based nutritional supplements, which are, you can determine the calories that he takes, you can determine the type of the complex carbohydrate that he takes, you can also give an allowance for the proteins and the polyunsaturated fatty acid, whatever you want to give. So in a sense, I think this is a very, very complex subject. As you asked me the question, VG, I think these questions were not in the framed by the scientific committee of Anand, Moses, Krishna and myself. You did it. So I think thank you for this opportunity. But these are some of the random thoughts I thought. I think lot of thoughts will be there with respect to the MNT. Please, yeah.
So basically, I asked this question mainly because you got several formula preparations that are available, and they are promoting as replacing a meal. And your take on that, sir? Basically, the formulas. That's what I would like you to tell the.
I think the look ahead, if I remember that trial, wherein there was one or more meal replaced with what was initially called as glucerna. Now I think it is Ensure Diabetic. This is a complex carbohydrate. I think it has got a lot of meaning in it. It is not as if we are promoting a commercial product. Instead of a patient, see, when you ask him to take a snack, it could be anything. It could be a bunch of cashew nuts, or it could be a pizza, or it could be a puff or a samosa, which most of them are unhealthy. So when you have a meal replacement or meal substitute or partial substitute, either you give 100 calories or 200 calories, you know the type of nutrient that you're giving. It's a complex carbohydrate. There are also added benefits in the form of some small contribution from the proteins and the TUFA. I, for one, recommend for all my patients, especially in a mid-morning snack as well as an evening snack, meal replacement, supplement. Say 3 scoops of your Ensure Diabetic, 100 ml of water, it gives about 106 calories. I think this is a good supplement. It protects them from hypoglycemia, especially somebody is on glimepiride in the morning. So if they are going to not take any calories between say around 2 o'clock to 9 o'clock, they're going for hypo around 5:36. At that time, they indulge in everything. A lot of sweets or
Venkatraman, you said in the government hospital, so the intake was almost 80 to 82%. If you have to reduce the carbohydrate in these lower socioeconomic class, it is very difficult to increase the proteins and fat. Cost is prohibitive. All the formulas which you have said are prohibitively expensive for daily use. Maybe in the sickness in the hospital, in the inpatient, it may be okay. Otherwise, it's prohibitively expensive. It is very, very difficult in the lower socioeconomic class to reduce the carbohydrate and increase the protein content. Very, very difficult.
Can I come in?
Yeah, can I have a word?
Krishna.
So since Dr. Venkatraman and I like to spar, let me do this. I think, if you look at the long-term data, and that includes the look-ahead study, there's really no data to support that manipulation of macronutrients ultimately improves outcomes. It can provide you short-term improvements in A1C. It can provide you some improvements in glycemic variability, but nothing has been shown to provide long-term benefits. I think that statement, I'm sure Dr. Venkatraman will agree with me.
It's very difficult it's very difficult, no? So even in the Looker trial, if you look at it, at the 1.5 years, what happened? Initially, there's a good response. So
and then it goes away.
To have a meal replacement or a meal substitution or meal manipulation, macronutrient manipulation, and then continue a trial, it's, I think, like your UK, it's actually impossible.
Exactly. So a couple of things, one is, you look at many other trials that have looked at this over a period of time. The one thing our patients don't do for weight loss is the only thing that works, which is to lower your total caloric intake. There has been no study that has shown that isocaloric macronutrient manipulation improves outcomes. If you want to improve outcomes, you must lower the calories, right? And when you lower the calories, it really doesn't matter what is the composition, but there is some data to show that in the short term, low carbs work. This is one point, right? So the second point is what people discount is the impact of eating traditional foods, right? In all the studies, there is one thing that is very clear. Processed foods worsen outcomes. So clearly, what you want to tell people is, the way is simple. Eat the food your mom, her mom cooked.
Correct.
There's really no need, but don't switch to a North Indian food or chapatis is no better than rice. But learn to eat small portions. Just to also, this is one part. To also to look at your meal replacement. Actually, that is where you and I probably agree. I don't do meal replacements, but as part of a meal plan, if a patient has difficulty reducing calories, replacing a meal seems to work with a nutrition formula where, for example, lunch or dinner, you substitute with a meal replacement. I don't know if supplements work, but meal replacement seems to work, at least in the limited number of studies. And remember that most of these studies, except the look ahead, were funded by pharma. So we must be very clear about it. But the most important thing that works for diabetics in terms of improving outcomes is, and this is something that Ross Taylor has done so often, is to actually reduce the calories. Eat your mom's food, but eat less of it. I think that is the message we need to start telling people. And of course, cut down the simple sugars.
Thank you. I think we are running very short of time. So I think the next few questions will be answered by a particular person, and then if time permits, we can discuss about that.
You shouldn't have gotten the three of us together and not.
But I wish we have another half an hour so that we can go there.
Vijay, I'm muting.
Next question is quickly, Dr. Madhavan. Can you just shortly tell about the role of C-peptide in type 2 diabetes in general practice? Do you think that it's useful?
Yeah, I would like to deal it in two areas. One, of course, diagnosis, very limited role. Occasionally, to differentiate between type 1 and type 2 diabetes in a very small percentage of patients. Most of the time, clinically, it is possible to say whether somebody is type 1 or type 2, but a small percentage, especially young person, we are not able to differentiate whether it is type 1 or type 2, maybe C-peptide. But again, as a routine clinical practice, I don't think we need to do C-peptide. That is one area. The second, of course, the differentiation between LADA and type 1 diabetes and MODI sometimes, where genetic testing is not available, or you wait for the reports of genetic. Again, literature suggests that the C-peptide may be useful in differentiating LADA and MODI from type 2 diabetes and type 1 diabetes. As far as therapeutic is concerned, we are now talking about precision medicine. We have to decide which medicine is going to work in which person. Of course, recently we had two papers, one from Sweden and other from Mohan et al., about the clustering of diabetes, how people with type 2 diabetes are in a very particular clustering. Maybe, I don't know, the clustering has been done with clinical data, but I don't know whether C-peptide estimation in such a scenario will help us, whether somebody is going to require insulin from the very beginning or they will respond to oral agents. And of course, there are some studies which have shown that which drug will work in a particular person by doing C-peptide. For instance, studies have shown that people who show good response in the stimulated C-peptide test, they respond better to sulfonylureas and metformin. Whereas those patients who have fasting C-peptide level high, they may respond to pioglitazone. This may be very reasonable in the Indian context. Of course, about the recent drugs, DPP-4 inhibitors, the studies have been very disappointing. There is no direct correlation between C-peptide and DPP-4 inhibitor response. But with reference to SGLT2 inhibitors, understand that those patients who have poor C-peptide response may be more prone for diabetic ketoacidosis. So that is one area where C-peptide estimation may be useful in type 2 diabetes. Of course, the future is about the complications of diabetes. For instance, people who have higher levels of C-peptide, they've been shown to be more prone for macrovascular disease, whereas those patients who have less of C-peptide response have been shown to be more prone for microvascular complications. This again may be one area where C-peptide, and of course, one most important therapeutic area is to decide when to initiate insulin. So some studies have even shown that the future need for insulin may be decided by doing a C-peptide response. Thank you.
Thank you, sir. Dr. Krishna, you got a question, very controversial, or the question is that SGLT2 inhibitors is a first-line therapy for type 2 diabetes. Very quickly, your crisp comments.
Maybe I should speak quickly and yield to Venkatraman. Quickly, absolutely, in the right patient. So two reasons. One, I think, is if somebody has come with an established cardiovascular disease to your institution or your practice, and let's say the A1C needs to go from, let's say, 7.6 to 7.2, absolutely. An SGLT2 inhibitor should be and it should be the first drug. Second, this is the controversial bit, and that is information that the subgroup analysis of two studies, both the EMPEREG as well as the CANVAS, where actually patients who were on metformin did not have the outcomes with an SGLT2 inhibitor when compared to those who are not on metformin. And there's a reason for that. And the reason for that is both of these drugs work by hypoxemia inducing factor 1 and 2. Cyclic AMP. But SGLT2 inhibitors have additional action in hypoxia inducing factor type 1 and type 2. When the AMP is maximally stimulated by metformin, SGLT2 does not have the bandwidth to increase it further. So whether this is, most people have discounted this, they simply brush it aside because they're used to metformin for many years. But I think there is a role for not using metformin in some of these patients. The second part is, of course, remember that metformin itself has many other issues which you may want to use. So SGLT2 inhibitors is first line in established ASCVD, in patients with congestive heart failure who come to you for the first time with lower A1Cs. Absolutely, my money is on it.
Thank you. Sir, Dr. Venkatraman, sir, reversal of diabetes, myth or reality? It's a very long session, but I would like it to be very crisp so that we can finish the session as soon as possible.
It is both real and a myth. Real for the simple reason, you identify a target population, follow them for a specific period of time with an intervention, you expect the rate to come down, which has been proven by all the intervention trials, DPPP, whatever you call it. That is, a vulnerable population in whom you expect the risk of diabetes to happen in a particular ratio, when that is being interfered, yes, you have achieved. Now, this is a reality, but this is relative with respect to, number one, the population in question, because you have identified a high-risk population. Whether they stay as IGT, they revert back to normal, or they go to diabetes. This is the scenario. So number two, it's relative for the simple reason, the follow-up. You have got follow-up during the duration of the trial, and then the post-study follow-up you have for 10 years, 15 years. So what we do not know whether this intervention prevents diabetes eternally. So in that way, it's a myth. So in my opinion, yes, the intervention has been beneficial. It has prevented diabetes. It is real, but this reality within inverted commas is limited to the population in question and by the time factor.
Thank you, sir. Dr. Anand Moses.
Yes.
Oral drugs in pregnancy.
Oh, this question has been going on for years together. I think the first oral drug which was tried in pregnancy was glibenclamide, by a good paper by Langer et al. I think about 10-15 years back, or even more than that. And it was extensively used in many countries, even in some centers in India. But it fell into disuse because of the increased neonatal hypoglycemia and of some of the side effects of glibenclamide. So it is no longer used. Probably the only other drug which is being used is metformin, where people pre-gestational diabetes on metformin or PCOS on metformin continue to use metformin. But again, none of the guidelines really say you have it used as a first line drug, except probably the NICE guidelines. NICE guideline, the only guideline which says you could start with the metformin. But please remember, metformin crosses the placenta. Metformin in small amounts crosses the placenta in the first trimester and extensively in the third trimester. In a mature placenta, there is extensive crossing over. Still, we do not know many of the effects, but many of off-label, many of us continue to use. I continue to use in many of my patients, particularly when my GDM patients require very high doses of insulin. Metformin comes to the rescue. We do use metformin, but please remember it is mostly off-label by any of the Indian guidelines.
Vijay, just a quick rejoinder to what Anand said.
Yes.
There is a trial called MITI trial, which we are going to take up in the next Journal Club discussion. Beautiful trial, about 7 years, 8 years follow-up from Canada and Australia, 28 centers, about 500 to 600 subjects, metformin and non-metformin on top of insulin. The primary outcome was the same. The secondary outcome, maternal secondary outcome, with respect to insulin requirement, weight gain, hypertension, they were favorably impacted by metformin. And from the point of view of the offspring, the birth weight, as well as the CORD C-peptide, they were, in other words, after this trial, this is the MITI trial, metformin in type 2 diabetes trial. It has just been published. We're going to take up in the discussion. I thought our delegates.
Yes, there are a lot of trials, Venkatraman.
Trial, I expect the guidelines to be revised because this is an RCT evidence of metformin in pre-gestational diabetes, how it has satisfactorily. But you do not know what will happen to the offspring, say 10 years, 20 years, 30 years later. That is speculative. But as on date, the evidence is favoring much more robust positioning of metformin in pre-gestational diabetes.
Yes, but till it comes into the guidelines, Venkatraman, till it comes into the guidelines, I think probably we'll have to wait.
Just share scientific information.
Yes.
From this point of view, not a drug.
If I am permitted, as a follow-up of what Dr. Venkatraman said, one more study, a follow-up of infants of diabetic mothers. It has shown that these children have more of subcutaneous fat than the
central adiposity.
That is the milk tofu.
They are those children with metformin.
So, of course, there are AGIs, particularly acarbose has been used in some centers. Some people use acarbose. There are a couple of doctors in our state also use acarbose. But again, being a postprandial hyperglycemia, probably acarbose may help. Again, we do not have robust studies with acarbose, though it is not absorbed. But 2% gets absorbed, actually. 2% of acarbose gets absorbed. We still do not know the long-term outcomes. But some doctors do use acarbose.
So from a practice point of view, the issue is not just a drug. It's a question of monitoring. A lot of patients, they don't have a problem with the insulin. They have a problem with the monitoring that you ask them to do.
Krishna, pregnancy, I don't think there is a problem with monitoring. I think 99% of my patients on pregnancy, there is no problem with monitoring at all.
No. What gynecologists and everyone else think is that you can put the drug on and then forget it. The thing is that the monitoring requirements are the same. Yes. You want to be vigilant. You want to make sure that the sugars are measured. So the added insulin is really not a big issue. All I'm saying is that, sometimes when we advocate OHAs, we need to make sure that we also say, look, while there may be no issue with the drug and its effect, the issue is that you shouldn't stop monitoring and giving it the importance. When insulin is there, people are ready to monitor. When OHAs are there, this tendency to monitor drops off. I think that is the point I was trying to make.
No, this is metformin on top of insulin.
Most often.
Yeah.
Exactly. Yeah. Exactly. So, but all I'm trying to say is that there are people who just start them on metformin or another OHA. The important thing is that, that the monitoring doesn't stop. It is actually a little more issue.
Okay. Thank you, the panelists, about elaborate discussion. Sir, Dr. Madhavan, sir, how about oral drugs in diabetic kidney disease?
So the moment we say diabetic kidney disease, the immediate worry is hypoglycemia. So that is one area we have to be very take care about using oral agents. As far as sulfonylureas, if you want to go, allow me to go by each oral agent. As far as sulfonylureas are concerned, I think it is always better, even when somebody has microproteinuria or macroproteinuria, leave alone end-stage renal disease. You have to be, one has to be very cautious. Even the modern sulfonylureas like imipiride and glyclazide. Maybe we can use it in reduced dose with good monitoring, but one has to be cautious about hypoglycemia. Of course, pioglitazone is totally contraindicated in diabetic kidney disease. DPP-4 inhibitors, we all know that all the DPP-4 inhibitors can be used. Of course, for sitagliptin and vildagliptin, we have to reduce the dose. Well, linagliptin, there is no need to reduce the dose. Now they say even for teneligliptin, there is no need to reduce the dose in diabetic kidney disease. Of course, SGLT2 inhibitors, we know there are restrictions about the EGFR. I think probably below 30, I may be a little reluctant to use SGLT2 inhibitors in those patients with diabetic kidney disease. Of course, my choice will always be in moderate to severe kidney disease insulin. None of the oral agents, I think, are suitable for moderate to severe. But in mild to moderate, yes, maybe you can continue the oral agents with good monitoring to avoid hypoglycemia.
Yeah, thank you, sir. Dr. Krishna, the last question of the day for this open house meet the expert session. How about dementia and diabetes? How big is that, and how is it we can manage? Unmute.
So you're asking me at a time when I'm probably sundowning. So there is. So remember, it's very interesting to think about dementia and diabetes from even a pathophysiologic perspective. Remember that insulin resistance in the brain is one of the reasons that you get Alzheimer's dementia. And clearly, patients with diabetes who are uncontrolled over a period of time do have cognitive losses. Now, one of the theories that has always been is looking at recurrent hypoglycemia and its effect on dementia and diabetes. There have been a lot of short-term studies which seem to suggest it, but you will see that when you add multiple regression factors, these cancel out. When you see dementia and diabetes, what should you do? One, make sure that you've gotten thyroid function tests and B12, and make sure something reversible is not there. And remember, especially if patients are on metformin, that you want to make sure you know their B12. This is the least you can do. Second, get the family involved. Third, simplify the regimen. I think this is something that most of, I don't know how many of us do this, but one of the things that we should do at least once in 3 months, ask them to bring their medicine boxes. Clear it out and see. You will see like Harry Potter's chest. You'll have layers and layers of drugs that are not being used, and the patient popping it up a lot of times. Always think of drugs when you see these kind of things. Then talk to the family about forgetfulness. Talk to this is where our role as clinicians and the art comes in. I don't want to go into a long discussion. There are no drugs that we know of that will prevent the progression of dementia. What you want to make sure is that they don't become hypoglycemic, that they don't fall, that their family supports them, that you simplify their regimen, and make sure you also loosen up the targets that they don't become further hypoglycemic. How do you prevent it? Early intervention in diabetes, do all the right things. Don't use drugs that they don't have to. I think that's where we are. I hope that was not too long.
Role of insulin and the DPP-4 inhibitors in delaying or progression reduction in dementia and Alzheimer's.
So the data is actually with insulin in an inhaled form. When inhaled insulin has been used, there has been improvement in some motor stability, some cognitive improvement, more in Parkinson's than in anything else. Second, inhaled GLP-1. When inhaled GLP-1 has been used, there has been benefit. I am personally there are 2 studies with sitagliptin. One, just to bring Dr. Venkatraman's previous discussion on this in delaying sarcopenia and improving sarcopenia. The second, which is a smaller study that looked at cognitive improvement. It's too small for me to say that DPP-4s are useful, but certainly in an elderly person, DPP-4s prevent a lot of damage by simply avoiding hypoglycemia. So that's what I would look at it. But the future is, of course, with these inhaled therapeutics, especially GLP-1.
Thank you. Excellent open house discussion. I'm so happy about that. But unfortunately, we are short of time, but still we managed 45 minutes. I wish we got more time about that so that we could have discussion. Thank you, Professor Anand Moses, Professor Venkatraman, Professor Madhavan, and Professor Krishna Seshadri. Excellent. It was excellent. Really great. Really great. Really great. Now we move on to the last session of the day. To do with this, we have a chairperson, very experienced and senior diabetologist from Coimbatore, Dr. J. Giri. He is an excellent speaker, very knowledgeable person, and he will take us into the next 45 minutes or so. Sir, I would like to request you to finish at least a bit earlier than what we could say because we're running short of time. Dr. Giri, sir, thank you. Take over, sir.
Thank you, Dr. Vijay Kumar. I'm personally very happy to see you in virtual. Soon we will meet in person. We will hug.
Thank you.
Thanks for the opportunity. Then, Dr. Shanmugavel, good evening.
Very good evening, sir. Very good evening.
Very happy to see you. Now, Dr. Shanmugavel is here, who is going to talk to us on timely insulin initiation, especially 2-in-1 solution for the total control. We all expect that the diabetic patient should have an excellent total control. What I mean total control is fasting and postprandial should be in control. Thereby, the HbA1c will be in the desired level. Preferably, what we do, we start with a lifestyle modification. Then we all add metformin. If it fails, we increase the oral hypoglycemic agents. During the course of the treatment, invariably, one day or other, the patient needs insulin, either due to exhaustion of the beta cells or due to sepsis or whatever it is. When HbA1c is high, either fasting is high or PP is high or both. Mostly in our Indian scenario, who takes a high carbohydrate diet, this is the postprandial sugar is very high. Controlling the postprandial sugar, if not done timely, then that leads to macrovascular complication, to a certain extent microvascular complication. To prevent all this macro and microvascular complication, you should initiate insulin in time so that the patient will be better in the future. When insulin is initiated, there are many inertias, both from the patient as well as from the physician side. To talk about more, here comes Dr. Shanmugavel. He's my very close friend for decades and decades. At present, he's a consultant diabetologist in Trichy. He had his postgraduate from
Okay, Giri, sir, I have been already introduced in the morning. I think we can cut short off.
Okay, my dear, you need not be introduced, accustomed to give respect to speak. Okay, then one thing I want to tell you, you are very excellent in presentation. Even the difficult subject, you'll make it very simple. Over to you.
Yes, thank you, sir. I'll share my screen. Can you see the slides, respected chairpersons?
Yes. I could see
Yes,
your
co-speaker, Dr. Shruti Chandrasekharan, learned viewers and listeners of this program. I feel extremely happy, honored, and most privileged to have been invited to make a presentation on timely insulin initiation, the 2-in-1 solution for totality of control with a particular focus on insulin co-formulation. I thank Dr. Vijay Kumar for inviting me to share my views on this particular topic. I thank Dr. Giri sir for his generous introduction. My disclosures, what I'm going to do for another 20 minutes, timely insulin initiation, the 2-in-1 solution for totality of control. Type 2 diabetes is a multi-causal, heterogeneous, progressive cardiometabolic condition. The progressive nature is one of the major challenges, so getting the patients to goal becomes challenging as the disease progresses. Multiple intervention will need to be used while managing diabetes as the duration advances. So despite major recent advances in diabetes care, large proportion of patients remain in poor glycemic control, necessitating the need for the development of new therapeutic options. So recent literature on the diabetes in aging study confirms that strict glycemic control within first year significantly improves the risk of micro and macrovascular events and mortality. So insulin therapy is the most effective, suitable, well-tolerated, safe in most of the patients whose glycemic control is not achieved with oral anti-diabetic drugs. So my financial disclosures. So the challenges of managing diabetes in India. The Indian reality is that people with the diabetes in India have high carbohydrate diet, high PPG levels, patient uncontrolled on multiple OADs, the need for simplicity and convenience. So what is the pragmatic solution for Indian realities of type 2 diabetes management? There should be need for a therapy which should tackle the postprandial hyperglycemic levels. And very important thing is it should provide the totality of control, effectively addressing both fasting as well as postprandial, and it should allay the fear of hypoglycemia of the major meal. So high carbohydrate diet is the common Indian reality. This particular study conducted by Shashank Joshi et al. Across different regions of the India, they assess the percentage of energy contributions through carbohydrate. So they conveyed that across different parts of the India, 61 to 70% of energy intake in Indian carbohydrates present in the diet. So high carbohydrate diet reduces the plasma glucose levels and is one of the major reasons for high PPG levels after major meals and leads to uncontrolled HbA1c. So more is the carbohydrate intake, more is the associated risk of mortality. So the relation between macronutrient and cardiovascular disease and mortality is controversial. This field study is a large cohort study that assesses the association between the consumption of carbohydrate to the cardiovascular disease and total mortality. So 70% significantly higher mortality in those who consumed higher carbohydrate diet versus moderate carbohydrate diet. So the patients were categorized into 5 groups and different quantiles depending upon the intake of carbohydrate. So Indian diet, 61 to 70% of energy intake through carbohydrate. Western diet comprises 39 to 47% energy intake through carbohydrate diet. So Indian diet, I told you, so 17% significantly higher mortality in those who consumed higher carbohydrate diet versus moderate carbohydrate diet. So the conclusion of the study was 28% higher mortality in those who derived 77% of total energy from carbs compared to those who derived only 46% of total energy from carbs. Right. Next is what are the clinical implications of high postprandial glucose with reference to macrovascular complications. So the left panel contains the studies and the right panel shows the relationship of PPG to macrovascular complications. So post-meal hyperglycemia exerts a harmful impact on carotid endometrium thickness, and 2 or post-load glucose level is a better predictor of risk of all-cause and cardiovascular mortality. And high PPG level increases the risk of CVD and mortality, and the post-meal glucose level is associated with CHD. So cardiovascular disease and mortality are associated with the postprandial hyperglycemia. So clinical implications of high PPG, its correlation to microvascular complication. This particular study was conducted by Dr. V. Mohan et al. So the prevalence of vascular complication, it was assessed in the South Indians. So the dependent variability included in the studies were nephropathy, neuropathy, and variable tested PPG, and the odd ratios, and the statistically significant impact P values. So variability PPG, no retinopathy and subretinopathy. So postprandial hyperglycemia is associated with increased risk of diabetic nephropathy, neuropathy, retinopathy in Indian people with type 2 diabetes. So unlike Western population, the PPG should be controlled at all levels of A1C in Asians. So the Modi et al. Studied the relative contribution of postprandial glucose level decreased progressively from the lowest to the highest quantile of A1C, whereas the fasting plasma glucose, as shown in the gray color, that increased significantly with worsening of the glycemic control. So very important thing. So the relative contribution of postprandial, according to Modi et al., it has yielded a controversial or conflicting report. So the study conducted in Asian Indians, which showed significant contribution to PPG even at the higher A1C levels in Asians. This particular study was conducted with CGMS data, unlike the Caucasian data from Monier et al. So uncontrolled glycemia in Indian demands timely treatment optimization aiming for totality of control, controlling both FPG and PPG. So in Asian patients with the type 2 diabetes, the postprandial glucose 24 hours and 4 hours after meal was a predominant contributor to excess hyperglycemia in well-controlled patients, number one. And what is most striking is that PPG was equally important as EPG or preprandial glucose, even in poorly controlled patients with mean A1C up to 10% and higher. So PPG contributions are more both in patients with well-controlled as well as in poor glycemic control. So evidence from Indian studies, high PPG and high A1C levels. And this particular study, that is the DiveCare study, clearly shown the fact that vast majority of patients with diabetes in India remain suboptimally controlled. Next is the IMPROVE trial. This baseline data confirms the global nature of poor glycemic control in patients with the type 2 diabetes, and that the insulin therapy is commonly delayed in clinical practice. So uncontrolled glycemia in India demands timely treatment optimization and insulin therapy. So vast majority of patients with diabetes in India remain suboptimally controlled and need for more structured intervention at an early stage of the disease. So bridging barriers to therapeutic inertia. So achieving glycemic goals by timely treatment optimization. So this light blue color represents the conventional step care approach. So patients are exposed to relatively long periods of uncontrolled hyperglycemia, greatly increasing the risk for diabetes-related complications. So the dark blue, that represents the A1C goal-oriented approach. So the patient achieves the targeted A1C within a short period of time, minimizing the glycemic burden, reducing the risk of diabetes complications. And this involves early combination therapy. And this has been supported by most of the national as well as international guidelines. So why is timely insulin initiation particularly important in Indians? This particular study was conducted in PIMA Indians as well as Asian Indians. They look into the plasma glucose level, plasma insulin level, insulin resistance, as well as insulin secretion. Even with normal glycemia, Asian Indians had lower mean fasting insulin secretion as compared to PIMA Indians. Following a 75 grams oral glucose tolerance, Asian Indians exhibited a significantly lower 30-minute insulin levels compared to PIMA Indians. So this clearly confirms the heterogeneous pathway of type 2 diabetes in the early natural history of disease, emphasizing insulin resistance in PIMA Indians, and Asian Indians had secretory defect with reference to insulin secretion. Right. Physician factors leading to therapeutic inertia for insulin therapy. There is a barrier for initiating insulin, there is a barrier for titration, and there is a barrier for intensification. So perception and inaccuracies in healthcare professional, assessment of patient preferences, concerns, and self-management skills. That is regarding the overestimation of injection fear, concerns about adherence, and lack of diabetes self-management skills, and perceptions regarding patients' prior non-adherence. So insufficient time, lack healthcare professional knowledge and experience about insulin therapy, and language barriers. That is number one. Patient factors leading to therapeutic inertia for insulin therapy. That is misconceptions in the minds of the patients. That is lack of self-confidence, opposing views, distress, financial burden, social stigma, fear of injections. With reference to insulin therapy, they perceive representing what's a healthy disease. It is a punishment for having failed the diabetes control. Unrealistic fears of adverse events such as weight gain and hypoglycemia. So the above misconceptions and realistic concerns lead to a phenomenon often referred to as psychological insulin resistance in people with type 2 diabetes. So patient healthcare professional interactions that interfere with insulin therapy. So discussions about A1C results by healthcare professional, describing a person as uncontrolled, non-adherent, and having failed oral hypoglycemic agents or lifestyle changes only further blames and judges people and this. And patients are reluctant to discuss self-care problems, trust, non-judgmental acceptance, open and honest communication. That is number one. Possible solutions to insulin therapy in inertia. That is healthcare professional actions. So begin discussions in a collaborative communication style, discuss health benefits of treatment targets, explain that treatment changes are a normal part of living, explain benefits of insulin therapy, address injection concerns about demonstrating the actual injection process, assess and address patient concerns. So the above key healthcare professional actions, they are linked with either insulin initiation and greater insulin persistence over time. And next is patient actions, knowing that with some care and effort, long and healthy life with the diabetes is possible. And learn early on about how diabetes, type 2 diabetes changes over time. Addressing concerns about diabetes and insulin therapy. Viewing the healthcare professional as being on the same side can facilitate a trusting relationship, that is focused appointments such as designated diabetes visits to minimize the compelling demands. So individualizing insulin therapy in real to Indian realities, I'm going to discuss a case scenario. So Vinita Pillai, 54 years, female, presenting with burning pain sensation and numbness in feet, housewife, type 2 diabetes for 8 years, hypertension with glaucoma, body weight, body mass index, fasting plasma glucose, PPG, and PPG post dinner 286 milligram, and A1C 9.3, blood pressure, serum creatinine. Currently on Metformin 1000 milligram BID with Lazertin 50 milligram BID, glycoside extended release 60 milligram OED. So main points of discussion. She lacks diet control, high carbohydrate intake, limited housework, high A1C, stable OAD therapy is inadequate, needs insulin therapy that can control both FPG and PPG levels with convenience. So RSSDA, Endocrine Society of India Clinical Practice recommendations, the provider should avoid using insulin as a third and should work to alleviate patient anxiety about hypo, dependence, injection site pain, etc., commonly admitted to insulin. And insulin therapy should be considered in all patients failing to achieve glycemic targets on 3 oral agents. So the recommendation is for insulin initiations. Initiate with once daily IDAG ASPA, or if the patient fails to achieve optimal levels of A1C control, intensify with the twice daily IDAG ASPA. So IDAG ASPA and insulin co-formulation. This co-formulation is base insulin with the bolus insulin in a single injection can mimic physiological insulin closely, unlike basal insulin alone. Very important thing is it avoids the shoulder effect and variability of proteinated premix insulin, thereby reducing the risk of hypoglycemia. And very important thing, it simplifies the insulin regimen and lowered the injection burden. So the conventional human premix insulin, because of the proteinated component, it can interfere with the pharmacokinetic and dynamic profiles of the short-acting soluble insulin. So the factors facilitating successful insulin initiation, don't miss the bus again. So with reference to the control of PPG, control of FPG, the suitability in case of delayed insulin therapy, simple initiation and explanation with reference to understanding of the therapy with reference to patient point of view, easy monitoring and titration, use of single device, and offer subsequent intensification, OD, that is once daily IDAG ASPA, scores over once daily basal insulin. Though it contains the combination of IDAG ASPA as well as insulin degludec, the components, that is pharmacokinetic and dynamic properties of the both the components are retained. There is no interaction when it is injected in the subcutaneous tissue. The rapid component releases very quickly so that it can take care of the prandial glucose excretion, and the basal component takes care of the basal plasma glucose level. So IDAG ASPA can be a pragmatic solution for Indian realities of type 2 management at insulin initiation because it tackles high carbohydrate diet with a major meal. And it provides totality control, effectively addressing fasting hyperglycemia without neglecting postprandial hyperglycemia, allays the fear of hypoglycemia with the major meal. It suits a dietary pattern administered with a flex touch and one injection, one delivery device, and one titration algorithm, and it makes the therapy convenient and simple. So the indication for using insulin co-formulation, start and stay therapy, patient uncontrolled on OAD, patient uncontrolled on basal insulin, patient uncontrolled on premix insulin, patient uncontrolled on basal bolus therapy. These are all the types of patients we come across in our day-to-day practice. The patient type includes type 1 or type 2, more than 18 years, elderly with type 2 with renal and hepatic impairment, and type 2 diabetes with comorbidities. So comparison of IDAG once daily to insulin glargine U100. So this particular 26 weeks open label treat to target trial investigated the efficacy and safety of insulin degludec with insulin aspart in insulin-naive Japanese patients with type 2 diabetes. So if you look into the A1C, and the A1C, there was significant reduction, superior reduction in A1C with the IDAG aspart compared to IGLAR. Next is significant reduction in PPG after dinner with IDAG aspart. That is very significant compared to the breakfast, wherein both the treatment groups achieve similar reduction with reference to fasting plasma glucose. So similar FPG control with a 70% basal component with IDAG aspart. And if you look into the risk of hypoglycemia, lower risk of confirmed hypoglycemia with IDAG aspart compared with IGLAR. So unaddressed PPG spikes after the major meal because basal insulin glargine lacks the prandial component of IDAG. So in that way, IDAG aspart confirms its superiority. So the basal insulin has actually failed indirectly bring the post-dinner levels with normal range despite providing similar FPG and pre-meal control. It shows the perfect harmony between bolus component insulin aspart and the basal component insulin degludec, with IDAG aspart is dosed with the major meal. So once daily IDAG aspart offers significantly better PPG control after the major meal missed by basal insulin. So in patient uncontrolled on OADs, insulin initiation must offer better efficacy without compromising on safety. So IDAG aspart blue in color, Aglar that is gray in color. So percentage of patients achieving the targeted A1C, that too A1C less than 7% without hypo. More number of patients in the IDAG aspart group achieve this. So with IDAG aspart, 72% more patients achieve the target without experiencing hypo versus once daily Aglar U100 in insulin naive type 2 patients. So once daily IDAG aspart offers significantly better PPG control after the major meal missed by basal insulin. So IDAG aspart provided superior long-term glycemic control compared to insulin glargine with similar FPG and doses and numerically lower rates of overall and nocturnal hypoglycemia. So let us come back to our patient uncontrolled on multiple OADs, her SMBG profile before breakfast, after breakfast, before lunch, after lunch, before dinner, and after dinner. So the patient also confirmed that she eats more at dinner. So IDAG aspart was initiated before dinner, and metformin vildagliptin was continued, glycoside was discontinued, and this was initiated, that is insulin IDAG aspart 10 units with the dinner, titrated to 20 units for 12 weeks based on FPG level. At the end of 12 weeks, FPG 114, post-breakfast 148, post-dinner 156 milligram, and A1C reduced from 9.3 to 7.2%. So IDAG aspart, it is available in user-friendly delivery device. The main characteristics of such includes no push button extension, end of dose click, and very low dose force is required to inject insulin, accurate and consistent dosing from 1 to 8 units, and easy touch button. And summary and learnings, patient had inadequate glycemic control despite being on multiple OADs. Insulin initiation was required for better control and to reduce the risk of complications. And the diet was assessed, and need for control of both FPG and PPG was felt as important, and total control with IDAG aspart at insulin initiation helped achieve the desired results. So my doctor friends, please remain safe, take care, stay healthy, protected, and connected in the days to come. Now I stop sharing my screen. I'm sending to
Dr. MSV Shanmugavel, excellent.
Thank you so much.
I called MSV thinking that they're a musician, MSV, singer.
Yes.
You did elaborately well. You said that 70% of the energy is from the carbohydrate, and you said high PPG is leading to cardiovascular mortality. And you also emphasized why timely insulin initiation is very important in Indian scenario. And with a beautiful case study, you said the IDAG is much superior in controlling the fasting, PPG, convenient to use with less hypoglycemia. Beautiful presentation. We will wait till the next speaker completes her presentation for the question and answer session. Dr. Shruti Chandrasekharan.
Yes, sir. I'm here.
Am I audible for you?
Yes, sir. You're audible for me. Am I audible?
I'm very happy to see you and talk to you and say good evening from my end.
Thank you, sir. Same here. Thank you.
Dr. Shruti is here. At present, she is a consultant endocrinologist in Reela Institute of Medical Center, Chennai. Also visits Sri Vikas Center of Hormone Health and IIT Madras. Earlier, she was a visiting endocrinologist in Global Hospital and Adayar Cancer Institute. Before getting as an endocrinologist, she did her undergraduate in Kirpak Medical College. Then she moved over to UK and had an internship, moved over to USA in Philadelphia. She had an internship with Albert Einstein Medical Center and also worked sometimes in New York. Now Suniti is with us and she is going to talk to us about recent evaluation in bolus insulin, that is bridging the gap with the physiological PPG control. Over to you, Shruti.
Thank you, sir. Thank you very much for that kind introduction. I'll share my slides now. It's open here. So, we had a great lecture by Dr. Shanmugavelu sir on the co-formulation, which is IDEC ads. So, I'm going to shift gears. I'm going to talk only on bolus insulin. This is after we fix the fasting sugar first. So, in an ideal scenario, if your patient comes to you, you fix the fasting sugar first with a basal insulin, say degludec. You have, and if the postprandial glucose still contributes to the uncontrolled blood glucose, we, according to the
Dr. Shruti,
guidelines,
your slides are not seen.
Kindly share your screen, Shruti. Kindly share your
Sir,
screen.
I'm sharing
It
my
is
slide. Can you?
no.
You can't see my slide?
We are seeing your face only.
Oh, okay. Can you see it now, sir?
We could hear you, but not the slides.
Just a second, sir.
Take your own time.
Can you see it now?
Yes.
Yes.
Yeah.
Yes. Good.
Yeah. Thank you. Thank you.
Very good.
So, yeah, as I was telling, once we fix the fasting sugar first, according to the guideline, if the postprandial blood glucose are still contributing to uncontrolled sugars, we have the option of either adding a short-acting prandial insulin or a GLP-1 receptor agonist. So for the next 20 minutes or so, I'm going to be talking on the recent evolution in bolus insulin, specifically on faster aspart, which is now available as Fias, right? So that is going to be my talk for the next 20 minutes. These are my disclosures. So I am a key opinion leader for Novo Nordisk, and I've been financially supported by Novo Nordisk for this promotional talk. So with that introduction, so my main agenda for today's talk is one, we will understand the physiological postprandial glucose. I think Dr. Shanmugavelu sir has beautifully pointed out the importance of postprandial blood glucose in the contribution of HbA1c and uncontrolled diabetes and also cardiovascular disease. And we will talk about if we have this postprandial blood glucose contributing, are there any recent innovation in the management of postprandial hyperglycemia with the faster acting aspart that is commercially available? And I will also briefly touch on the inpatient hyperglycemia and how this faster acting aspart can fit into our practice. With all the agenda of the main presentation, I will also share some important take-home message or how we can practically apply this to our clinical practice. So we would start with a poll question. I know there is no poll answering option here, but in your patients, what do you target for optimal postprandial glucose, right? So many of us do it differently. Most of us prefer the pre-meal or the 2 hours postprandial glucose, and pregnancy about 1 hour postprandial blood glucose. It'd be interesting to see the poll, but for us to understand the importance of 1 hour post-meal glucose, which can itself be a talk for the next 20 minutes, I would start off by saying this is a very short, beautiful review from Italy, which was published in 2017, which talks about targeting the 1 hour post-meal glucose. Well, would it be a better paradigm shift in the diabetic management, throwing some data on cardiovascular disease and also the future risk of diabetes in patients with oral glucose tolerance test? I have also made few slides out of this brief review that came out. And this is just to sort of point out to start with, as Dr. Shanmugavelu sir has said, the postnatal glycemic surge for the common Indian food in type 2 diabetes, whether it's North Indian food or whether it's idli chutney, happens the first 30 to 60 minutes. And this is what was shown in this study here, looking into the glycemic index of different food that was consumed by patients to see where exactly the spike happened, right? So the highest surge happens 30 minutes to 1 hour. So we, in an ideal situation, if we have an insulin that would address this, that would be really valuable in our practice. So the question that we need to ask ourselves is, does monitoring 1 hour blood glucose, would that add something to our hyperglycemia management? And do we have a mealtime insulin that can address your 1 hour blood glucose, also address the 2 hour blood glucose with a lower risk of hypoglycemia? That is what I'm going to be talking for the next few minutes. So what are the clinical implications of 1 hour blood glucose? This is from our own data, Dr. Mohan's group here. looking at the 1 hour blood glucose data in an oral glucose tolerance test, and they summarized from this trial that 1 hour blood glucose value had a higher area of under the curve compared to the fasting blood sugars in predicting the future risk of pre-diabetes or diabetes. So the 1 hour blood glucose, if we do in our patients and we are reviewing the results, it's good to look at the 1 hour blood glucose as well, just not only the fasting and the 2 hours blood glucose, because that could predict that patient's future risk of diabetes. And this is exactly what was shown in the next Swedish trial, the Israel study, pardon me. This is from an Israel follow-up study for 33 years. If you look here, there are 4 groups. I would just highlight the group B for you. If you look at the 1 hour blood glucose value, the postprandial glucose, it's more than 155. And if you look at the 2 hour value, it's less than 140, right? So according to this, imagine fasting blood glucose is normal. So this is normal glucose tolerance test because the 1 hour fasting is good and the 2 hours is within the target. But if you look at the 1 hour, they actually categorize these people to 4 different groups as pointed out here. And as I told you, just concentrate on group B here. If you look at the group B, if you look at the mortality rate, and they follow these people for 33 years, they said even if patients have a 1 hour postprandial glucose value that's more than 155, there is a 28% increased risk of mortality. So that signifies the importance of 1 hour blood glucose value in even screening purposes for our patients with diabetes. Are there any confirmed data? No, there are possible mechanisms. We did talk about the cardiovascular data when Dr. Shanmugavelu was presenting, but there are also animal studies and mechanistic studies looking at the possible mechanisms by which it can cause. It increases the arterial stiffness, increases the LV mass, causes endothelial dysfunction. The carotid intimal medial thickness is directly correlated with the 1 hour blood glucose value. So all these things could lead to an increased cardiovascular disease and perhaps worse outcome in patients who have an increased 1 hour blood glucose value. So other target recommendations, well, it depends on what guidelines you follow. Now the A says 2 hours blood glucose value, but the ADA or the ESD says time after meal you can monitor 1 to 2 hours if you do a SMEG for your patients, but a lot of us do pre-meal as well. So, I mean, I'm not saying you need to completely change your practice because of the talk. This is something to keep in mind, that this is also there in our guidelines. It's also recommended by professional societies, targeting postprandial glucose after 1 hour, and also sort of looking into the importance of getting the 1 hour blood glucose, not just in pregnancy. I know in pregnancy we all go by numbers. I think this is also valid in patients who are otherwise coming to our clinic. So moving on to the second part of my talk, what is the innovation in the management? So up until this point, if you remember, the first review that I showed talks to you about why the 1 hour sugar is important. They also, in this brief comment at the end of the review article, say that up until this point, we didn't have a molecule that was so efficient in addressing this 1 hour postprandial blood glucose level, and perhaps that is the reason why we were targeting the 2 hours blood glucose value or the pre-meal value. So imagine if we have a molecule or an innovation that would help us in the management of this postprandial hyperglycemia, right? So here, we all know this. This is a regular human insulin. We need to give this 30 to 40 minutes before the meal, and this is how it acts, right? And this is a normal physiological insulin secretion that happens in our pancreas. This is a gross difference that we see. I'm not saying the human insulin is, as far as the efficacy is concerned, if you need to get your glucose under control, most certainly use it. But then came the analog insulin, the Glulysin, Lispro, and the Aspart that we still use in our practice, right? That is very, very close to our physiological insulin secretion. And then up recently, we had this faster Aspart, which is an ultra fast acting, short acting insulin, right? What did this do? This shifted the curve to the left. So it had a better approach for physiological insulin, especially in patients with type 1. And we also have studies in insulin clump studies in type 2 patients. And it replaces the early insulin secretion in patients with type 2 diabetes. And it has a better glucose control with a lower rate of hypoglycemia, which I will be showing in the next few slides. So now we have an insulin that is very close to the physiological insulin that happens from the normal pancreas. So how does this change our practice? So how does this happen? This is a molecule of insulin aspart. To this, you add a niacinamide, which is a vitamin B3, and L-arginine. Both are FDA approved. The L-arginine is basically for the stability of the insulin aspart once it's injected. And the niacinamide is it sort of increases the absorption. So basically, once you inject the insulin, if you attach it to niacinamide, the insulin that you inject gets fastly absorbed into the bloodstream, and it goes and acts as the insulin receptor, targeting whatever insulin would do, right? And the niacinamide is also shown to increase the vasodilation in the skin, the way you inject, especially in the animal studies, whereby it also has shown to increase the absorption of the insulin that is injected. So what exactly happens is it's shown in this cartoon. So once you inject the insulin, it breaks into the hexamers, break into the monomers, and this is what happens. This is a cartoon. So this is what happens in the human insulin. It sort of dissociates very slowly, right? And this is what happens in faster insulin aspart. So it rapidly dissociates and it reaches the bloodstream, right? And once you give the insulin, within few minutes it's there in the bloodstream and it works in the insulin receptor. And this is possible because of the excipients that we add in terms of arginine, not more than arginine. Arginine is for more for stability, and niacinamide, which helps with the absorption of the insulin, right? And this is a PK/PD property. If you look through the darker blue lines, that is for faster aspart. Here we are comparing it with a regular insulin aspart. So what this PK property has shown is, as I showed you, there is a physiology, the shift is towards the left of the curve, which means it has twice as fast onset of appearance in the bloodstream, twofold higher insulin exposure in the first 30 minutes of injection. So it works very effectively, very quickly. And if you look to the total and the maximum exposure of the insulin between the aspart that we're using versus the faster aspart, so there is a similar total and maximum exposure to the insulin, and that is what is shown here. And here in the 12th minute, if you look through this diagram here, this shorter duration of exposure is the insulin dissipation rate. That is actually 12 minutes earlier for the insulin aspart, also sort of correlating with the lesser risk of hypoglycemia that happens at the 3rd and the 4th hour after giving the short-acting insulin, right? And if you look at the PD properties with a glucose clamp, which was done in type 1 and type 2 diabetes, this is a pooled analysis of 3 studies, again looking into the regular aspart versus the fast-acting aspart or the faster aspart or FIAS, which just shows you here that 74% of the greater insulin action happens in the first 30 minutes of insulin injection. So it's a very quicker action of insulin that we inject into our system. So how does this translate into my practice? You know, we have talked about a lot of graphs and PK/PD properties, etc. One, it gives me the flexibility for my patients. I know I can give this insulin like 5 minutes before or as soon as the patient starts eating, or 20 minutes after start eating the meal, right? So I can give this according to the patient that is sitting in front of me. So it's very flexible for the provider and the patient. As I told you, the onset of action is within the 2.5 minutes. So that is important for us to understand. Once we give the insulin, it's going to act within less than 5 minutes, and that would really help our clinical practice. So that is how this PK/PD property sort of translate to my clinical practice. Do we have evidence for this? We have robust evidence for the faster insulin aspart, which goes by the study called onset program. It's onset 2 or onset 1. We have in type 1 patients, you have patients with insulin pump, you know, different basal bolus regimen comparing with different conventional insulin and insulin degludec. I will not have time to walk you through all the onset programs, which can be a talk by itself, but I'm just going to point out the onset 9, especially done with patients with diabetes, type 2 diabetes, my apologies. Here the faster aspart is compared with the regular aspart for a duration of about 16 weeks. And all these patients were on degludec for basal insulin. So they were on degludec, the fasting sugars were fixed, and then the bolus insulin, prandial insulin was started either with aspart or faster aspart. So as I told you, if you're looking at the efficacy, there is no difference. I mean, that is true not just with faster acting postprandial bolus insulin, that is true with even basal insulin or with the split mix insulin, whatever insulin regimen that we use. But what came out here is not going to talk about the efficacy, we are going to talk about the risk of hypoglycemia. So if you split it out in a better diagram here, if you remember the PK properties, if you remember the 12 minutes dissociation or the insulin, what do you call it? The time for the insulin to leave the body, what we see here is between 2 to 4 hours and between 3 to 4 hours, there is a lower risk of hypoglycemia, and that favors the faster acting aspart when compared to the regular aspart. So you have insulin that's super fast, super efficacious, gives you greater flexibility for you and your patient, and it also reduces the risk of hypoglycemia, right? So to put together all, so we have a re-engineered insulin aspart formulation that is faster, and it increases that because of the excipients that are added. The difference in the glucose lowering effect between the faster aspart and insulin aspart represents comparable improvement, right? So as far as I told you, the efficacy is the same, but you're using it basically in your type 1 patients. I use it a lot in type 1 and pregnancy, where you have a lower risk of hypoglycemia. as I showed you in the Onset 9 program. So what are the clinical pearls, or how do you take this into your practice? Well, you can use it for any of your patients if you have a postprandial blood glucose optimization. In any bolus situation that you want to use, yeah, you can use this. Efficacy is the same. I reiterate the point, the efficacy is the same. Flexibility is the best, with the edge over the hypoglycemia. Pregnancy, type 1 patients, it's approved for patients with insulin pump, again showing better outcomes. LADA patients, again, there are PK/PD properties on elderly, hepatic, renal, Asian, which includes the Japanese data, which shows that it works pretty much same in all these scenarios, where you really probably need to adjust the dose, but there is no difference as far as the kinetic or the dynamics of the insulin. And the other favorite area where we have used, especially in the COVID situation right now, is corticosteroid-induced diabetes, where almost 90% of our patients were on steroids, and we had very tough time getting the postprandial glucose under control or the premeal under control. And that is one scenario where I would say see a great use of the fast-acting insulin aspart, and also insulin inpatient hospitalization, which I will briefly talk to you for the next 2 to 3 minutes. So moving on to the next part of my agenda, where how can I use this for my IP patients, in patients to prevent a good glycemic control as an inpatient hospitalization. We all know this, the complication of diabetes is there, and higher the diabetes at presentation or new onset diabetes at presentation, the worse the outcome. And we've seen this again in COVID situation, with majority of the patients presenting to us with new onset diabetes or DK or hyperosmolar, HH. Okay, so we have seen this. So it worsens the outcome. This is from the Indian scenario. And also we know that the mortality increases if you have a patient who present to you with higher blood glucose or remain hyperglycemic in the hospital. So these are the different glycemic targets depending on what your practice is. So we try to keep it between 140 to 180, going with the ASADA guidelines of less than 140, random blood glucose of less than 180 milligram per deciliter. And we all know sliding scale insulin can be used for a short duration of time, but it is definitely not something that you're going to use it for a long run, because it does give you this roller coaster pattern, and you cannot target the insulin dose for the carbohydrates. So what is ideal in an inpatient setting is a basal insulin, bolus insulin, and a correction insulin. So we have a correction scale, and the next day when we round, we see the total correctional insulin that the patient is required and add 50-50 to basal and bolus. And that is what we've been doing with basal bolus protocol in our hospital setting. And most of the professional bodies also prefer basal bolus regimen in inpatient setting. So again, this is sort of summarized saying that the sole state of insulin sliding scale is not recommended. Basal plus bolus correction insulin regimen with the nutritional dose, with the mealtime correctional dose is what is required. And these are the available insulin that are approved or recommended for inpatient hospitalization. Again, to sort of reiterate the same point and recap whatever we have gone through, the onset is 5 minutes. We'll just focus only on the faster acting aspart, which is a FIAS. It has 5 minutes earlier to aspart, and it peaks about 11 minutes earlier to aspart, and it has a 10 minutes smaller late glucose lowering effect compared to aspart. So it is something that would really fit into our hospital practice. I'll tell you why. So we know both hyper and hypo has been associated with adverse outcomes, including cardiovascular disease and death. And from analog insulin, specifically any analogs, we know it has a better glycemic control, lower hospital mortality, shorter length of stay, and of course lower cost. And this is what is shown in this cartoon here, the slide deck here. So the thing that we need to keep in mind is if we use a regular insulin, it has to be given 30 to 45 minutes beforehand. So the one that we are commonly using, we still will continue to use the aspart, glulysin, and Lispro, the analog insulin, can be given 0 to 15 minutes before the start of the meal. But now we have a faster aspart, which can be given before, during, or 20 minutes after the meal without compromising the A1C control and reducing the hypoglycemia risk. So it is very, very effective, and this is what was shown in this onset 1 trial in the inpatient setting. So where they concluded that a faster aspart given 20 minutes post-meal, right, which would work in a hospital setting, provides similar HbA1c control as aspart given pre-meal. So you have the flexibility of giving it after the patient finishes the meal. Why would that help us? Because of the flexibility. A lot of patients in the hospital setting have a poor intake. In the inpatient setting, they could be having vomiting, or they could have kept NPO and they would break the NPO without telling the physicians. And a lot of times waiting for orders. Sometimes patients get really frustrated if you're giving orders over phone and the patient is sitting in front of the food and there is no insulin, right? So the waiting for insulin can actually delay the insulin. Finding a DMO to get the orders could be very difficult, right? So all these things could delay the insulin, and the patients could not eat at the right time, and it could create a lot of frustration and friction between the patient and the nurses. And because of this, what will happen is there will be a mealtime skipping of insulin, and the next meal, if you check the pre-meal sugars, the sugars will be very high, right? So this is one reason why this would work well. The patient is eating and okay, fine. You just call the physician and get the insulin orders. You can calculate the insulin for the food they have eaten, right? The carbo, if you can do the insulin to carb ratio, you can do the carbohydrate, calculate the insulin dose, and then you can give it 20 minutes, within 20 minutes after the patient eats. So, and that is what my fourth point is, lower risk of hypoglycemia. We saw that. Again, if you have a renal, hepatic, elderly patients, pediatric patients, all these practical settings will fit into the outpatient setting as well. But I'm just sort of trying to put it into perspective so that we'll at least have some take-home message at the end of my talk. And patients with cognitive impairment, they really don't know how they're going to eat or whether they're going to eat or not eat. It'll be very helpful for them, not just in the inpatient setting, but also in the outpatient setting. So to summarize my talk, so the faster and effective insulin, the faster aspart provides early glucose lowering effects for better postprandial blood glucose levels for a cost that is about 50 rupees cheaper. Insulin that is offering so much is not expensive, right? So, and it is available as vial, it's available as cartridge, it's available as a flex pen, right? It's like how you use the aspart is how you're going to use the faster acting aspart, but for a cost that is effective for our patients. And it is approved in pregnancy, pediatric, renal, hepatic impairment, lesser rates of severe hypoglycemia. You have the providers as the flexibility, patients as the flexibility of taking it as they want. As I told you, it's easy to use. And how do you start the unit is how you start any pre-meal insulin. You can start 4 to 6 units, ask your patients to SMBG, the self-monitor the glucose, and you sort of titrate it depending on the postprandial blood glucose that you're targeting for the patient. But if you're sort of switching the patients from one mealtime insulin to another, it is just a unit to unit conversion, right? And as I told you, the greater advantage for this is not for the efficacy, but for the flexibility that it offers in terms it can be given after a meal for up to 50 minutes or with a meal or just 5 minutes before the meal as we give insulin aspart. So with this, I finish and I thank the organizers for giving me this wonderful opportunity. Thank you, sir. Thanks, Dr. Giri. Thank you so much.
Dr. Shruti.
Yes, sir.
Wonderfully presented. Very happy.
Thank you,
and
sir.
you have completed in time also. Very, very happy.
Thank you, sir.
And during the presentation, you said and you emphasized the clinical importance of 1 hour PPG control. This is very, very useful for the practitioners as well as for the consultant. You also said about the insulin aspart, which is very, very faster acting, and beautifully said the clinical practice and pearls where the aspart can be very much useful. And you also touched upon the hyperglycemic management in the non-ICU setup and how this aspart is helpful. Very good. Wonderfully presented. Now, Dr. Vijay Kumar, any questions from our audience input? You can go ahead. Vijay, over to you. Any questions, input?
Sir, you're muted, sir.
Sir, there's no questions from chat box.
Okay.
There are no questions from chat box, sir.
Okay. Vijay, what about your comments from these speakers?
Yeah, definitely, sir. I think we need to take care of this, especially for the Indian perspective. Indian perspective. I think we need 1 minute, sir. From the Indian perspective, with all the high carbohydrate diet, where I think Dr. Mohan also has indicated that in the recent paper that he has presented, he said that because of the high carbohydrate diet, I think from the starting of the meal, usually we say that 2 hours is the control of diabetes. Now he says that no, it is 1.5 hours. The Indian population, because of the diet that we take, Indian population are going to get this the postprandial spike at 1 to 1.5 hours. So at this situation, I think it is more relevant for fast-acting part. As Dr. Shruti has very, very important that we need to be that insulins are concerned, so he said that I think every innovation in the insulin that we are getting is basically to make the patient more comfortable, right? For example, take a basal insulin, it is very effective with low hypoglycemia, especially nocturnal. For Indian perspective, where the postprandial spikes are very, very important, and we know that postprandial hyperglycemia is an independent risk factor for cardiovascular disease. Very essential for us to reduce the postprandial blood glucose as well. So at this situation, if you can see that the usage of these novel and very user-friendly, patient-friendly insulins, we have to do that. See, always a cost may be a factor for most of the people. Those people who can afford, I think it's better to go for such medication so that we get the postprandial blood glucose so low without any hypoglycemia. As Dr. Shruti has already said that the hypoglycemic episode is very low. See, intermeal hypoglycemia is a big issue that we are facing. With the advent of newer analogs, I think we are in a better position to ensure that the quality of life, because most of the practitioners doesn't look into quality of life. All the innovations, all the improvements in the insulin happens because to improve the quality of life. And I think whenever there is a chance, we need to use these molecules so that we can improve the quality of life. That's what I feel. Not a barrier. I think we encourage people to use these molecules, faster aspart, and even that second generation basal insulins. These are all going to be very effective. No doubt why insulin has got already 3 Nobel Prizes. 3 Nobel Prizes, and more to come in future. No other molecule has got so many Nobel Prizes. Insulin. You know the reason? So the innovations that we can bring into an insulin molecule is something extraordinary that is happening. That is number one. Number two is that whether you can able to control diabetes with oral drugs or not. Insulin, definitely we can assure that we can reduce the blood glucose levels. And with all the new advents, new generation insulins, without any hypoglycemia, and secondarily without any weight gain, because there is one concept, what is snacking. The fear of hypoglycemia will make people to eat more. That is a high calorie dense foods that they take and they put on weight. It is very difficult to blame insulin alone for putting on weight as well. So these are the two things we expect: weight gain and hypoglycemia. I think both the things can be easily managed by newly innovative, new generations.
Dr. Vijay Kumar? Hello? Dr. Vijay Kumar?
Yes.
Can I take 2-3 minutes?
Yes, sir. Yes, sir.
Am I audible to everyone?
Yes, sir.
Okay. I direct like this. 50 years ago, Dr. Mohan's father, Professor Viswanathan, was practicing in Rayapuram. In those days, usually we confirm diabetes by doing a glucose tolerance test 5 times. We will have a fasting, after glucose half an hour, 1 hour, 1.5 hours, 2 hours, if necessary 2.5 hours also. He had a roaring and excellent practice, Professor Viswanathan. When my classmate Dr. Mohan was analyzing the past records, patients of Dr. Viswanathan, we come to know in those who had 5 times GTT, the 1 hour value was high. Those patients were followed for 40 years and they have become a diabetic. And their offsprings also become diabetic. Now we say 1 hour PPG is important. In those days, Dr. Mohan's father, Viswanathan, has beautifully made a comment. If 1 hour PPG is high, he will warn the patient. I'm very proud. I was his student. I think Dr. Shanmugam will also accept in those days Professor Viswanathan's. Number one, about the 1 hour PPG. Number two, this aspart and aspart IDAT. A patient admitted in ICU or non-ICU, you will not give OHS at any cost. Whether by sliding scale or by IV insulin, whatever it is, you always use short-acting insulin. Instead of using regular insulin, you use the fast-acting aspart. You will very well control the infection or the critical care events. When the patient are discharged, you know the calculated dose of short-acting insulin. Then you give IDAC asp. Finally, the cost is not very much because when you don't control, if the patient gets a cardiac infarct or renal failure, subsequently what he has to spend for in multiple lakhs by giving few hundreds for IDAC asp is worthwhile. With these few comments, I will go back to Professor Vijay to you. If any comments from Dr. MSV, go ahead.
Yes,
That is, if we come across post-challenge glucose levels between 140 and 200, such patients 1 hour value more than 145, that patient carry very high risk for developing type 2 diabetes in the near future, number one. And those patients, when followed up for a few years, the cardiovascular events were very high. So in that way, 1 hour level in a patients with IGT, it provides the risk for developing type 2 diabetes in future as well as cardiovascular events in the long run.
You are correct, Shanuvel. Dr. Shruti, anything you want to add, please?
No, sir. It was a good learning experience.
Vijay Kumar, back to you.
Sir.
Yes. Yes, Dr. Ramanan, go ahead.
Yes, as Shanmugam sir,
Yes,
said,
sir.
the importance of 1 hour postprandial when we see clinically, we can't, especially in glucose tolerance test, we can't start them even we term as sometimes we may emphasize the patient to follow a strict diet pattern.
Yes, sir, definitely.
That is where we can at least control them to becoming we can postpone the the scenario of becoming them diabetic.
That's modification of diet or meal plan is mandatory in order to minimize the 1 hour postprandial glycemic excursion. So that is from fine sugar, and that is introduce more of starchy, that is complex polysaccharide. So modification of meal plan is first important. Second thing is improvement of physical activity.
And most of our diabetic patients started taking now that millets instead of rice. That also reduces the 1 hour postprandial.
Yes. That is incorporate pulses along with the cereals. So instead of taking too much of cereals, incorporate pulses along with the cereals, along with the vegetables, starchy vegetables, along with the fruits, along with the nuts. Definitely, this will minimize the postprandial glycemic excursion nicely.
Sir, the problem what we are facing in India is that very simple, sir. It's very difficult to change the dietary habits of our people. See, in the START study said that both diabetics and non-diabetics, all over the country, the Shashank Joshi has done one study about 3-4 years ago, where he has said that about 65% of diabetics, the calorie consumption from the carbohydrate, 65% in a diabetic and 67% in a non-diabetic. There is absolutely no difference between a diabetic and a non-diabetic. But we say that 50% of the energy intake should be from carbohydrate. So we have been imbibed for the generations, over the centuries. So I think we are in a position where we need to modulate our therapies to our traditionally eating habits. How can you say that, sir? Sir, for example, we are from Chennai. Can we avoid idli, dosa, pongal, upma from everyday breakfast? Let me know, sir. We have to be practical.
No, it's impossible.
And that's number one. Number two, this patient is hungry. The plate of food is ready for him. But you take a regular insulin and wait for 45 minutes for you to eat that. Imagine yourself in that position. It's a torture. It's absolute torture. It reduces the quality of life. It reduces the confidence among the people. So I think these innovations in insulin are going to be very helpful. That is one thing. See, apart from what Dr. Vishwanathan has told, in fact, I was involved also along with him about 40 years ago in this particular study, what you are mentioning. There are so many studies which state that, that Paris police study and so many other studies which have clearly said that even in normal people, when they did a GTT, in fact, they have done 50 grams GTT in most of these patients, most of the general population. Those who had a 1 hour high postprandial blood glucose, when they followed it for 25 to 30 years, those people, even in a non-diabetic population, which has got the highest quartile of 1 hour blood glucose, they had more cardiovascular disease, leave alone diabetes, cardiovascular disease. No doubt why San Antonio study has clearly said that postprandial hyperglycemia is an independent risk factor for cardiovascular disease. I think we need to look into that, where we take so much of carbohydrate, which we cannot change, sir. See, if you ask me, I cannot change. See, after what is it we need in life? Things, good food and good sleep. If we're able to change, okay. If we're unable to change, we your strategies of therapy, suit the diet that you take, and then we give you the better quality of life for the patient. That's what I feel.
Sir, can I, sir?
Yeah.
Sir, this 1.5 hours, this one postprandial evolution has been clearly defined in landmark study, recently published landmark studies, sir. Have you heard about that, sir? Because they have shown the 1.5 hours postprandial escalation or surge will show the significant independent factor for the vascular inflammation.
Yes,
that
sir.
has been published in recently published landmark study.
Yes, sir.
By
Landmark
men
study. Yes, sir.
Yes, sir.
Yes, sir. Yes, sir. It is ongoing. Yes, landmark study is ongoing. Yes.
Still is going.
Yes, we are part of it.
Yes, we are doing it. Dr. Vijay Kumar, shall we close it?
Yes, sir. I think so. I think so.
You have.
Sir, it is. Shall I say that before you close as a chairperson, I would like to say thanks, Dr. Shanmugavelu, Dr. Giri, and also those people who stayed back like Dr. Ramanan, Dr. Kannan, and so.
Thank you for the opportunity, sir.
I'm very sure all the discussions that we had. The 3D means is diabetes, dialogue, and discussion. What is there's so much discussion which is gone. So because of the discussion, we are late by 15 minutes. Please pardon me for what has happened. And definitely, please, tomorrow, we're going to 10 o'clock and we'll end by 4:15. Definitely, yes. So please stay tuned. Definitely, as faculty members, as responsible faculty members, Dr. Shruti, Dr. Shanmugavelu, Dr. Ramanan, Dr. Kannan, Dr. Giri sir, all of you, please join us for tomorrow and join us for the discussions and dialogues. Dialogues and discussions. You know why? These inputs that you can give with all your lifetime experiences is going to benefit our delegates who are there to listen to us definitely. So that they can take care of the carry home messages back there. My is please just thank you.
Thank you, Surji Madam, for the excellent talk. Thank you.
Very happy. I'm very happy to everyone. Only thing is we are missing the hospitality of Dr. Vijay Kumar. Good input here. But to the gastric
no oral input. No oral input.
No, to the gastric mucosa, we are missing Vijay Kumar. Anyhow, we'll compensate next year.
So that tongue receptors need to be saturated.
Yes. Thank you.
Sure.
Thank you
Thank
so
you.
much.
Everyone, thank you.
No,
Thank
sir.
you, sir. Thank you. Good night.
In fact, last year we were expecting the delegates. We
Okay. Right. Bye bye. Good night.
Bye. Good night, sir. Good night. Bye.